That was the reel of 4 and the reel of 8.
Sorry, y'all. Okay, we're gonna fix that a little bit. Hello. Again, we are the Lion Sisters. I'm Talia.
I'm Zara.
And I'm Serena.
Yeah, so we're Swabby Cree Métis, but we live in Ottawa, so we're Métis, citizens of the Métis Nation of Ontario, and we're going to perform a couple of dances.
Bonjour, je m'appelle Zara, mes sœurs sont Talia et Sarina Lyon, et nous sommes les sœurs Lyon, danseuses de la gigue Métis. Nous sommes fiers de notre origine Cree, du terre natale du peuple Métis du Manitoba, de la Saskatchewan, et comme nous habitons en Ottawa, nous sommes devenus citoyens de la nation Métis de l'Ontario. Our first dance is called the Maple Sugar, and we all have a chance to showcase some of our fanciest steps. Notre première danse s'appelle le sucre d'érable.
All right, that was great. Lion Sisters. I forgot to introduce myself. My name is Alicia Bloor. Good morning. Happy second day of this conference. I'm going to play a good old tune I learned from an elder from Bacon Ridge, Ebb and Flow, Manitoba. His name is Teddy Boy Hoole, and the tune's called Bacon Ridge Jig, and it was a little road allowance community in Manitoba. All right. Thanks. I'll do Caribou Reel next, and we'll have the Lion Sisters come back.
Our last dance is going to be called the Orange Blossom Special, and this one is modeled after a train called the Orange Blossom, and it'll start off really slow and speed up towards the end. Notre prochaine danse s'appelle the Orange Blossom Special.
So once again, we want to thank you for inviting us here today. If you'd like to know more about us, we have a website, Métis Jiggers, or Instagram, YouTube, and Facebook. Merci de nous avoir rejoints aujourd'hui aussi. Et un gros merci de nous avoir accueillis. Si vous voulez savoir plus sur nous, nous avons un site web, un Facebook, YouTube et Instagram. Merci. Now, Alicia is going to come up and do a few more songs for you.
All right, that was great. Woo! Happy Thursday. All right, I'm going to play a couple more tunes, and then we'll start our second day. All right, I'm going to play another set of tunes from the elder Teddy Boy Hoole from Bacon Ridge, Manitoba. And this is a medley or a Three Sisters set. Has 3 tunes, a jig, a reel, and a breakdown. The jig's Swinging the One You Love. The breakdown is Walter Flatt's breakdown, which was his stepfather. And the reel is a reel that's called Smothered in Smoke. And the reference is how our people would dance in the prairies and pound on the earth. And they would pound so hard on the earth that after the day's event, they would literally be covered in soot. And that's what that comes from, smothered in smoke. All right, I'm going to finish off with a waltz. I was always told to finish with a waltz. So this morning I'll finish with a waltz, and maybe the last set I'll finish with a waltz as well. Thank you, Marcy, everyone. I'll see you at the break.
Bon matin, good morning, everyone. How are we doing this morning? Woo! Yes. Okay, I like the energy feels rejuvenated. I was saying to my friends at the Oktapamsuak Métis government that I don't know if it's all the coffee I've consumed, but it feels electrified in the room, right? It just feels like a good energy is about us. I think we're gonna have an amazing day today. And for anyone who is joining us today and who wasn't here yesterday, welcome to the 2024 National Métis Health Policy Forum. A big merci to our jiggers this morning, the Lion Sisters and our fiddler, Alicia Bloor. I want to share a teaching with you all today, this morning, that I really want us to carry throughout the day. So Alicia, quite a while ago, said to me, listen, if you're not fiddling, if you're not jigging, and if you're not playing the spoons, your job is to be a hootin' and a hollerin'. And so, you know, she's our main fiddler for the day, and it's a demonstration of support and engagement for our musicians to be a hootin' and a hollerin'. Whether you're Métis, friend of the nation or not, we're gonna make it a party in here today. So that's what I want us to carry, the hootin' and the hollerin' energy to support our fiddlers and just have a general good old time, right? This is like a ballroom party, not a kitchen party, a ballroom party. There's spoons there at the buffet table. You grab them, we're gonna make it a great time, all right? Amazing. So if you're wondering who I am, I'm Tara. My pronouns are she, her. I'm a citizen of the Métis Nation of Ontario. My ancestral communities are from Saint Laurent, Manitoba, and the Qu'Appelle Valley area in Saskatchewan. I'm a registered psychotherapist, and I founded a private clinical and consulting practice called the Weaving Wellness Center. And we have the great privilege of working with First Nations, Métis, and Inuit on their journeys of healing and wellness. And I made a drastic error yesterday in thanking absolutely everyone except my own team who's here, supporting me and keeping me on track and doing all of the amazing work behind the scenes. So I want to acknowledge Sophie McGrath, who just came from my hotel room because I forgot to take magnesium this morning. So they grabbed it for me. So Sophie and Sandra Gosling and Kimberly Jordan, our amazing, amazing team from Weaving Wellness Center who is here. They're gonna be presenting. We have a booth out in the front. Please come by, visit us. We've got nice seed paper for the harvest, or not the harvest season, the planting season that will be upon us soon. So just a thank you to you all for being here and helping me get through these 3 days. Amazing. So what I'd like us to do just before we welcome up our elder for our opening, just as we did yesterday, to begin our event today by recognizing the traditional and unceded, unsurrendered territory of the Algonquin Anishinaabe people whose lands we're gathering on today, which is also the chosen home of the Ottawa Regional Métis Council of the Métis Nation of Ontario. And at this point, I'd like to welcome Elder Vida Westerlake up to offer our opening prayer.
Thanks, Tara. My mother was jigging up until she was about 99, so nobody in this room has an excuse not to. Thank you for including me in your meeting. My name is Vida Westlake. I'm a Cree Métis with ancestors in Northern Ontario and primarily Manitoba, Saskatchewan, but some of us traveled into Alberta and into the Northwest Territories. I've been living and working in Ontario on unceded, unsurrendered Algonquin and Anishinaabe lands for many, many years. And for many, many years, I've been working on Indigenous files, both inside and outside government. Right now, I'm a member of the Ottawa Regional Métis Council. I hope you had a good day yesterday. The topics you covered yesterday and will be covering today and tomorrow are very important. I've been thinking about the challenges ahead, including the challenges to human health we will be facing with the challenges of the climate crisis and impacts on the natural environment in which we as Indigenous people so much depend. I've also been thinking about some of the things I learned over the years. Years ago, I was doing work on a spectrum of health-related issues, including suicide and intrafamilial sexual abuse. What I learned was how alone people sometimes feel, how they assume responsibility for the bad things that happen to them, and how much they need to hear that they are not alone in their pain and that they are not wholly responsible for the experiences they are having. Many of the people in our Métis communities have felt invisible. And when people have been devalued by others, they tend to devalue themselves. We need for our people to be healthy, to be well cared for, and to feel well cared for. People working in healthcare fields know this. They know how important it is to treat all people in their care with respect in a way that affirms their human dignity. I cannot say how much I appreciate the work you do. Turning to a prayer to the Creator, we thank you, Creator, for all, first of all, for our people and their survival. We thank you for our healthcare professionals and the good work they do every day. We thank you for our medicines and our knowledge, and we thank you for the natural world in which we live and on which we depend so much. We acknowledge and express gratitude for the many gifts that you have given us. We acknowledge and express gratitude for all our relations, the flying creatures, the birds and the insects, the living beings of the waters, those that walk on the earth and those that live beneath the earth. We thank you for the water and the air. We thank you for all of the trees and the plants that sustain us emotionally, in body and in spirit. And we thank you for the grandfather rocks and the teachings they bring. We thank you for the sun and the wind, the seasons, the days we have been given, nighttime, the moon and the stars. We thank you that you have given us a place in creation, an important work to do. As we turn to the work of this day, we ask that we be able to work together with good hearts, clear minds, and strong spirits. We ask that our circle be strong, that we listen to one another carefully and kindly. We ask that we do good work, knowing how much we all depend on healthy people and a healthy world. Miigwech, merci.
You got
I think
my-
that's
you
stealing
got
your
me
stuff.
speaking points. I'm gonna be lost for the day.
There you go.
Merci, Vida. Merci, Elder Vida, for that beautiful opening. And I just want to express, my thanks to our elders, the elders that we have here and that who we've been able to hear from. Our elders bring that perspective of being in community. They acknowledge and they create space intentionally for our community members who are not here. who are not in this space. It's a privilege to be in this space. It's a privilege to be able to do the work that we do, whether you work in government or other industry area, whether you're a healthcare practitioner. You know, our people are not reflected. The folks living on our streets, the folks who are in the jail system, the folks who are institutionalized right now. And so it's so important, you know, our elders remind us of who we're doing this work for, why we're doing it, and that these people, they are part of us, they're with us. We cannot forget them, that this is really what, you know, our work is about. So Marcy Elder for that beautiful opening and for contextualizing us within that beautiful picture of creation as well and all of our relations. So yesterday was a terrific day. I gotta look at the time so I don't ramble too much here. You know, we discussed some awesome work across the Métis Nation. We learned about a number of amazing programs, projects, partnerships across the homeland, such as MNBC's Tasanti Mamawepawak and Naomi's Principle, MNO's Mental Health and Addiction and Cancer Care programs, MNA's Life Promotion and Opioid Wraparound programs, and MNS's Cultural Revitalization work around preventing cancer, and so many more. These, I'm just kind of highlighting a couple of things. It was such an amazing day of so many different you know, topics and presentations. We had an amazing spoken word performance by Reagan Bartel, and we were surrounded by the musical talents and gifts of our fiddlers, Alex Kusterok and Alicia Bloor, and our jiggers, the Lion Sisters, and Brad LaFortune. We received uplifting words of hope and vision and inspiration from our Métis Nation presidents and leadership, as well as our knowledge keepers, Parm Burgi and Calvin Reset. And day 2 is shaping up to be just as phenomenal, if not better. I don't know if that's possible. So if you weren't here yesterday, hold on to your sashes. We're coming in hot like fresh fry bread and jam this morning. Hey? Whoever yupped me out, I appreciate. Yes, Becca right over there, loving the fry bread. So just a few housekeeping notes. So again, washrooms, I feel like I'm a flight attendant. Out that door to the left and the right. And then there's water at the tables today, which is amazing. Thank you, Weston staff, for helping us and feeding us and clearing and providing food. You're doing amazing. There are also water bottle filling stations out in the hallway. I have yet to see them, but they exist. So if you have a huge water bottle, don't worry about finessing with those things over there. Head out to the main hallway. Also on each table, there should be a little tinted card that has a QR code. There it is. It has a QR code. So if you're fancy and know how to use these things, which we hope you do, and if you don't, I'm sure we can make the survey accessible in other ways. If you'd like to complete the survey, I know that the Métis National Council staff and everyone from the governing members would really love to receive feedback that you have on this year's Health Forum, whether you are attending today, yesterday, you can fill it out at any point in time. Just a reminder that sessions are being live streamed from the ballroom, and the link to access the live stream can be found on the Métis National Council's homepage. Sessions in the main ballroom are also being recorded, and they'll be made available to share following the Health Forum. A detailed schedule of today's events can be found in this beautiful document, starting on page, not on page 6, that's tomorrow, starting on page 4. And I want to take a moment also to acknowledge our amazing sponsors, the Canadian Institute for Health Information, CIHI for short, who has sponsored our wellness room, which is located in room 211. Again, out and to the right immediately. There's a sash hanging on the door this morning. The Canadian Agency for Drugs and Technologies in Health, who is also sponsoring one of our concurrent sessions this afternoon, and we'll get to hear from them a little bit as well. The Canadian Medical Association, who is sponsoring lunch. I don't know any midshifts who don't like ample amounts of food and beverage. So we're excited that they have put on lunch for us. And last but not least, our friends at Healthcare Excellence Canada, who are sponsoring our special presentation and appreciation brunch tomorrow morning at 10 a.m. So definitely stick around, because who doesn't love food? So a big round of applause for our sponsors who are supporting the nation, fostering wellness, and feeding the nation as well. So merci everyone for sponsoring and supporting us through this beautiful forum. So having said that, I'd now like to introduce our keynote speakers for today, Stephen Thompson, Director of Health Governance, Métis Nation, British Columbia, and Vishal Jain, Director of Cultural Safety and Humility, Health Standards Organization, who will be speaking about a new cultural safety and humility standard, working together to improve Indigenous healthcare in British Columbia. Welcome.
All right, good morning, everyone. Thanks for joining us today. Really excited to have an opportunity to talk about some of the exciting work we're doing in BC and in partnership with our colleagues at Health Standards Organization. So to start us off, I just want to once again acknowledge the traditional and unceded territories on which we are gathered today, recognizing that this is the traditional, ancestral, and unceded home of the Anishinaabe and Algonquin peoples who have been here since time immemorial, and also recognizing that this is the chosen home of the Ottawa Regional District Council. I also want to take a moment to thank the amazing cultural performers we had this morning and our wonderful elder who opened us up in such a good way and made sure that we're grounded in our culture and able to be here in the ways we need to be here today. My name is Stephen Thompson. I am a proud Métis citizen, and I trace my heritage to the Pope family and to scrip handed out in Medicine Hat in 1901. And I have the privilege of being the Director of Health Governance at Métis Nation, British Columbia. And I'm honored to be here today visiting from that territory, and I'm grateful to live, work, and play on the traditional and unceded territories of the Kakite Nation, which is also the chosen home of the North Fraser Métis Association, where I call home. Vishal?
Yeah, thanks, Stephen. Hi, everybody. My name is Vishal Jain. As it's noted on the slide there, I'm a second-generation Indo-Canadian settler. My parents immigrated from India here in the late 70s and early 80s. Not dissimilar to my colleague Stephen, who's my neighbor, coincidentally. I also am here from BC on the traditional, ancestral, and unceded territory of Kakite First Nation, which is also the chosen home of the North Fraser Métis Association. Colonially, it's known as New Westminster, British Columbia. I also just want to really acknowledge and send my deep gratitude and appreciation for being welcomed here to present on this cultural safety and humility standard and some of the work that we're hoping to do nationally. It's a real honor and privilege, so thank you for that. I am the Director for Cultural Safety and Humility at Health Standards Organization, and away we go. In terms of a bit of an outline for today's keynote, we'll be doing a bit more context setting and providing a bit more background on this British Columbia Cultural Safety and Humility Standards, the first of its kind, not just in BC or Canada, but the first of its kind anywhere in the world. So we're quite proud of coming here and being able to talk a little bit about it. We'll do an overview of the standard itself, and then be discussing how a distinctions-based approach was critical and vital to the creation and application of the standard. And then we'll conclude with a bit of a scoping of the National Cultural Safety and Humility Standard, the work that we've been doing from coast to coast to coast with our partners at the Canadian Indigenous Nurses Association to understand if a tool like this, if an opportunity like this would be valuable to Indigenous-led healthcare reform across the country. And then we'll close it out with a bit of a Q&A. We're happy to answer any questions that we possibly can about this standard.
So before we dive into the content of the standard and some of the work we're doing around it, I think it's really important to set the context and really the background for why we feel this is necessary and why it's become a path forward. So I think really much of this began in 2015 with the release of the TRC Calls to Action, which really laid out the foundation for a lot of the anti-Indigenous racism work that has been happening in Canada over the last decade. And really started to sort of set the stage for an environment where a standard might be possible. Sorry. Where something like a standard might be a possibility, and it might be a way forward for us to do this work. It really brought into the foreground the experiences of racism and discrimination that all First Nations, Métis, and Inuit across Canada have been experiencing. And of course, it's been built upon time and again by a series of other documents, including the United Nations Declaration on the Rights of Indigenous Peoples Act, and then in BC, a few specific documents that I'll touch on shortly. But it's really that sort of that sort of groundwork, that level setting across Canada, that made us realize that this might be a tool that could be pursued. So in 2020, unfortunately, we had a number of incredibly serious and incredibly powerful allegations leveled against the healthcare system in British Columbia, which resulted in the release of the In Plain Sight document. The allegations that started this spoke to extreme harms in our emergency departments in BC, and action needed to be taken to really and meaningfully address the work. And so while work on the standard had already begun, it had been started in the years prior to the release of the In Plain Sight recommendation, In Plain Sight report. It really made sure that this needed to happen, and it actually called for the adoption of an accreditation standard as recommendation 8 of In Plain Sight. And so it was in that sort of environment that we knew that this is something that could happen and could move the work forward in a really meaningful way, in a powerful way. And of course, there was so many voices, so many, hundreds of thousands of Indigenous people that spoke up over this period of time, and over 9,000 voices that contributed directly to the In Plain Sight report, that made this a clear necessity for us.
Thanks, Stephen. Some people call those documents the hundreds of thousands of voices and experiences that contributed painstakingly, in many cases, a tipping point. That's not really necessarily how we see it. It wasn't a tipping point, but it was a story being told over generations and generations. We don't necessarily think that this work deserves or requires a tipping point. What it deserves and requires is sustained commitment to action. And how are we translating and how are we honoring the voices that have, like I said, painstakingly and profoundly told their stories in great detail, and how do we make sure that we act upon that, we act upon those voices. And so that kind of brings me to the question that I probably get the most as being a representative of Health Standards Organization, which is, what is a standard? When we talk about standards, what exactly are we talking about? So a standard, or an HSO standard in this case, is a published document that includes a set of evidence-based criteria and guidelines to support and promote quality and safety. These standards are typically developed over a 24-month period, so it's a 2-year process to develop one of these standards. It's quite lengthy, and it does require sustained commitment from those who are developing the standard to actually create it. In just a few minutes, I'll be talking about how we created the HSO BC Cultural Safety and Humility Standard, and one thing that you'll observe right away is that it did not take 24 months. It took about 4 years from ideation to publication. 4 years and one global pandemic, but because of the brilliant work of a dedicated technical committee that had balanced representation of experts in multiple categories, those with lived experience, policymakers and healthcare workers, those who are using this standard administratively in clinical teams, and those from academia and foundations all came together from their respective points of knowledge and experience and entered into a space of really deep reflection in order to create this standard and ultimately to support better health and wellness outcomes for First Nations, Inuit, and Métis individuals, families, and communities in BC. So going to a little bit more depth here in terms of developing the actual standard itself, Health Standards Organization had partnered with the First Nations Health Authority, the first province-wide health authority of its kind anywhere in Canada, to develop the BC Cultural Safety and Humility Standard. The standard itself was developed and led by a 16-person Indigenous-led technical committee over a 3-year period. Those are their pictures at the bottom here. One of the things that I'm really really important to, I think, Stephen and I, is that while we have the incredible privilege of being the ones that get to be up on this stage and talk about this story, it's really because of the brilliant minds and really the 16 members of the technical committee, but the thousands of others who really contributed to this work. We just get to be the ones to come up here and celebrate that work. So I just really want to take a moment and acknowledge this technical committee and how much they gave to this process over years of their lives. The standard itself is intended to blend Indigenous knowledge and experiences with the HSO standards development process. When this standard was released for kind of public review and feedback, Health Standards Organization received over 1,100 comments during the public review process. One thing I'll note about that number is that it is a pretty significant number in that while HSO has over 100 standards and have published over 100 standards, 1,100 comments was the highest number of comments that HSO had ever received for any standard, and this was a standard for British Columbia specifically. We received comments from coast to coast to coast, people from all parts of this country wanting to contribute their voices, their thoughts and experiences, their perspectives, their wisdom to enhancing this standard. And that technical committee read, listened, understood, reflected on all those comments and made sure that this is a standard that was representative and reflective of the priorities and objectives of those receiving service in BC, but also included the voices of many others from across the country. One thing that is also important in terms of making sure that this is an actionable project is that the provincial and federal government supported the adoption and use of this standard in the accreditation program in BC and beyond. As Stephen noted, that in the 2020 In Plain Sight report, there's a recommendation for an accreditation standard related to cultural safety and humility. The province of British Columbia did endorse all 24 recommendations coming out of that report, and we are very committed to be working with government parties to ensure that a standard like this that was developed over multiple years and with such care and attention sees its way into BC health systems. So how was the standard developed specifically? This is a bit of a standard development pathway specifically for the BC Cultural Safety and Humility Standard. As I mentioned, this was a journey that began in 2018 and then was eventually published in 2022, 4-year process. And I think what's really notable here, a couple of things is in 2018, when we were identifying opportunities for the standard and reviewing those opportunities, the question was really, how do we take a really transparent but really rigorous standards development process that is audited and is is just really thorough in its development process, that has all these stages and has all these rules and guidelines and practices and procedures and protocols with standards development, and how do we break or bend some of those principles, those pathways, in order to ensure that this is Indigenous-led, and how many rules can we break, how many assumptions can we challenge with standards development processes. And that's what really the early work was, is understanding how far can we bend and break those rules to create a standard that is unlike any other standard that exists in Canada or globally. And so that was a work that had began in 2018, and we're really grateful to have such incredible partners in Métis Nation, British Columbia, and the First Nations Health Authority to help us work through this process till where we are today. From that moment of identifying that opportunity, challenging preconceived assumptions, doing things differently, doing this work differently, over that kind of 4-year process, we went through the development of the 16-person Indigenous Technical Committee. We did a deep study. We achieved consensus making over a 2-year period, November 29 to May 2021. The standard entered a full public review so that everybody can have an opportunity and chance to inform this standard. And then the technical committee approved the standard, voted on the standard, approved the standard for publication, which happened just in time for National Indigenous Peoples Day 2022. So it's been about a year and a half, almost 2 years since the standard was published, and we're very excited to be able to talk a little bit more about the work that's happened since. But before that, next slide. Talking a bit about the purpose of the standard. What's the point of this standard? The standard itself specifies the requirements for governing bodies, organizational leaders, teams, and the workforce, and health authorities and health and social service organizations to provide culturally safe services to First Nations, Métis, and Inuit people and communities, and address Indigenous-specific racism in service delivery in BC. One of the things that I think is really key here is that the standard itself, and I'll go into kind of a few of the sections of the standard in a little bit, but the standard itself works across the continuum of care. So it includes health promotion and disease prevention, access to health and social services, admission, assessment, treatment, discharge, and end-of-life care. This isn't a standard that sets its flag on any particular area of a health organization or health system. It works across the entirety of the continuum of health services. It's a standard that is intended to uphold systemic transformation and change. In terms of the applicability, the standard is intended to be used by governing bodies, organizational leaders, teams, and the workforce in health authorities and health and social service organizations in the province of BC to support the design, development, and implementation of health and social services and care delivery that respects cultural safety and humility principles. In terms of the applicability of this, it was really critical that we had health systems partners who can speak about their experiences working in health and social service organizations on the technical committee to be able to inform the development of the process so that this is not a standard that is aspirational. It's a standard that's pragmatic, it's implementable, it's something that it can actually inform and change or uphold cultural safety and humility principles and practice. So we had multiple individuals from health authorities in the province of British Columbia on the technical committee itself to support the design of the standard. So in terms of the key sections, the standard itself, and there's a picture of it on the right there, is organized into 8 distinct but really interrelated sections. So as you'll note just by the 8 sections that are noted here on the slide, is that it's a huge kind of continuum, thinking through all the ways that health systems deliver services and how many decisions are made and how many practices and beliefs are upheld. So everything from supporting social, public, and reciprocal accountability, establishing inclusive and meaningful partnerships, shared governance, and implementing responsible leadership, all the way through to things like designing and delivering culturally safe services and collecting evidence and conducting research and evaluation. So the technical committee really wanted to ensure that no stone was left unturned when it came to this standard. They wanted to see specific criteria, actionable criteria that affect no one area in a health system, but all areas in the health system. I'll turn it over to Stephen now to go through cultural safety and humility and to discuss a little bit about the distinctions-based approach and how it made its way into the standard.
Yeah. Sorry. So speaking about really the intention of the standard and trying to understand how do we actually mandate something that sets standards for these concepts of cultural safety and cultural humility that really are defined by the people experiencing care themselves. So it's been a massive undertaking to develop those standards, and as Vishal mentioned, it speaks to sort of every aspect and every facet of the healthcare system in that way. Because really the intention is that this standard has to meet such a fundamental level of care that it allows for a system that by default is providing care that is free of racism and discrimination, that has responded to colonial policy and colonial actions that have contributed to poorer health outcomes for First Nations, Métis, and Inuit people. And to do that, it makes sure that there is good language and good supports in place to support a distinctions-based approach, to support a strengths-based approach, to actually measuring and understanding the experiences and the impacts of these events on our people, and then in terms of how it's responding to those experiences and those outcomes. So really taking that sort of outcome-based approach to cultural safety, understanding at a fundamental level that it's not something we can measure directly, and it's something we have to only measure through those knock-on effects, through those the ways that we sort of see it happen throughout the system, and that fundamentally it's our patient voices, our citizens' voices, and the voices of all First Nations, Métis, and Inuit in BC that can define and ascribe when we've actually met the commitment set out in the standard. And so throughout the standard, sort of those fundamental ideas are built in, and some of the specific pieces I'll speak to sort of highlight where and how the system can actually hold itself accountable to this commitment to achieving cultural safety and humility.
Do you mind if I just actually add in there? So one thing that I'll note is in the province of British Columbia, 2015 is a really significant year. It's the year that the Ministry of Health, along with all regional health authorities and the provincial health service authorities, signed a declaration of commitment to embed cultural safety and humility in health service delivery. It has been 9 years since that commitment has been signed, and health authorities have been tasked with doing this really important work led by First Nations, Inuit, and Métis governing bodies, communities, and organizations. And so, you know, what we're hearing back from health systems themselves, but also partners like the First Nations Health Authority, like Métis Nation British Columbia, is that it's time to do an assessment. It's time to see where we are right now. It's time to understand where the strengths lie and where the challenges are, what are the future opportunities 9 years into this process. And it's a big piece of ensuring that we're holding ourselves accountable to the words that have been spoken by governing bodies, by health system leaders 9 years into this process.
So you might have noticed that up until now, this has been pretty heavily focused on the partnership between the First Nations Health Authority and HSO. And a big part of that has been that when the standard was being drafted, MNBC just did not have the capacity to be engaged and to be involved in this work. But what we really see as an opportunity is being engaged and being involved in the implementation of the standard, being involved in the accreditation of the standard, and in terms of how it gets applied across BC. And the way we want to see that happen is through a distinctions-based approach, through a Métis-specific approach to a lot of this work, and making sure that there is clear understanding of how and why we need separate lines of thinking, separate lines of operating for First Nations, Métis, and Inuit to make sure that all of our voices are heard and that all of us have an equitable voice at the table. And so it means really fundamentally working independently with each of our nations and working independently for the betterment of each of us. And as some of the analogies yesterday came up, making sure that instead of having one pie that we have to fight over, making sure that there's a bakery in place to supply more of those, making sure that there's a lot of opportunities across the system for us to be able to engage in that work distinctly and uniquely. And really, I think at a fundamental level, it gives us that opportunity as Métis Nation British Columbia to make sure that our voices are heard and recognized alongside our First Nations cousins. And a lot of the work of the standard speaks to work that's already underway by our nation, work that we've already been doing over the last 10, 15 plus years to really drive this forward. And now there's a tool in place within the system to actually hold them accountable and mandate that this is something that needs to happen and something that needs to happen in the ways that we've been, frankly, telling the system it needs to happen for. So how do we practice a distinctions-based approach? One of the things that I think needs to be settled first is some of the language. And on the last slide, I used the term Aboriginal, which of course is the constitutionally recognized term, because in the British Columbian context, there's a lot of conflation sort of between the terms Indigenous and First Nations. Because of the First Nations Health Authority, oftentimes when people speak about Indigenous people, they're really just meaning First Nations. And so there's a lot of work that we as Métis Nation British Columbia have had to do sort of set the stage and set that baseline understanding of what does it mean when you're speaking about First Nations people? What does it mean when you're speaking about Métis people? What does it mean when you're using terms like Aboriginal, Indigenous, et cetera? And so really building that in as sort of a fundamental piece of our teachings, a fundamental way that we approach this work has been essential to how we move it forward. So some of the basic things that we encourage and that you'll see throughout the standard are use of language and representation. You'll see in the standard First Nations, Métis, and Inuit is used almost exclusively throughout. There are a few places where, for grammar and other things, we see the use of terms like Indigenous. But generally speaking, having us named in the standard means that we're not being forgotten, means that we're not being excluded, and means that we're not being ignored. Thank you. It also means being really relationship focused. And so as I'll speak to as well, there's a lot of very strong components of the standard that mandate relationships between health systems, accredited health systems, and First Nations, Métis, and Inuit. And so it's essential that those also maintain that distinctions-based approach. It's not enough to have one table that has a First Nations and a Métis person at it and call that your governance model. It has to include specific methods and specific actions that the health system can take that address the needs and the concerns of the Métis population alongside the First Nations and Inuit population. And then lastly, we need disaggregated data and disaggregated reporting. If I hear another Indigenous statistic, it's a useless waste of our time as far as I'm concerned. If we can't drill down into what is the impact of this metric, of this item, whatever, what is the impact specific to the Métis population? What is the impact specific to the First Nations and Inuit populations? We need that. It's fundamental. It's the only way that we can move this work forward, and it's the only way that we can actually understand what is happening on the ground to our citizens, and then be able to actually effectively advocate and push on their behalf. It's also the only way that the health system can take accountability for the care it's delivering to First Nations, Métis, and Inuit, if they actually understand how the system is underprivileging or potentially harming our people. So moving this into actual practice, I've brought a few examples, and you've heard my team speak to a few examples over the last few days as well. But we really want to see Métis-specific data and data governance in place. So in BC, we are currently working on a new data governance principle that we hope to blend together sort of the Western ideas of fair use and care principles alongside of our Métis core values. And so this is a very draft and early version of this framework that we've created. But it really sets up a path forward for how the health system can work with us to uphold our data governance, to uphold our frameworks, and to make sure that they get implemented. And in fact, Standard 8.1.1 speaks specifically to the need for data governance principles and practices that uphold First Nations, Métis, and Inuit data, and actually speaks to collaborating and engaging directly with the nations to use their specific data governance principles. So it's not enough for the system to just use OCAP. They have to also use our systems and our models. And so in the standard, there are reference to some of those external systems. Of course, our data governance framework hasn't been developed yet and hasn't been published yet. But as it gets implemented and as it gets acted on, that's one of the ways that the standard sets out that the system will have to engage with us and have to interact with us. That also looks like making sure that there's funding and resourcing available to support Métis-specific data, Métis-specific population health data, and Métis-specific understandings. And so I've also highlighted our Tanchi Kia report here, which is our Métis population health program in British Columbia, and really speaks to that overarching population health lens and sets out a series of recommendations for how the system can respond to and address the impact of colonization on the health and wellness of our people. And it's through these sorts of high-level data governance and data pieces that we're actually able to measure the impacts that the standard is having, and we'll be able to measure the distinct changes and outcomes that we're seeing across the system. This also looks like the signing of letters of understandings and the creation of our Métis-specific health and wellness plans. Recommendations 3.1.5 speaks to the idea of wellness plans where the system has to collaborate directly with First Nations, Métis, and Inuit in order to inform both operational and strategic plans that address the specific needs and concerns of our nation. And 3.1.1 calls directly for the signing of letters of understanding and similar agreements, making sure that there's a collaborative space where governance processes are acted on and worked on within the system. So that means the creation of Métis-specific tables where we are able to inform governance practices. And so in British Columbia, where we've been able to set up leadership-to-leadership tables with each of our health authorities in the province, and twice a year, our board meets directly with the board of those health authorities. That is in action and in support of one of the actions of the standard. And so having it mandated also speaks to one of the comments and the questions that we received yesterday of how do we hold the system accountable? If it's part of the accreditation standard, if it's part of the way that the system has to act, has to move things forward in order to achieve accreditation, then they're going to have to work with us. And they're going to have to work with us on our terms because that's the specific language that's been built into the standard. And that's, again, just for the British Columbia context. But I think as we speak about some of the future work that is hopefully happening, I think there's going to be great opportunities for us to bring that across Canada as well. And I'll pass back to you, Vishal.
Thanks, yeah. And I think Stephen noticed something really important, which is the implementation of the standard and how it's going to be done. And we're really, at HSO, we're very grateful for the partnership and collaboration with Métis Nation British Columbia. In fact, Stephen and I spent countless hours going through every sentence, every word of this standard to ensure that it was reflective and representative of the health and wellness priorities and objectives of Métis chartered communities and Métis Nation British Columbia. And really we're able to ensure that it is in alignment and upholds Métis-specific actions and priorities within the standard itself. In May of 2023, so about a year after the publication of the standard, the First Nations Health Authority and HSO convened an Indigenous working group to prepare the standard for assessment. This process eventually led to that document that you see here pictured, which is the one that has the Accreditation Canada logo at the top of it, and it's powered by the HSO BC Cultural Safety and Humanities Standard, and this was the standard that will ideally be assessed in health and social service organizations, the one that we were able to ensure speaks to and upholds Métis-specific priorities throughout the entirety of the standard. So the working group itself brought together Métis and First Nation governing bodies, communities, and organizations to really drive this standard towards accreditation processes and procedures. The working group met about 10 times over the course of 4 months to support the transformation of the standard into an assessment-ready standard, but also to provide key recommendations to Accreditation Canada on how do you assess a cultural safety and humility standard? What does that mean for surveyors to go into health systems to assess against this standard? What would that look like? I cannot say this enough, but this standard is unlike any other standard that exists, not just in Canada, but around the globe. And so the question about how do you actually assess this type of standard loomed large over this project, and we're really grateful once again to have had Métis Nation British Columbia participate on this working group to provide those concrete recommendations. In total, 26 recommendations were made and put forth to Accreditation Canada. So really grateful for that opportunity as well. In November, the assessment standard was shared with all BC Accreditation Canada client organizations, so that's all regional health authorities and multiple other health and social service organizations, as well as supporting resources that were co-developed with Métis Nation British Columbia and the First Nations Health Authority to support organizations in understanding the standard. All client organizations, so all health authorities, were then invited to participate in a user testing of the self-assessment of the standard. So to kind of give health authorities an opportunity to try out this standard, try some it's kind of self-assessment. If you were to self-assess against this standard, where would you lie right now today? That is running from November 2023 and is set to conclude this month. We're really grateful to have had, I think, about 10 client organizations, including multiple regional health authorities, participate in this this self-assessment process. So we're going to find out from health authorities specifically and multiple other health and social service organizations in BC what's it like to self-assess against this standard. We're really excited to understand from their perspective what is it like to do this work. FNHA and Accreditation Canada concurrently are also co-designing surveyor competencies and recruitment and training materials to assess the standard. This is all work that we hope to continue on beyond any fiscal year or any calendar year, but the work that needs to happen day in and day out. All this to say is that we've been moving. In many cases, documents like this are published, then you kind of never hear from them again, and they line the drawers of offices and things like that. But we're really deeply committed to taking this work forward. The publication of the standard is not the end of this project. Bringing assessment to health authorities, health and social service organizations, that's the goal here, and that's what we are really committed to exploring and examining how we do that in a culturally safe way. And so we're really grateful to have had the partnerships that we've had to push this standard forward, to continue to move it forward. And I also just want to note that that we've heard from health and social service organizations, health authorities, provincial governments that this is something that they want to. So it's less about how are we bringing a tool to hold health authorities accountable, but it's really about how health systems are working in cooperation with First Nations, Métis and Inuit governing bodies and communities and organizations to bring assessment into health authorities for cultural safety and humility. And from a health standards organization standpoint is how are we able to leverage the levers of change, the tools and opportunities that HSO has to contribute to this work, noting that it must be led by First Nations, Métis and Inuit governing bodies, communities and organizations.
And if I can just add a little bit as well, we're also working in partnership with the First Nations Health Authority and Healthcare Excellence Canada to develop a way for the system to sort of come together and do that. And so actually next week in Victoria, we're hosting a gathering of all of our community of practice, which consists of about 60 members across all the health authorities in British Columbia. And we've been working really diligently to sort of fan out and create champions in each of the health authorities to leverage that self-testing and that self-assessment work and really help each of the health authorities prepare to undertake the larger accreditation process when that comes up.
Yeah, that's absolutely true. And in November of 2023, we were really grateful to also partner with the National Collaborating Center for Indigenous Health, who also hosted and convened a gathering for a day and a half with health systems partners and First Nations and Métis and Inuit governing bodies and communities, patient partners, to come together to talk about the implementation of this standard. So there's been tremendous amount of movement. We're really grateful to have so many organizations contribute and partner on this work, recognizing its significance as and its foundation as a standard for cultural safety and humility that speaks true and loudly to the priorities of Métis Nation British Columbia, the First Nations Health Authority, the First Nations Health Council. So once again, just grateful for how many opportunities that have been provided and how many partners have joined in on this movement. So that brings us kind of to the end of this presentation, which kind of is a bit of a look into the question that we've heard time and time again, which is what about beyond BC? This is a country comprised of 13 healthcare systems spanning territories and provinces. The BC Cultural Safety and Humility Standard is a significant standard, really provides an insight into what is possible. And so really grateful to have had the partnership with the Canadian Indigenous Nurses Association SINA to lead a national engagement to scope the need and design of a national cultural safety and humility standard, outlining a common set of expectations for every hospital, every health system accredited to meet cultural safety and humility priorities and objectives. From July to November, SINA gathered feedback through a national online survey to hear the voices of Indigenous peoples from coast to coast to coast. In total, 95% of First Nations, Inuit, and Métis survey respondents agreed that health and social service organizations across Canada should be meeting a national standard for cultural safety and humility, that this is something that should be assessed, should be measured through accreditation processes. In terms of priority areas that were identified by survey respondents, a few of them came out really loud and clearly. I don't think this is going to be a huge surprise, but upholding Indigenous rights and truth, looking at the United Nations Declaration on the Rights of Indigenous Peoples. They said concept of native healing the health system came out very loudly and very clearly, and then of course inclusive representation of Indigenous knowledge systems. SINA and HSO will release a What We Heard report in March of 2024, documenting the themes, perspectives, and voices heard through the engagement process. We're very excited about this, this prospect of a national cultural safety and humility standard. But what we really wanted to do over the last year is not make the assumption that a standard like this is going to be supportive of cultural safety and humility as a movement spanning 13 healthcare systems, not make that assumption that HSO has a role to play here, but actually ask the question, would a standard like this be useful as a tool? Would leveraging accreditation as an assessment process, as a continuous quality improvement opportunity for health and social service organizations, would that be needed? Would that be warranted? Would that be welcomed? And I think what we're hearing more clearly now than ever before is that using accreditation to advance cultural safety and humility, to address Indigenous specific racism, discrimination, both systemically and interpersonally, is needed. And so one of the things I often say about this work is, if you've heard of day one of developing a project and making sure that that the voices of First Nations, Métis, Inuit people are included on day one, well, this is the day before day one, and we want to ensure that we're starting right from what's the possibility of this work, and starting from there all the way to what we hope is a really incredible journey over spanning years. Because once again, one of the things that we hear often, and I'm sure many of you hear, is, we have this really important work to do, but it has to be done in 2 months, or it has to be done in 6 weeks, or we only have funding for 3 months to do this, so we're all going to need to really dig deep and figure out how we're going to do this. This is not a process that we want to bring into those types of timelines. We want to take our time. We want to give the technical committee, a national technical committee, all the resources, the tools that they're going to need to put a standard like this together. We want to make sure that this is a process that takes its time in its development, and we're committed to ensuring that that there is that time and attention and care and opportunity for self-reflection that is a prerequisite for a cultural safety and humility standard spanning from coast to coast to coast. So, in conclusion, those are our cats. We opened it up with pictures of ourselves, and we're closing it with pictures of our cats.
The real bosses.
The real bosses of our organization.
So, thanks, everyone.
I love the cats. I love the work.
Yeah.
But I love the cats as well. Strong way to end today.
This is Dory and George.
Yeah. So merci for this amazing presentation that just speaks to such systems level impact change, like truly. So we're running a little bit behind time, but I think we can have one question perhaps, if anyone has a burning desire that they really need to vocalize and want to put out there right now.
And Stephen and I will be around the whole day if somebody
Yes.
wants to ask any questions at that point too. We're more than happy to talk about this journey as well.
Absolutely.
Awesome. Okay, well, thank you so much to our keynote speakers this morning then, and please definitely follow up, connect with them for your questions and to chat throughout the day. Merci.
Thanks, everyone.
Okay, so we're going to transition into our panel, our first panel for the morning. And our panelists are going to be speaking about National Métis Health Data Strategy. We're going to have 3 speakers on this panel. We're going to do sequential presentations, and then we're going to do one big Q&A session following all of their presentations. So the first speaker I'd like to invite up is Hannes Edinger, the founder and managing director of Big River Analytics, and they'll be speaking about a Métis Nation data strategy. Welcome.
I think this is not the correct presentation.
That's just the title slide. Can we pull up that one? Got it?
This is forward.
Yes.
Okay.
And so we'll probably, we're sitting right over there, so we'll just flash it as we're getting a little close to time.
Got it.
Time card. Sound good?
Good.
Okay.
Okay, thank you. My name is Hannes Edinger. I'm Métis with roots from St. Boniface, though most of my family has moved to northeastern Alberta. I'm an economist, the founder and managing director of a company called Big River Analytics. Big River Analytics is a Métis-owned company founded in 2011 with a mission to provide statistical and analytical capacity to benefit Indigenous governments in Canada. And I'm here to provide an overview and update on the Métis Nation data strategy. At the highest level, MNC, with direction and guidance from governing members, is developing the Métis Nation data strategy. And the objective of that strategy is to describe a path toward meeting the long-term data needs of Métis citizens, governing members, and the Métis Nation collectively. This work is funded through Indigenous Service Canada's transformational approach to Indigenous data. And in terms of timeline, a substantive draft of the strategy is anticipated this spring, and the final strategy is expected by March 2025. In terms of my presentation today, I'll provide a little bit of a refresher and context on the project, speak to some of the progress that we made specifically around the strategic framework component of the project. I'm particularly excited about demonstration projects, and so I'll speak to those. And then give a bit of a timeline in terms of our next steps.
Just a reminder to click that too.
Oh yeah, okay, I'm clicking on my, you can't see.
All over the place. Do you want Sophie to click for you?
Oh boy, and I've got a different presentation than my presentation. That's okay, we'll get through this. Okay. For those of you that know me and my fear of public speaking, this is not an ideal situation. Okay, thank you. Right, so in terms of background, I mentioned this initiative had its genesis in the transformative approach to Indigenous data, which provided funding for the work that's being done, but in my perspective, more importantly, it's created a policy window or an opportunity to redefine the relationship between the Crown and Métis governments as it relates to data. It's an opportunity to strengthen the Métis voice on issues related to data, to increase capacity for data management, and develop data-related tools and practices to serve Métis governments and ultimately Métis citizens. The strategy is an opportunity to ensure that Métis voices tell data-related stories in a place of colonial narratives that have previously existed. I think it's important to really highlight the change that we're seeing beyond the funding that TAID provides. Like I said, Big River was founded in 2011, so we've been working with Indigenous governments for the last 13 years, supporting them in data provisioning and all kind of data-related work. And a lot of that work is often trying to secure secondary data, so data collected by other organizations for their purposes to support them in their governance. And you can kind of summarize much of that experience in having the door closed or the door slammed on your face sometimes when asking for these data, which has certainly been challenging. It's pushed us to support Indigenous governments to collect their own data. But there's been really a change in the last 6 months in terms of the openness of different levels of government to engage with Indigenous governments and share those data. And I really have, noticed a difference, a marked difference. And so to me, this is just a tremendous opportunity to kind of like take that policy window and open it as wide as we can while we have this opportunity. And finally, I think the challenge for this strategy, and the strategy will only succeed, is if we're able to balance what's best achieved together through collective and coordinated efforts while ensuring that GM-specific and policy area-specific data needs are prioritized and met. In terms of the scope of the strategy, there are 4 main elements. There's the strategic framework. That's where we've done most of our work so far. This would consist of a vision, a set of principles to guide the development of the framework, some desired outcomes, which are kind of like mini visions, and then some themes that have emerged, which would be, you know, the primary concerns, the primary opportunities that GMs have identified. There's an implementation structure. And so the implementation structure component is kind of like the business plan. What will eventually emerge from the strategy would be a set of recommendations about the development of an institute or an organization that would, you know, ultimately serve to help the Métis Nation meet its data capacity goals. We don't know what the form of that, oh boy, I've been clicking again. No one told me. This is why, yeah, PowerPoints, I'm not great with PowerPoints. I just like to deliver the whole thing all at once. We're on scope, okay. So the implementation structure is like the business plan. It describes the governance or the functions and the attributes of the institute or organization that would eventually emerge from the data strategy. So just, I'm going to say that again because I give this presentation and then people come up to me after and they say, what the heck are you talking about? What's the national strategy? The strategy is a roadmap informed by governing members that will describe an institute or organization that will help achieve the data-related objectives of the Métis Nation. So this could be, you know, like a Métis center that would have centralized or coordinated data capacity. Could look like GM level data capacity. Could look like a combination of the two, like a network whereby you'd have some coordinating capacity and some distributed capacity. And yeah. Just wanted to make that as clear as I can because I feel like it kind of gets lost in like all of this, the language. We're developing implementation support, so these are kind of like specific one-off pieces intended to advance and increase the likelihood that, you know, this structure, this organization or institute gets funded and has some legs beyond the development of the strategy. And then demo projects. So this is an opportunity to test and refine some of the pieces that we've been developing and to build some like on-the-ground, hopefully useful tools from the work that we're doing. Can I just ask how I'm doing for time?
A solid
10. 10, okay, good. And I'm again just changing on my, oh man, okay. Right, so in terms of principles, I feel like we should just take a minute to talk about principles because we often use this word. I'm sure you'll actually hear this word on the panel a couple of times. And what I mean by principles in this case, like in this space, you'll often hear about data governance principles. And I think people, when they see our principles, assume that this is like a set of data governance principles, but they're not. These principles are the how in terms of how we develop our strategic framework. So these are just, you know, guiding conceptual practices that will guide the development of the strategy. This is what we've heard from GMs, this is what we heard from our working group in terms of what's important about how we go about the development of the strategy. So it's important that the strategy is practical and Métis-centered, that is, we prioritize on-the-ground and near-term data needs of Métis citizens while still advancing an aspirational vision for the strategy. Got to be practical. Self-determination and sovereignty, so we advance the inherent jurisdiction of Métis governments to engage in nation-to-nation relationships and own, steward, and use Métis data to support the diverse perspectives, voices, and interests of Métis citizens and disrupt colonial data practices. I like that last bit in particular. In terms of stewardship, we manage the life cycle of our data according to Métis values, protocols, and ethics, upholding the privacy and confidentiality of Métis citizens while maintaining transparency and accountability. It's inclusive, so data are not just data sets and numbers. We understand that data extends the Western concept, that we intend to extend the Western concept of data to respect and include Métis experiences, stories, knowledge, and worldview. We're collaborative and responsive, so we respect regional needs and we create space for collaboration between Métis governments in areas of collective interest and foster reciprocal relationships with external partners. We build on regional or policy area work that already exists in order to not recreate the wheel. And finally, the strategy needs to be innovative. We're not, StatScan, we're not this like large organization that has a big history, big legacy that's hard to change. We can be innovative. We can use the latest technologies and methodologies to support and enhance Métis data capacity. Yeah. I won't go into all of the themes, but these are some of the themes that have emerged from our work with the working group around their interest and opportunities that they've identified. So in practice, this is the implementation structure component of the overall strategy. We're looking to propose a set of operational models and then have the working group and GMs refine the operational model. This is what I was talking about in terms of like, is this, one organization that lives in Ottawa and serves governing members? Is this, a mini data center, one that would live in each governing member? Or is this a network that combines some central or coordinating capacity with a distributed model? We're looking in this component of the strategy to actually articulate the operational model. So proposing a few, and we're going to work and see which actual operational model best aligns with those principles. The governance structure, so what's the decision-making authority? What does that look like? Is there a board? How would that be structured? What would they meet? When would they meet? Who would the board be comprised of? All of those details, we're proposing options and working through them with our working group. And then a business plan. So how do we ensure that this proposal is ultimately, picked up, funded, and brought into reality? So that's the second component of the strategy that we're working on. Okay, demo projects. This is the part that I get excited about. All the while, we're working on this kind of like higher level or conceptual stuff, and then like the slightly more practical component, which is like the business plan piece. But as we're kind of moving through this space, we're identifying opportunities to do work right now. This particular, so conceptually, the idea is let's identify on the ground practical opportunities to build data capacity as we're developing the strategy, to demonstrate the value of the organization or institution that ultimately emerges from the strategy, to show that there is an opportunity in the data space to have collective capacity and benefit from opportunities that really scale. So we're not developing a tool in each governing member, for example. You could develop one and then tailor it specifically to other organizations, other governments. So I've got one example. Right, that's what I spoke to. So this is the landing page of a dashboard project that we're working on. This project emerged out of some of the work that we were doing. There was StatsCan reached out to us to coordinate some response to a product that they had developed from our working group. They said, hey, can you take a look at this product? We looked at the 2021 census data and we analyzed it. We looked at it and the objective of this paper is to speak to the reality of Métis people in Canada. Do you have any feedback? And ultimately, what they put together did a really bad job of speaking to the reality of Métis people in Canada. They had sliced and diced things in a way that didn't make any sense. They had used, the Indigenous identity variable, according to some of the input inappropriately. And so we collected and collated all of this feedback, saying like, listen, if you really want to release this paper, this is the long list of changes that we would recommend. And they said, okay, great, thanks for your input and thanks for your feedback. We don't actually have any capacity to make changes to the report. It's going out as it is. So out of that frustration, we proposed, well, why don't you build a dashboard? Why don't you build an interactive tool so that way governing members could navigate census data and use the variables that are meaningful for them, use the geographies that are meaningful for them to extract information from the census. Like, it's imperfect. We all know about the problems with the census, but it's still, the largest and often, the most important data set that's produced in this country. And they said, okay, great, yeah, we could build a dashboard that would take 5 or 6 years. And so we just said, okay, fine, just give us the data, we'll build the dashboard. And so this is, these are some screenshots from the product that we're working on. And again, this is just one of the demonstration projects. We're open and soliciting ideas for additional data projects or demonstration projects. There's a mapping component. I like this slide. We're working a lot on the visualizations. It's taken me a while, but I finally conceded that most of what I do as an economist and as a data scientist is to show that one thing is bigger than other things. And my staff, I'll never kind of like, this was like a profound realization. I'm like, wow, this is actually what we do with all of these charts and all this visualization, these hundreds of lines of code, is we just show that one thing is bigger than another thing. So let's just focus on doing a really good job of that. And so that's literally part of our review process when we're looking at charts in our reports in my organization is like, can you clearly identify what is bigger than the other thing? And since we've had that focus, we've started developing new visualization techniques to make sure that that's really clear. And so we're doing that as part of this tool. Is we're investing in visualization techniques that really allow folks to contrast either across variables or across geographies. This is just an example of one of the bubble charts that I really like because it does a good job of showing what's bigger and smaller. This is kind of neat. So in alignment with our principle around innovation, we have included an API to incorporate a large language model into the development of the dashboard. And so I've also kind of realized that a lot of what we do at Big River is support domain experts, all your health experts. I'm not a health expert, but we support domain experts to leverage data in their work. So we're kind of like data experts, we work with domain experts, and there's like this gap. And the goal with this tool is to ideally narrow some of that gap. So domain experts can just use their knowledge and access the data to achieve their mandate and their objectives. And so what this part does here is essentially it's like you just describe the chart that you would want, point it to the data set that you'd like, and it builds the chart for you, so there's no more coding. We're actually using this internally. We now have analysts that don't know how to code, that just describe the charts they want to build, and AI actually generates the chart. And then there's a first, I wouldn't trust this 100% yet. This is the space is evolving really quickly, but there's an AI component that would allow you to produce a summary of the chart that's then produced. And that's a good starting point for folks that are not super familiar with that process. So yeah, this is kind of a cool feature. And then I guess the final part of the dashboard that I'd like to present today is this, I'm calling it the model UN nation component, where all of these data are public, so there's no confidential data, but we're imagining that maybe one day governing members would want to use this data visualization tool. Suppose they're really enjoying it, they use it to navigate the census and other public data sets, and one day they want to upload their own data into the tool. If anyone else were to access that data, you'd need to have data sharing agreements in place and that sort of thing. And so we built this model UN version of a data sharing agreement whereby governing members can actually enter into data sharing agreements to access the census data of other governing members. So it's a bit contrived in the sense that anyone can actually make that data request and get data from other governing members, but we want to put together the data sharing agreement and put together the process by which governing members would enter into those agreements, just to flex that muscle and practice what is it like to get into a data sharing agreement ultimately. And so that's built into this tool as well as something that we can kind of go through that process with public data, so that way one day when we may want to share or compare confidential data sets, we could be in a place to at least have that conversation. And this is just a description. Where am I at? I'm probably, yeah, okay, right on. This is just a description of the process that we're going through in terms of trying to collect additional ideas, right? So this data dashboard is just an example. I'll be honest, that was my idea. I thought it was a good one, and it's good to have an example to solicit additional input and additional data, or additional ideas rather. So a bit of a, yeah, there we go. To summarize, the transformative approach has created a policy window. I think it's really is an opportunity. It's the best that I've seen in the time that, that I've been doing this work. We're developing the Métis Nation data strategy, and this is not just a paper-based exercise. We're testing our ideas, we're building demonstration projects, we're engaging with governing members in our working group to make sure that this work is done in a good way. This phase of funding is finalized in March 2025. The goal would be to secure additional funding to actually implement and build the organization or institute that would be recommended as an output of this strategy. And yeah, implementation of the strategy is anticipated to begin in April of 2025. Good. Thank you. Did it. Well done.
Good job. That was awesome. I just wanted to say, even though it's just amazing to see the story of our healthcare needs be told in these very engaging ways, right? And with the use of technology, with the use of imagery, and it creates accessibility for our people. I'm not a big fancy scientist, and I don't really know a ton about numbers, but I can figure out what the big circle is compared to the little circle, right? And so that's about accessibility so that we also understand as Métis people what is happening. And so I just want to say, Marcy, thank you for that fun presentation. Okay, so next we're going to welcome up Dr. Chelsea Gable and Dr. Bobby Henry, who are going to deliver a presentation titled What We Heard from Governing Members on Health Data Initiatives and Métis Data Governance Principles. I just also wanted to do a quick check that we're using a lot of shorthand language here. Métis National Council, there are 4 governing members. So if you hear GM, that's what we're talking about. Otipemisiwak Métis Government of the Métis Nation within Alberta, aka MNA, Métis Nation of Ontario, Métis Nation Saskatchewan, and Métis Nation British Columbia. So if you hear us saying GM, that's who we're talking about, the Métis governments. Over to you folks. You got clicker? And we're going to flash the signs every now and then, okay, just to keep you on track.
Okay, I'm like,
Okay.
I know it's blinding. It is a little blinding.
Don't look directly into it. Yeah.
Great, okay. I know I can't, it's very blinding. Well, it's really great to be here. And where's Hannes? I can relate. I mean, I am an academic, but I have to say I do get very nervous before talks, and I have to do a lot of them, but there's something especially nerve-wracking when you're talking to your own people too. So, but we're both very grateful to be here, and just to have some dedicated time and space to talk about a national Métis health data strategy and principles. So different than what Hannes was talking about, and hopefully that becomes clear throughout the presentation. We had a really great discussion on Tuesday. We had a health data pre-forum engagement session, and then hope for a little bit more discussion in our session. And again, please feel free to come and reach out to us. We will also be here throughout today and tomorrow. So I realized, Bobby and I have done a few presentations. We co-lead a number of networks, and I'm so uber focused on the get through the presentation that I often just totally forget to introduce myself. So I'm Chelsea Gable. I'm Métis I'm from Rivers, Manitoba. Desjardins, Fleury are some of my names, and I've spent the last 25 years living in Ontario. Went to school, to university in Ontario. I'm an associate professor at McMaster University in Hamilton, Ontario, in the Department of Health, Aging and Society and the Indigenous Studies Department. I have a Canada Research Chair in Indigenous Wellbeing, Community Engagement, Innovation. I only have 7 minutes, I think 7.5, before I turn it over to Bobby, and you always go over. So he's notes today, so that's good. So I definitely don't want to spend this whole time talking about myself, but I do want to highlight that my background is in Indigenous research ethics. I served on the McMaster Research Ethics Board for many years, as well as having spent 6 years with the Canadian Institutes of Health Research Standing Committee on Ethics, and I chaired that committee for 2 years. At the health data pre-forum engagement session, I know some of you were there on Tuesday, Dr. Chris Anderson gave a presentation and talked about the book that he wrote over a decade ago. Some of you probably know it, Indigenous Statistics, a quantitative research methodology with Maggie Walter, who is Palawat, a member of the Tasmanian Aboriginal Briggs family in Australia. But I also want to acknowledge that myself, Maggie, and Tahu Kukatai, who is Maori from New Zealand, have joined Chris, so 3 Indigenous women, as authors on the 2nd edition of that book, which is now called Indigenous Statistics from Data Deficits to Data Sovereignty. And included in that book is a chapter that speaks specifically to Métis data governance and sovereignty. So I highlight this not to talk about myself, but really just to highlight that a lot has changed in the last decade when it comes to the history and even the language of Indigenous data governance and sovereignty. The other shift in the last couple of years is around the importance of distinctions-based data. And we've heard a lot of that in the last couple of days, and I thought Stephen did a really great overview. And it was in 2021 when the federal government announced that they would co-develop distinctions-based Indigenous health legislation with First Nations, Inuit, and Métis. And I shared this story on Tuesday at the pre-forum. My PhD student, I'm not going to make her stand up, maybe I will. There she is, Ali. So Ali is Métis from Manitoba, and she wrote a really powerful op-ed last year that speaks to some of her concerns about the legislation as a Métis student and citizen herself. So I'm just going to really quickly summarize what she wrote. While I was excited for the prospect of Métis health being recognized, as a student and as a citizen of the Métis Nation, I was also met with anxiety about the lack of accurate population-level health data we have to inform decisions. Another growing barrier that contributes to the lack of Métis-specific health data is chronic underfunding across Canadian universities. From 2010 to 2022, only 1.5% of projects funded by the Canadian Institutes of Health Research, the federal funding agency for health research, focused on Métis-specific data collection. As a Métis PhD student, my research study accounts for 1 of the 19 funded studies in the last 12 years. So now more than ever, we need Métis health data that is conducted ethically and is respectful of both individual and collective rights, and accurately represents our distinct population. This will require a comprehensive strategic health data plan that crosses jurisdictions, considers the complexities of data sovereignty, and ultimately understands the nuances of who we are. Next slide. So this brings us to where we are today in the work that we are doing to support a national Métis health data strategy and principles. And I really always love just to highlight the team. I would never do this without them. I love them so much, and so grateful that we are working together on this. Dr. Jennifer Walker isn't here today, but she works with me at McMaster. She has a Canada Research Chair in Indigenous Health Data, and she's a core scientist with the Institute for Clinical Evaluative Sciences. I know some of you know Jen and that you've worked with Jen. She was involved with the Data Governance and Partnership Agreement between ICES and the MNO in 2016. She's produced a number of publications on chronic disease among Métis in Ontario and has a close working relationship with the First Nations Governance Centre, FNIGC. Dr. Walker is also part of the International Indigenous Data Sovereignty Alliance that developed the CARE principles, which are intended to empower Indigenous peoples by shifting the focus from regular consultation to value-based relationships that position data approaches within Indigenous knowledge systems to the benefit of Indigenous peoples. Dr. Tate was here with us the last couple of days, and so I do want to acknowledge her. She's been at this for a really long time, really important part of the team. She was involved in the 2010 work out of the Métis Centre with the National Aboriginal Health Organization, NAHO, when they hosted a think tank to talk about Métis-specific research ethics. I know a number of you draw on that document. So our goal today really is to provide an update, and I'm going to turn it over to Bobby really quick. How much time? I feel like now I'm always yelling at him. You go over, and I'm going over. So just to give a quick update of what we've been asked to do. We've been asked to undertake community consultations, very mindful of engagement and research fatigue amongst many of you, especially just hearing in the last couple of days all of the important things that you're doing. We started this work in the early fall in September, and Bobby's going to share some of those sort of high-level highlights with you in the next couple of slides. We've done an inventory and assessment of current Métis health data governance, and we're also drawing on information and recommendations from other jurisdictions and sources, like what's happening with Indigenous health data nationally, internationally, across other Indigenous communities and organizations. And so ITK, for example, they received $6.4 million last year from CIHR. It was a targeted funding call to establish a new Inuit health research network. They also have their own national permanent health survey. CIHR is going to release data next month to show how much they have invested in Indigenous health research, including a breakdown of distinctions-based funding initiatives. And I think it's safe to say, and Bobby's seen these results already because he sits on the board at CIHR, but it's safe to say that we are severely underfunded, and in my notes it's bolded and underlined, severely underfunded compared to First Nations and Inuit. So I'm going to turn it over to my colleague, Bobby, just to talk a little bit about the principles that he and Dr. Caroline Tate developed in Saskatchewan, and talk about some of the what we've heard.
Thanks, Chelsea. So good morning, everybody. My name is Bobby Henry, or Robert Henry, depending where you know me from. Métis from Prince Albert, Saskatchewan. I'm at the University of Saskatchewan, and I hold a Canada Research Chair in Indigenous Justice and Wellbeing. I also lead the Networks and Environments of Indigenous Health Research for the province, and I co-lead with Dr. Gable here, the National Coordinating Center for the NEAR Networks. So for those of you in other provinces, I know some of you are working with the NEARs. I really do recommend that you go and connect with your NEARs as the renewal's going in, and making sure that you're embedded within those processes as for community engaged research that's happening. I'm going to do this really kind of quick. You can come and talk to me whenever you want afterwards, along with Dr. Gable. So in 2015, Dr. Tate and I were approached by at the time, the Saskatoon Health Authority and Métis Nation Saskatchewan. And the reason why we got approached was they had no data on experiences of Métis people in emergency room settings. And they didn't know how to collect the data, they didn't know how to, they had sets of self-identified pieces, but they didn't know how to move it around. And so this is how we began to start talking about what are these principles and how do we actually start developing agreements across different health sectors on sharing data. The reason why this was being done was what they were finding with First Nations data was that they were staying 31 days longer in care than non-Indigenous people. So this was a huge burden on the healthcare system, and they were trying to understand why. They wanted to see if Métis were experiencing the same pieces, especially for the Northern Métis. So from 2015 until 2023, we've been working with communities and MNS on developing these principles. And going through, we looked at OCAP, NAHO, care principles, and everything else going through. And what we have to understand again with OCAP is a First Nations understanding of Western control, right? That's what it is. And it has to only be used for First Nations status. That's what it was created for. I sit on ethics boards and we see researchers continuously come in and say, hey, I'm going to follow OCAP principles with Métis research. And I was like, you can't do that. You can't actually use that. So this is one of the issues of why we're bringing these principles in as well. Within the principles, we've been talking with different GMs going across the country here, kind of highlighting them. And what we have to understand with these principles is that these principles are to guide research agreements or agreements to share data. They're designed so that you begin to work with your partners through a Métis-specific lens on what this looks like. And so we've come out with 6 sort of principles that will highlight different things, building reciprocal relationships. And these are highlighted if you actually listen to what the conversations, they're there already. We just haven't put them on paper so that everybody can kind of follow similar ways of agreement. Respect for individuals, safe and inclusive environments, diversity, research ethics, and a Métis context, meaning that the individuals who are working with you should understand the context in which you are working with the Métis communities that you're working with. In Saskatchewan, I'll put it this way, there is beginning to become a larger divide between the north and the south, and even across language and what language is being used. In the north, very strong Cree-focused Michif speaking, and in the south, it's more French-focused within that. And there's a big divide that's beginning to happen. So we have to understand that even the idea of Michif as a language going across is not the same across jurisdictions based off of the relationships you have with the First Nations and your other communities in and around that area. But when we talk about Métis as a culture, it becomes homogenized into one way of knowing. And so this is why we're asking individuals to do this. The importance of this is the beginning and the creation of data stewardship agreements, which should be put into place. The other part with these health principles is that these should not be just focused on health, and you should be able to look at these principles across all areas of interest, housing, justice, et cetera. These are to guide you on how to engage with your partners and so forth. It's also, they have to be understood as a spectrum, which is why it's embedded within the symbol of the infinity. You can start wherever you want on here, but every governing body is also saying that they're at a different place. And you're also going to have different places with your relationships. We just heard this morning, a great presentation. There's a very strong relationships going on there, and some other places don't have relationships with their health authorities in the same way. So what we've been hearing, governing bodies are at different stages within their data process. Citizens continue to experience engagement and research fatigue. I think what we have to understand when we hear this as well is a lot of people continuously fall onto Linda Tway-Smith's idea, as research is one of the dirtiest words, and that they're doing that. It's actually not research anymore that's hurting our people. It's underfunded programming and lack of continuous programming. Research isn't what's hurting our communities. It's the idea of creating a 2-year program and then ripping it from the community when everybody builds a relationship, and then you got to go and build it back up again. Very different in what we're talking about here. We're also seeing MOU agreements across and between governments, agencies, organizations, and communities. But we also want to look at what does this mean? When we look at data, data is individually owned. We have to understand this, that even our nations don't own the data. You have to go back to the individuals within those spaces and within there. Challenges with data and research literacy. Working with communities, sometimes they don't understand what it is that we're talking about, so we have to engage continuously. Connection with Métis social determinants of health, that these have to connect in. Discussion about a centralized clearinghouse and repository. I'm seeing a lot of projects that are being done. Where's that information? Where's the evaluation report that you should be doing with that? Where's the data that you should be coming or collecting through your programming pieces, and how is that being stored, and how do we share that across nations? I think there's a lot of information out there. We just haven't found a process in which to share this in a good way. Insecurities remain about who gets to control the data. We've heard this across the GMs that they're hesitant on MNC controlling data. We've also heard at the community level, because as community researchers and from the community and embedded in my community, there's at the regional and local levels, they're even wondering, okay, how do we get to control this from the provincial body and all the way through? So we need to start looking at what those agreements look like and how do we build them across. Communities should do research, but data needs to be safe, and people are in agreement with the principles in principle. So we've shared these principles, and everybody's like, yeah, no, this is great. This is what we do all the time. It's like, okay, it's on paper, we can do it. But how do we move this forward? And we're on a very tight timeline to bring all of this together. The other thing that that I do want to highlight right before I get into the discussion questions, and we'll end it here, we need to be very careful on recreating distinctions-based as a buzzword. And what I mean by that is we're using it quite rapidly and all over the place, and we really are missing the point sometimes that we're just putting in there. We're going to do distinctions-based research without actually understanding what it means, and we're going to fall into the trap of two-eyed seeing and other buzzwords that researchers are using in order to engage with our communities. So we got to be very careful and hold into account what is the accountability mechanism that we want to hold on to with our partners. What happens if they don't live up to what the agreement is? What is that mechanism of accountability? And this is what these principles are supposed to will help get into a place to say, what is the accountable idea? We talk about relational accountability. Well, what happens when a relationship, somebody does something bad in a relationship? Who gets to control that? So these are where the principles are moving forward. I just want to say thank you, and we will go with that.
How do I change? Yeah, I was going to put our emails up.
Oh, you're going to put, okay. I just
And
don't.
picture dogs. I love the cats. A Great Dane, a Golden Retriever.
Yeah.
What's Franklin?
Pit bull.
A pit bull.
But no, anyways, thank you. And we are here, and we do want to have more conversations with you. We do have time and space to move away. Wherever you want to move, you just find us, and we have a meeting space to meet with anybody at any time. So we look forward to having those discussions with you.
Thank you.
Awesome, Marcy, thank you so much. And we'll invite you folks, if we have time, we're hoping to have time for questions, so we'll invite you back up for questions too. Yeah. Awesome. So our third presenter that I'd like to welcome up is Nicolas de Guzman Chorny, who is going to be presenting a presentation called the Pan-Canadian Health Inequalities Reporting Initiative, Health and Wellness Indicators by Métis Identity and Approaches to Selecting Key Inequities. Welcome. There's the clicker there. That's you? Right there?
That's me.
Perfect.
So I advance with this one, presumably.
Point it at that, though.
At that?
Yeah.
Oh, okay. How do I go back?
I don't know how to
Can't
go
go
back.
back.
There we go, you got it.
Thank you. Good morning, everyone. My name is Nicolas de Guzman Chorny. I'm a senior policy at the Public Health Agency of Canada. And I'm here this morning to tell you a little bit about the Pan-Canadian Health Inequalities Reporting Initiative and the data that we have developed that can be disaggregated by Métis identity. So briefly, I would like to begin by acknowledging that Ottawa, the place where we are today, is located on the unceded territory of the Anishinaabe Algonquin Nation, who have been the traditional guardians of these lands. I also acknowledge that I am a light-skinned Latin American man living and working on these lands, and I personally strive to contribute to the healing and decolonizing journey that we all share. So as I mentioned, the purpose of the presentation this morning is to provide an introduction to the work of the Health Inequalities Reporting Initiative. I would like to outline how the work of this initiative can play a key role in identifying inequities for various population groups, including Métis. And in particular, I'd like to do a bit of a mapping exercise using indicators from this initiative and how they stack up to the priority areas that have been identified by MNC in their publication, Métis Vision for Health. So the Health Inequalities Reporting Initiative was launched in 2012 in response to global and domestic calls for more routinely disaggregated data to inform action on health equity. The objective of the initiative is to strengthen knowledge and action on health inequalities in Canada through improved data infrastructure, monitoring, and reporting. There are a number of drivers that underpin our work on equity, but I will only mention a couple today. So at the national level, there's the Truth and Reconciliation Commission's call to action, particularly call to action number 19, which calls on the federal government to monitor health inequalities related to Indigenous peoples and assess long-term trends. At the international level, one of the key drivers is the Rio Political Declaration on the Social Determinants of Health, which played a key role in the establishment of the initiative. So the initiative brings together data from multiple sources in order to identify and develop a number of indicators that can help stimulate intersectoral action and dialogue. So this means using data from about 20 different data sources. Some of that includes administrative data, survey data, census data. And we bring different sort of numbers of years of this data together in order to develop the analytical framework that allows us to identify these inequities. As you may imagine, advancing health equity requires a comprehensive approach that includes engaging and collaborating with partners across different sectors. So even though the initiative is led by the Public Health Agency of Canada, we closely collaborate with other government departments, including Statistics Canada, as well as provincial and territorial government partners and data custodians. So in particular, since the inception of the initiative in 2012, we've been fortunate to work with various Indigenous organizations. MNC has been, in particular, a key partner for us. And we've worked together over the years to ensure that the unique priorities, worldviews, and circumstances of First Nations, Inuit, and Métis are reflected in all aspects and all stages of our work. So the initiative has developed a number of knowledge products. So one of those key ones is the Health Inequalities Data Tool, which was launched in 2017. And it contains indicators related to social determinants of health and health outcomes. And I will be speaking in more detail about this today. But we have also developed a number of scientific reports that provide a more in-depth look at some of the inequalities that the data identify. Some key examples include the Key Health Inequalities in Canada report that was launched in 2018. But we also had developed some publications around COVID mortality and inequities in COVID mortality. And we're currently working on a report that will be looking at inequities in relation to social determinants of mental wellness. I know this was a topic that was discussed at length yesterday, and we hope some of our data and our findings can help inform those discussions as well. In addition, we've also developed things like infographics and videos to reach various audiences through different means, so social media, newsletters, and so forth. And then we also work a lot on capacity building. Some of that includes developing the evidence around interventions that have been shown to reduce inequities. So, in addition to identifying those inequities, we're also trying to develop tools that practitioners on the ground can use to address those inequities. But we also do things like trainings, and we've developed a number of tools that can be used for that. So as I mentioned, the focus today will be mostly on the data tool. And you can see a QR code there on the screen. Feel free to use your smartphones to scan it, and it will take you to the data tool so you can explore as we move along the presentation. Okay, so as I mentioned, the Health Inequalities Data Tool was launched in 2017 and is Canada's primary health inequalities monitoring platform. It's available online, it's searchable, it contains publicly available data that can be downloaded by anyone. It currently contains more than 180 indicators related to social determinants of health and health outcomes that can be disaggregated for up to 13 population groups. We've had a number of updates to this data tool. The most recent update was in late 2023. So out of those 180 or so indicators that are contained in the data tool, we wanted to see how many of those we could disaggregate by Métis identity. And this was in response to discussions that we had with MNC over the past year in particular. And what we found is that out of the 180 so indicators, 131 can be disaggregated by Métis identity. And these indicators cover everything from health status to health determinants, and things like mortality and life expectancy in terms of health status, and a number of health determinants that you can see in the first row there. So where possible, we try to disaggregate indicators at the individual level, and that is the case for the majority of the 131 indicators contained in the data tool. Nonetheless, there are some indicators that can only be disaggregated using ecological stratifiers or area-based measures. So this is normally a geographic area where at least 1 out of 3 respondents identify as Métis. I mentioned also that in order to perform the comparisons that allow us to identify those inequalities, we need to pull sort of a number of years of data together in order to get the necessary number of observations to disaggregate the data this way. So in the majority of cases, this means combining about 3 cycles of data when we're using administrative data sources. But when we're using surveys, that usually requires combining 4 or even up to 5 years of data. Lastly, I should mention that all of the indicators contained in our data tool can be viewed, can be disaggregated by sex, and can also be viewed from a live course perspective. So we can look at things for children, youth, adults, seniors, as well as men and women. So we thought it would be useful to do a bit of a mapping exercise against the report that was developed by MNC a couple of years ago, which contains a section that outlines the Métis social determinants of health. So what you see in the table there are those, on the left side, are the determinants of health that have been identified by this report. And then the column on the right with the check marks, those are areas where we think our indicators have relevant information. I believe some of these presentations will be circulated. For those of you who really want to drill down into the data, we do have an annex at the end of the slide where we outline all of the indicators for each of these. This gives you a bit of a bird's eye view in terms of the areas that are covered. Similarly, the MNC report also outlines some areas for programming and that requires some additional supports. Same exercise, so those are in the column on the left, and then the column on the right with the check marks are again areas where we think our data can inform those topics. So that was a bit of a bird's eye view, but just to give you a better sense of some of the data that we have. So out of the 180 indicators that are in the data tool, 131 that can be disaggregated by Métis identity cover areas such as healthy behaviors, and that includes physical activity, fruit and vegetable consumption, and so forth. Things like employment, whether people are currently employed, the amount of stress that they're subjected to at work. We also have some data around access to healthcare services, whether they have access to screening and preventive services, whether they have contact with healthcare professionals. And then things like socioeconomic status, particularly looking at income. So we have data on median after-tax income, low-income families, seniors living in those families, and children in low-income families. So this is just to give you a sense of some of the data that we have. So the next couple of slides give you some examples of what kind of data we have, how it can be visualized, how it can be used. So this slide is looking at social determinants of health and Métis identity. And these follow a life course approach highlighting inequalities in health determinants for children. So the chart on the left is looking at children in low-income families. And so what we can see here is, and we know from evidence that income is an important determinant of health. We know that poverty can have lifelong repercussions for children, making them more susceptible to disease and other health problems, both during childhood and adulthood. So what we see from the data here, and I've highlighted the Métis data here, is that the rate of Métis children in low-income families, as determined by the market basket measure, was 1.35 times higher compared to non-Indigenous peoples. So this is certainly an area where additional attention is required. The chart on the right looks at physical activity, which again, we know is an important component of healthy living, and it's one of the main behavioral risk factors for chronic disease. And so what we see is that while Indigenous peoples do experience some inequalities in this domain compared to non-Indigenous peoples, at least for Métis, we can see that there are no statistically significant differences in terms of physical activity. So, it also allows us to highlight areas where things are going well and where programming may be having an impact. Again, I know that yesterday a lot of the discussion was around mental wellness, so I did want to take the opportunity to highlight that we will have some forthcoming data in this domain. We've been working for the past year and a half or so on a report that will be looking at inequalities in social determinants of mental wellness. We've worked very closely with our Indigenous partners on this report. And we've been looking to work with MNC, in particular with the Technical Health Committee on this. So this is an example that looks at the intersection of mental wellness, which is operationalized here in terms of mean life satisfaction, and the intersection of Métis identity and sense of community belonging in this case. Not sure how easy it is to read what's going on there, but just to situate you here, what's on the y-axis is the mean life satisfaction, so this is a scale from 0 to 10, and the x-axis is looking at years from 2007 going up to 2021. We wanted to look at trends over time, see how things have evolved, whether things are getting better, staying the same. And what we did is we looked at Métis respondents who had a strong sense of community belonging, Métis who had a weak sense of community belonging, and we compared this to non-Indigenous respondents. So what you see up there, the yellow line in this case is non-Indigenous respondents who identify themselves as having a strong sense of community belonging. The blue line right below it are Métis respondents who said they had a strong sense of community belonging. Next follows the red line, which are non-Indigenous respondents with weak sense of community belonging. And lastly, that black line at the bottom are Métis respondents who identify as having a weak sense of community belonging. So a few observations that we can derive from this data. We know that from 2007 to 2021, looking at this data, what we do see is that Métis consistently reported lower levels of mean life satisfaction. This independent of whether Métis respondents identified as having a strong or weak sense of community belonging. Having said that, the gap is quite significant between Métis with a strong sense of belonging and a Métis with a weak sense of belonging, as you can see from the lines, the blue lines and the black lines. Interestingly, Métis with strong sense of community belonging didn't have as much of a gap in terms of their life satisfaction compared to non-Indigenous respondents with strong sense of belonging. But we do see a more pronounced gap between Métis with weak belonging and non-Indigenous with weak belonging, as you can see in the bottom. So this data will be forthcoming. It will be going into our data tool. We expect it to be live within the next 4 or 6 months at the latest. Fantastic. So I'll be brief on this, but I did want to highlight how we approach identifying sort of the key areas of interest where additional attention may be required. So what this slide does is it provides an overview of our methodological process that we followed in 2018 when we put together the Key Health Inequalities in Canada report. So this report looked at 22 key inequalities that we identified through the data and through discussions with our partners. As you can see, there are 7 steps. I won't go into a lot of detail. Suffice it to say that there are 2 sort of key components to identifying or ranking those key inequalities. One of them involves a quantitative ranking and the other one a qualitative assessment. So in terms of the quantitative ranking, what we do is we used two measures to categorize the various indicators that we had. And we use one absolute measure of inequality, in this case, the rate difference, and then one relative measure, which in this case is the rate ratio. We basically compiled all of that data and ranked using those two pieces of information to see which ones are the ones that show the most pronounced inequities. But then we take that data and we go through a qualitative assessment where we ask ourselves a number of questions, including whether the indicators are policy relevant, whether these are areas where we can actually act on, and whether we have strong partners at the PTI level that can help us move the needle. So I won't go into more details. Having said that, those of you who may have followed the QR code to the data tool, there is a tab there with publications. If you're interested in finding out more, I would invite you to follow the link to the report, the 2018 report that looking at the 22 indicators, where you can see more. So to conclude, we're excited to see that we have a number of indicators that are relevant to the work that MNC is leading. We hope that these indicators can help inform some of this work. I think the data tool brings a number of strengths to these discussions. One of them is that it allows us to identify inequalities in health outcomes and determinant, and we can see the groups where those inequalities are more pronounced, and we can do this both at the national as well as the provincial and territorial level, and really measure and identify the magnitude of these inequalities. It also helps us to inform surveillance and research activities, as well as programs to inform decisions and reduce inequalities in Canada. And lastly, it provides baseline data for ongoing monitoring of progress in reducing health inequalities in Canada and allows us to track trends over time. I will be around if there are additional questions. QR code to the data tool in case you want to explore more. Also the email address if you have questions. Thank you so much.
Marcy, thank you to all of our panelists. That was, I have thoughts, but I'm going to save them. I can't give all my goodies away right now, so I got to wait till the end of the day remarks. But it's so important, data and research. As much as I can't stand those phone calls, Joanne, about, completing all our surveys at the Métis Nation of Ontario, household, healthcare, et cetera. Very important to do, because we need this. We need information. We need numbers. We need to understand the needs of our communities. So fill out your love on your Autobot calls to complete your Métis Nation government surveys, all right? Quick question, do we have Heather Logan somewhere in the room? VP, you fancy person? You not yet? She's not here yet? Perfect. So does anybody have any questions for our panelists then, since we have a few spare minutes since Heather's not here yet? Just wanted to see if anyone had, we can welcome folks back up to the stage, but we had any questions for Chelsea or Bobby or Hannes, Nicolas? Yes? Who do you have a question for? Because we'll yank them back up here. Everybody? All right, come on back up then if you want to kind of respond to the questions. Go ahead, Becca. We have a couple of minutes, so before our health break. Sorry, folks, I know you were comfy.
Thanks so much. I'll try to put this into question and not just a rambling statement, but forgive me if I... So I'm Becca Britton, and I work as the health systems advocate for Métis Nation BC, and my role is essentially a bridge between Métis Nation BC and the regional health authority in the interior. So we're really trying to push forward information sharing agreements and data governance commitments with health authorities in BC. And I'm just wondering, in terms of the work that you're doing, if you've run into, what we're trying to do is basically be able to pull disaggregated data based on Indigenous self-identification, and pull data in like really specific areas. This is kind of the dream we want to do, like, you know, how many Métis people are accessing care for XYZ in this area to, you know, this region, so we can direct supports and services there. The issue we're finding is, like, we're working with the epidemiology teams, and the data is just so granular that they're saying, you know, we can't really use it. Just wondering if that's something that you've run into, if there's a way around that, if there's, you know, if that comes back to like better Indigenous self-identification at the beginning. Yeah, I'm wondering if that's that kind of too granular of data is something that you're finding.
Why does everybody look at me?
We know you have something to say.
Can we just turn on the mics up here if they're not on yet?
Not sure if I'm going to answer your question, or I'll just kind of pose some issues. I think one of the things that we need to start looking at when you even look at the data that was shown in the last presentation there is the idea of self-identification and the impact that that's going to have on data that's coming in. And so this is where you need to really create strong agreements with, especially if you're collecting health data through hospitals and all of that. Who are you collecting from? What are you collecting, and what's the importance of this? When you look at self-identification, what I've seen in a lot of different places is that we'll target the most marginalized in order to do that and get that, which will actually decrease our health outcomes of what's going on in order to access funding dollars for these things. So I've seen that happen going across it. The other part too is when you're collecting information in especially emergency room areas, these are individuals who are coming in at very heightened traumatic spaces. And so when you're collecting that, you also need to start looking at, okay, how do we break this down geographically, also economically and so forth, to understand, okay, is it that it's their identity of being Métis that's causing the issues related to going into these spaces, or is it related to poverty? Is it related to gender violence? Is it related to other pieces that are also going in there? So there's intersectionality that is going on in here. So when we're looking at developing these, I think when you, as a community, these are some of the considerations you need to take into place and as a government is, what does the agreement mean, and how do we find ways to collect the data? What is the data that we actually need? And how do we go about sharing and analyzing the data in a way that does not pathologize the experiences of our people, but looks at ways in which provide us the information needed to improve services for our people. So I think that's sort of a balance you're gonna have to try and figure out. Again, that's why the principals started. They wanted to understand this information on our Métis staying 31 days longer within the healthcare system. And the reason why First Nations were staying 31 days longer in Saskatchewan is for uninsured health benefits, that they were getting the money back from the feds in order to support our healthcare system. That's the reason why they're staying longer. I think we can't lie about that because of that funding space. So, though going on too much more of a rant, because I saw somebody shaking their head at me, I will just leave it there for now.
And I'm going to connect you with Dr. Jennifer Walker and Dr. Amanda Fowler-Woods, who yes. Yeah.
Thank you so much.
Thank you.
Thanks.
Support. Yeah.
Any other responses? No? Good?
So, sorry, just,
Yeah,
so
go ahead.
your question was, you're running into like suppression when you're trying to get very specific, you're interested in a specific, say, health intervention type in a specific region. There aren't enough records to actually produce a reliable statistic. The EPIs are saying error bands are too big, we can't distinguish this from another region, we can't give you that statistic. Is that right?
Yeah, it's like the data is either too small, like the data doesn't exist, or it's too small and, you know, they're saying it's too granular, so it's not like a reliable source.
Yeah.
So we're just kind of trying to look at ways to troubleshoot that and come up with maybe like stronger indicators or.
Totally.
Yeah.
I mean, I guess the challenge is like those data were collected for specific purposes, and they're not the same purposes that you're imagining for them, right?
Yeah.
And so like this is what we're always running up against, because none of the data were collected to serve Métis interests ultimately, and that's part of like what we're trying to change with the national data strategy, is that, you know, there are all of these secondary data sources and none of them were really collected with the intention of serving Métis interests. And so like how do you solve that problem right now? I don't think that you can solve it with the existing system. The goal is like long-term, MNBC understands their data-related priorities, their research questions, their interests, and they are our data collection processes in place to inform those research questions. So it's like we're not even doing linkages with, you know, MSP in BC anymore. It's like MNBC understands their health-related research questions, and we're collecting data. We're engaging with citizens and getting responses directly to inform those research questions. I think that's like that's the long-term answer.
And do you see with like Big River, like the platform you were discussing, that kind of dashboard as something then that could support like specifically for health, specifically, you know, if we, I guess like the data wouldn't be collected through the hospital, then it would just be directly through that platform?
I mean, I would love that. I think that there's a really long road of trust building to get there.
Yeah.
You know, no one's proposing that like MNC or any governing member actually own any data at this point, and that's why we built that system with publicly available data. Like, let's test it, let's build some trust, let's see if there's interest on the part of government in using that tool. Maybe the tool actually comes to the government's data set. It's actually locally hosted. There's no uploading, there's no sharing. Like, what is the model that enables that level of trust in the use of these scalable data products? But I would love for that tool to be useful in that context.
And I think the other part too, just to add on, we got to be really careful. Like the data stays with the person, right? So you have to make sure that your citizens are, they have that respect as well. So it's not just across systems that we need to be able to talk into. It's also the individuals need to be able to know that their data is being held in a good way, that they can say, yes, you can use this for these sort of things. Because when you do again, there's a difference between doing a survey that's getting sent to you by a bot and get it done because you're choosing to do that versus you're walking into a system that is taking your data and collecting that data going through. And so you need to make sure that you have really strong relationships across systems, but with your citizens to make sure that they trust that this information is going to in a good way.
Yeah, I like that perspective because we talk a lot about trying to get the data, and like the data should be in the hands of the nation, and the nation owns the data, and the nation, but just, yeah, hearing you speak today, it's like, hey, that's also, you know, we have to really consider like that's with an asterisk of with consent and with trusting relationships with community members. So yeah, that's important. Thank you so much.
Thank you.
Awesome, Marcy. So thank you to all of our panelists. Big round of applause. Thank you so much.
Good job, Hannah.
I know we're running a little bit behind schedule and we are going to get to a break, but before we do that, I did want to invite up one of our sponsors to share a few remarks. So I'd like to invite Heather Logan, VP of Strategic Relationships and Initiatives from the Canadian Agency for Drugs and Technologies in Health. CADTH is sponsoring our upcoming concurrent session on home care, long-term continuing care and palliative care, as well as anti-indigenous racism in healthcare systems and trauma-informed care. So welcome, Heather. Thank you.
Good morning. It's such an honor to be here. Honestly, I didn't think this would be possible as we started our work and reconciliation a year ago, so it's just an honor. Thank you for allowing us to be here. Good morning et bonjour. My name is Heather Logan. I'm a little nervous. Again, this is a real honor for us to be here, so I've made some notes so I don't forget anything. I hope you'll just bear with me. So we are humbled to be here and honored to be able to share the stage, even just looking at the speakers on the last panel. What an incredible group of speakers and an incredible opportunity, even for just a few moments today. So I want to recognize the Algonquin and Anishinaabe Nation and the chosen home of the Ottawa Regional Métis Council, whose traditional unceded territories on which we're gathered today. As an act of reconciliation and recognition of the traditional territories, rights, and diversities, as an organization, we recognize and acknowledge those for Métis, First Nations, and Inuit peoples and communities. and have begun to, that are harmed, continue to be, and have been harmed by Canada's healthcare systems. We are a nonprofit organization designed to providing information to decision makers to help them make better evidence-informed decisions. In the spirit of reconciliation, CADTH is committed to addressing the inequities and realities of Métis, First Nations, and Inuit peoples and communities, and to develop, to support where we can your priorities. Many speakers at the forum, I've looked at your agenda and it looks absolutely amazing. We have two of our staff here to take in every ounce of learning that we can. Emil Reddy, who's at the back and can put his hand up, who helps with our work on inclusion, diversity, equity, and accessibility, and Victoria, who will be here this afternoon, who's our Indigenous strategic partner to assist with reconciliation and guide our organization. Many of the speakers have talked about the importance of planning home and community care for older adults. As the speakers you're here in the plenaries this afternoon, and I know through the entire session, we realize that this is a priority for Métis, First Nations, and Inuit peoples, and for non-Indigenous peoples across the country. Our demographics are shifting, and we need to do better to help people age in place. We are actually starting some work as an organization on aging in place. We're at the information gathering and learning stage, and we'll be setting up meetings with decision makers to understand where their concerns are. And we would be honored if there is anybody in this room or any people in your community that you think would like to share perspectives with us and help us understand and reflect their realities, your realities. Finally, we're excited to learn from the presentation. I'm going to a plenary on aging in place that's coming right after the health break, and we're really excited to be able to learn with you. There is much that we don't know, and we're excited to be here together with you. When we heard about the forum, we thought we just might be a sponsor, but to connect a priority that we're hearing from decision makers and to see how much of a priority it is for your community is just such an opportunity. So I hope, please come and talk to me if you have questions. I'd love to meet people, and I really, truly look forward to learning from you and to maybe continuing the conversation after today. Thank you.
Marcy, thank you. Thank you so much, Heather, for those lovely remarks and for joining us here today and sponsoring our forum. So we're going to take a break now. I just want to remind folks of the plan for our concurrent session that's coming up after our break. In the ballroom, there's going to be presentations on anti-Indigenous racism in the healthcare system, as well as trauma-informed care. In room 210, there's 3 amazing presentations on Métis perspectives, on home care, long-term continuing care, and palliative care. And in room 209, Minister Marg Friesen will be talking about advocating for Métis people with disabilities. So let's take a break until 11:10 if we can, with a firm start. 11:10 a.m. It's about 15 minutes. Grab a coffee, grab some snacks, and then we'll see you all at 11:10. Have a great break, everyone. Just a quick note that all the snacks are outside. If you're saying, what the heck, where's the food? Apparently it's outside, so head that way. Just a reminder that we're going to get started in a few minutes. So if you're hanging out and you don't want to hear about anti-indigenous, I don't know why you wouldn't, but if you're not wanting to hear about anti-indigenous racism in the healthcare system or trauma-informed care, you should make your way to the concurrent sessions and rooms. So T-minus 3 minutes for our session start. You gonna play for 3 minutes? I think you can wait. I would wait, yeah. Okay, so we're gonna get started. And as if folks haven't, that's not the right deck. Oh, that's the overview slide. Perfect. So if we can pull up the anti-indigenous racism in the healthcare system slides, that'd be fabulous. There they are. So as if folks haven't heard enough from me, I am actually going to give a talk now to boot. So it's actually my true and great privilege to be able to do so. So I'm going to stand up here, I think. So we at Weaving Wellness Centre have been very fortunate to be working with the Métis National Council as well as the Métis governing members on two projects. And the first project being anti-indigenous racism in the healthcare system. And so our team and my colleagues, Sandra Gosling and Kimberly Jordan here, we've been working with the governing members to explore resources, projects, initiatives, challenges around pockets of funding related to AIR, as well as trauma-informed care. And so this is just an overview of what I'm hoping to chat about in the next 20. I was like, whoa, I'm gonna take the whole time. In the next 20 minutes. But we do have a fantastic video from the Métis Nation Saskatchewan that we do want to show. It's about 10 minutes. So I'm gonna kind of like rein myself in as much as I can, so make sure that we get to watch the full video. So the Weaving Wellness Centre, we've been talking about Weaving Wellness just as to highlight, because we've come onto this project as consultants and facilitators. We do a variety of different things, including individual psychotherapy groups, crisis response and debrief work, consulting facilitation. We're a training clinic, so we have a number of Indigenous students who come and do placements with us, social work placements, Master of Arts or Master of Counseling placements, and various education and training and program and resource development initiatives. This is our amazing team. I want to acknowledge Riley Gooden, who is a citizen of the Métis Nation of Ontario, who acted as a co-facilitator for a number of these engagement sessions, and our amazing graphic designer, Elise St. Germain, who's also a citizen of the Otipemisiwak Métis government, who brings a Métis perspective, worldview lens to everything that we do and translates it into the most beautiful imagery possible from we're biased, but we think it's great. So in terms of this project, to advocate for fair and equal treatment of Métis people and their experiences within the healthcare systems, federal funding was acquired from Indigenous Services Canada, and Health Canada to address anti-Indigenous racism in the healthcare system, and that funding pocket was from 2021 to 2023. We were contracted to work with the governing members around exploring their current programs and services, identifying successes across the Métis Nation, exploring current gaps and systems, as well as program gaps and other needs that exist, and then of course to produce a final report that details recommendations specific to anti-Indigenous racism and trauma-informed care. And so just to say, we're presenting in collaboration, not on behalf of, but we're just showcasing the work of the governing members in these presentations. We take no credit for the amazing things that they are doing. And there are members from the different governing nations in the room who will also assist or address any questions that you may have about their specific programs. And if they're not here, we will help make that connection so you can learn more about their phenomenal work. This is an overview of the project. So we've collected various resources related to anti-Indigenous racism. We've held engagements with Métis Nation staff and stakeholders from December until they're actually ongoing. We have a few more to do. And so this today is a preliminary high-level report back of the preliminary analysis of what has been shared with us. So just to note, the results have not been fully validated yet by the governing members. That will be occurring and ongoing as the final analysis is completed. And I've already mentioned that the governing members are more than happy to talk about their work. So I know that we heard from MNBC yesterday about Naomi's principle and Naomi's story, but we also wanted to include several quotes to really start to tell the story of Métis people's experiences and racism within the healthcare system, and the way that we thought we can add to that narrative and build that narrative, because it's not a narrative that is not talked about enough. We don't hear enough about these experiences, and so we've pulled many quotes into our presentation. And so if you want, I'll read aloud some of them, but we also, if I'm yakking, please do read the quotes on the slide as well. But this one came from Métis Nation, British Columbia. This is about Naomi. So we've already heard quite a bit about Naomi's story. I'm going to go to the Otipemisiwak Métis government. So a woman's partner abused her. Just as a note, as a reminder, this is obviously quite a heavy and impactful topic. The wellness room is available. Please do whatever you need to do to take care of yourselves as we read these stories aloud. So a woman's partner abused her, and police assumed she was drunk because of the brain damage she experienced from a violent partner. When she dealt with victim services, they were very violent with her. She had to stay in a motel, and they arrested her because she didn't want to testify, and she wanted to go back home and live with him. Another story we heard from the Métis Nation Saskatchewan was that in rural hospitals, they're finding a lot of racial tension in the community and a very large need for support. The Métis Nation shared a story about a client who was 31, had gone to the emergency room with a lot of pain. She was female and Métis and was told it was a cracked rib and to just lose weight. She didn't get better, went back again. They told her, nope, you pulled a muscle. Finally, she said something was not right. She visited her mother down south and then found out she had stage 4 ovarian cancer. The client came onto this worker's caseload because she didn't know what to do, but she wanted to meet with the doctors to tell her story. So again, very upsetting experiences that our community members are navigating and living with and experiencing harmful care. And so when we talked with the governing members about the overarching anti-Indigenous racism initiatives, these are some of the shared initiatives across the governing members. So we've seen they have built, they've retained and developed patient advocate and support workers. They have resources and supports for complaints related to AIR experiences. They've researched documenting experiences of AIR and pathways forward, cultural safety and AIR training that have been developed, and healthcare navigation resources and toolkits. And when we look more specifically at each of the governing members, so when we look at MNBC, again, there has been amazing work done around Naomi's story. They also have patient advocates, health equity manager, ombudspeople office, complaints process guidebook that's been developed. They're working on the HSO standards, which we heard about this morning, and the Métis Health Experiences program. When we look at one of their quotes, patients often don't feel safe accessing these processes. We've seen huge success in providing invitations and information. People are responsive and do want to share their experiences when they are invited to do so. When we look at the Otipemisiwak Métis government, some of their AIR initiatives have included midwifery expansion courses with, oh gosh, I didn't practice this one, Kihu Awasis Wakamik. Am I close? Yes, June? Okay. Métis birth worker mentorship programs, again in partnership. Research on the experiences of self-identified Métis in Alberta emergency rooms, as well as community wellness advocate. The Otipemisiwak Métis government shared it was a complete 180, talking about a client, 180-degree turn of a scared, angry, distrusting young man, and now he has his family. It's become a cascade of support. It started with just visiting and connecting him to a kokum or a grandmother. We've been strong at pulling in last-minute supports to provide to families, including accommodations and travel, so folks can be with their family members in hospital. So again, very clear, impactful outcomes from this funding and from the initiatives that the Otipemisiwak Métis government is leading. When we look at the Métis Nation Saskatchewan, again, we see that they have patient advocates, they have a mental health team, cultural safety framework that's being developed and is in progress. There's a video series that they have developed. health and various different engagements and conferences, elder and knowledge keeper supports in healthcare settings, and Métis mental health and addiction patient support worker programs. In terms of their sharing, they offered, what frontline workers are hearing is that patients are finding value in patient advocates and navigators, especially for folks traveling from far away. They provide support in accessing services, language supports, being a friendly face, helping to schedule appointments, etc. The value that patients feel will only grow more as time goes by. So if we can play the video from Métis Nation Saskatchewan, that would be amazing.
Hi, my name is Demi Neufeld.
I'm Annette Montgrand.
I'm Donnie Elkrow.
Terry Hansen-Gardner.
My name is Dean Herman.
Hi, I'm Sally Workman. I'm from Prince Albert, Saskatchewan.
I was diagnosed with cancer 10 years ago, and that's where I saw that Métis people struggling.
I had to go on leave from work, so I didn't have an income, and I know I had to travel, and just paying for fuel was a lot.
As a Métis, now that I'm not driving, I have to rely on one of my grandchildren to bring me to the city.
I had to wait 45 minutes for an ambulance because there was no ambulance in Beauval. I had to take my belt off my pants and I had to MacGyver it. Good thing I watched movies, and the doctor said that's what saved my life too, was stopping all that blood.
I can't remember the total hours, but the kilometers I had to drive in 10 months was 60,000 plus.
My cancer doctor says you have to go home and go back and get work with your family doctor. I said, what family doctor? We don't have family doctors up there. You're coming and going. There's no consistency there.
Like this one lady waited all day to get in, and she said I was here early. And she said, I'm going home now. Can I use your phone? So I let her use my phone, and she was going home to Shelburne. And she didn't get to see no doctor, and she was sick.
We need more sober homes in Saskatchewan. There's so many people crying for help that need help. There's 16 people on the waiting list to get into the home where I'm at. 16 people, and they need another home for those other 16 people that wanna get better, you know what I mean?
I am a proud Métis. The government is so focused on First Nation, and they're getting so much more than what we're getting as a Métis. I don't have the same privileges in getting the care that I would need medically.
I haven't had any bad or negative issues along the lines of being Métis going into the healthcare system. But like I said, I've witnessed other Métis people and Aboriginal people totally getting treated differently. I see that quite often in anywhere I go, actually.
With a lot of our people, with their addictions and whatnot, sometimes you get painted with the same brush.
Well, when I first went to the hospital there, I had dry, thick blood all over my leg. And the surgeon walked in there and said, how come nobody's washed his leg? They looked at me with disgust. I looked like I was a heavy addict back then, though.
They kept asking me if I was a drug user and if I drank, and all because my veins were skinny and they were rolling veins. So they just assumed that I was that person.
If I need certain equipment for my health as a Métis, I'm responsible for that.
I went to 3 different places, never got proper check. And when I got sick, I was diagnosed like I had tonsillitis when I didn't. I had to plead to them that something else is wrong before they did any blood work on me.
I felt those eyes on me from the nurses, like they left me 4 days without cleaning the blood off my leg or helping me to the bathroom. And all they did was feed me with pain pills and morphine.
And they're not looking deep down. They're only looking at front, what they see, and they don't like it, and that's it.
But when you go in and tell them something's wrong and you don't get proper care, a diagnosis that you should have got right off the bat instead of dragging it on.
I grew up in a remote community in the northern Saskatchewan, Pine House, and we were very close. We're very close people, loving, respecting each other.
It is how we were raised, to be respectful. And we never could speak back to anyone who was older than us.
Like we respected our elders. We were taught to respect them.
It probably comes with that territory of being, being respectful, and you don't talk back. And you definitely didn't ask questions.
And I just feel sorry for the elders that don't speak English, because what can they do? It's really sad.
The key is the language and the trust. The doctors need to be able to communicate to their patient in the language that is understood. We're not doctors. We're not nurses. We're not in the field of medical.
They're already scared being in the system, especially struggling through cancer. They need that respect for someone to talk to them in their language, to make them understand. And if they're struggling with the system, to make sure that that's taken care of.
Whatever it is that's wrong with us, make it simple in letting us know what that is and what you have to do to make it better for us. Or what can we do to help you to help me?
The other doctor, I think, was too negative for me. I trusted him, but I didn't like how he spoke to me. Well, he didn't explain it plain enough for me. He put it in his terms, and that was it.
Patients also need to ask questions. If they don't know what it is they've been given, before taking it, ask those questions. It's so crucial.
And I was talking about going through Métis Nation for financial help. Then I mentioned it to the social worker at the hospital, and then we got into it that way. But if I wouldn't have mentioned anything, that wouldn't have happened.
Ask about the self-effects, what you can expect. Ask about how long you should be on this same medication before it becomes addictive. These are the important questions, and they need to ask. They shouldn't be afraid. It's their life they want to save. It matters to you. Don't just take whatever is given to you unless you're satisfied.
I wish things would be different in our healthcare system, where you can be treated as any other person, whether you're Indigenous or Black or white. We're all human.
So I mean, what a powerful piece of work to hear those experiences, to hear those lived experiences of navigating racism in the healthcare system. And just to acknowledge also that video was created in partnership with Healthcare Excellence Canada. So this is, such an amazing example of, what we've been talking about, which is building these partnerships, building these relationships, working in collaboration and at the direction of governing members to produce powerful and amazing pieces like this. So just to acknowledge in Healthcare Excellence Canada, as well as the Métis Nation of Saskatchewan for that work. When we look at the MNO's AIR initiatives, there's a variety of different things that are happening here within the MNO. So transitioning from home guides, outpatient ombuds programming, MNO regional online resource libraries, frontline AIR training, compassionate companioning, online training modules, exploring Métis health and wellness research, scoping reviews, circles of knowledge where there's networking, relationship building, knowledge translation, etc., across partners and agencies, provincial events and tables to do that knowledge exchange work, and two patient advocates also within the MNO to help and support citizens in healthcare settings. And when we, listen to the MNO, they share with us that to have people to be the connecting link is helpful for expediting referrals and services and to promote smooth transitions. It takes a load off of staff. You're connected to the province through one library of information. I learned a lot from the anti-racism and bias presentation, and I learned more about the MNO through this exact same presentation. When we look at partnerships and collaborations, the governing members talked about the importance of connecting with local health authorities, Office of Ombudspeople, also working in collaboration with other Indigenous nations, including First Nations, community organizations, agencies, and programs, being a part of working groups and communities of practice, and again, having those connections with university and research institutions. And that many of the benefits of these types of collaborations, revolve around knowledge sharing, co-learning and training, raising the profile of Métis people. While some of the challenges remain around, competition of resources. We've heard so much about the underfunding, chronic issues with programming, research. I mean, this is sort of really a key theme, right? And so these general pots of funding where there's high competition, but not that lens around equity and distinctions-based care or Métis-specific care is a challenge. Relationships are not necessarily always reciprocal, and there is an ongoing need to recognize that Métis governments are self-governing and that they are self-determining around what their needs and priorities are. And that relationships take a long time to build. So, for any partners in the room or agencies or government folks, sometimes coming up and expecting relationships to boom, start right away today, that may not necessarily be the case. It takes a long time. Trust is important. Colonial harm is a real thing. There's a history of injury, right? And so we have to do and build relationships with diligence and with responsibility and care to ensure that they are mutually beneficial. I'm just going to go through that one because I want to talk about data indicators. So when we look at data and what's being collected, MNBC has added Métis-specific identifiers to the First Nation Health Authority's complaint process. And so gathering statistics, working on the AIR data strategy, teaching the system to interpret and accept Métis ways of knowing and being within data collection are all important pieces. The MNO has engaged in tracking resource and knowledge product distribution. MNS has been focusing on gathering impact stories on the patient advocate and patient support worker programs and developing and implementing data governance framework and processes, which we heard about this morning. The Otipemisiwak Métis government has been engaging in a review of macro level trends and looking at hospital administrative data, including things like number of caller complaints, informal qualitative feedback, as well as intake data. And some of the data challenges again are that these numbers don't always necessarily capture the Métis people's experiences. And so that's why we need really innovative, knowledge translation products to understand and to deepen, but also to engage in other types of, I think, research to capture those stories. There's often not enough time or funding for data collection and evaluation. Someone shared with us there was hardly enough funding to run the program, let alone enough time to evaluate the program itself. So even when we say we apply a Métis lens on data, this is not coming close to what we're seeing from our reports. The In Plain Sight report shows 50 to 60% are having racist harm in accessing the system, but from our question set, our rates are higher than racialized minorities and non-Indigenous communities. So there continue to be gaps, right? And this is the importance of governing members being able to have self-determination around those data processes. Funding challenges, there are many. So not enough time. All of the governing members talked about delays in receiving funding, not having enough time to implement programming, the expectations of what was supposed to be done with that programming within funding parameters and timelines as being very difficult or unreasonable in some cases. There was also turnover with other provincial health authority and agency staff, which then results in breaks in communication, breaks in relationships, and then we kind of hit the reset button, right, on that relationship building work. The amount of funding was limited, the amount of what the GMs could do was limited, also based on the funding limits, and that separated parameters of funding did not necessarily align with the nature or work of Métis values. And so again, there's this sort of box being placed on Métis Nation saying, here's your funding, do this, but it's not necessarily reflective of what the needs of community may be. Lack of flexibility around expenditures and how monies can be used, and that, application processes, proposals were quite cumbersome, for example, with Health Canada, but that Indigenous Services Canada funding did arrive quicker. And so, all of these things go into and impact the type of work that governing members can do, and yet they do amazing work, given all of the challenges that they're presented with. And when we're talking about addressing a health system that is so massive without specific air money, it makes it difficult to do anything. We're not going to fix racism within 17 months. Short-term funding getting delayed with delivery adds additional stress and pressure to the work. There's a lot of turnover of staff, breaks of communication. It takes time to develop these partnerships and communicate culturally appropriate environments within the healthcare system. When we look at some of the successes of AIR, though, and there were many, some of the key ones included creating safe spaces for Métis citizens to connect with each other, creating complaints processes that validate citizens' self-determination around their healthcare experiences and needs, supporting citizens to receive that healthcare that they deserve, building trust between citizens and the system. There's a lot, as a mental health practitioner and clinician, a lot of clients that I work with are extremely distrusting of different systems, healthcare, education, justice, you name it. And so a lot of times it's actually governing members that can help foster and build those relationships in good ways, because our people need to access the systems, right? And so that is a really important success from these types of projects. Ensuring citizen stories are heard and promoting citizens' self-determination around healthcare choices, especially when they're related to difficult choices like long-term care, end of life care, etc. So where does the work need to go? So we heard about expanding patient support workers and programs into rural hospitals, in particular in rural communities. We need more educational materials that citizens can use to advocate for themselves and actually to know how to advocate. I mean, advocacy is a very difficult thing, right? It's for yourself, but especially if you're within a system that has harmed you and now you're expected to advocate for yourself. So that's a very tough thing. More anti-Indigenous racism training for healthcare workers, more research led by the Métis Nations around citizen healthcare experiences, and really the need for Métis elders, knowledge keepers, cultural liaisons to be in healthcare spaces. Last year, our team did a project with La Femme Chifo Tepemsawak around Made for Mental Disorders, and we heard really a lot about how the healthcare system is not set up to support Métis people around end of life. And so including things like access to cultural care in mainstream healthcare spaces, these are fundamental rights and the system is not reflecting that. So more supports for Métis healthcare workers and caregivers, especially because they also are experiencing racism within the system that they work within. And so needing to have more funding for education, burnout supports, debriefing resources for them, and of course, distinctions-based Métis-specific funding. I'm just going to move on. So in terms of what we heard, key recommendations and priorities. So just starting in one of the lower corners. So the need for Métis medical care resources for physicians and nurses. How do physicians and nurses work with Métis people? What do you do? What do you say? How do you engage, right? In culturally humble and safe ways. National Métis Health 101 cultural safety training, again, looking to sort of systems impact work, Métis specific national health standards, cultural safety assessment tool is a need, Métis healthcare worker and caregiver supports, continuing with this work of impact videos, especially around the work of the governing members and how this is creating change. It's creating change for Métis people and their healing needs. Documenting Métis citizens' healthcare experiences, and developing self-advocacy toolkits, also again for Métis citizens, families, etc. So why does this work matter? Well, we always have colleagues identifying as Métis for the first time during these sharing circles. This tells me that they are not feeling safe in their workplace to identify. So how are they feeling safe to identify to their patients or to speak up against racism that they are seeing in the workplace? We have to create more safety in these places and address racism in real time as it comes up. Especially in rural areas, police are unnecessarily being involved, especially with those struggling with substance use or psychosis. You finally connect to folks and help them get support, and then they experience traumatizing care by the healthcare and justice system, and then they are gone, and then we lose them. And so then we have lost that opportunity to provide healing and to provide support to someone in need. A more detailed story in terms of why this matters. The client came onto my caseload because she didn't know what to do, but she wanted to meet with the doctors to tell her story. I, the worker, supported her and sat at a table with about 6 males. We wrote out her story. We told her story from her first ER visit to the very end. It took a lot of strength to do. Some of the doctors were very understanding and some were very standoffish. I asked her, "Do you feel heard?" She looked at every single individual and said, I hope you take what happened to me and do better. And so this is why this work matters. I'm gonna go, just close your eyes for a second. I'm gonna go all the way to the front of the deck because I did skip over a quote from the Métis Nation, British Columbia about Naomi's story and principle. And, oh, are you doing it for me? Yeah, you are. And I want to read this aloud because I want to also make this connection between experiences of racism in the healthcare system and trauma, because experiences of racism are traumatic. And so this is, a very clear connection. And so in October of 2022, Naomi Gladue, a young Métis woman, lost her life after seeking substance use recovery treatment. Naomi was determined to take these first steps in changing her life in a way that was meaningful for her, and with the assistance of MNBC, she attended a private treatment facility as public beds were unavailable. After 10 days in treatment, Naomi died of an overdose at 22 years of age. Naomi was a vibrant, beautiful, fierce protector. Unfortunately, MNBC came to understand that Naomi had experienced culturally unsafe care and is seeking to share Naomi's story to advocate for safer care for Métis people. And so, when we talk about what is racism within the healthcare, what are experiences of racism, that inherently interconnects often with trauma and experiences of trauma for Métis people. And so on that note, I'm going to hand it over to my colleagues, Sandra and Kimberly, to present on the work that we did with the governing members related to trauma-informed care. Marcy.
Is that the remote?
Are you going to sit here? Yeah.
Mm-hmm. Oh yeah, we're going to sit. Hello, everybody. On the note of everyone admitting that they get nervous when they present, I also get nervous, and I don't know what's more nerve-wracking, presenting in front of your boss or directly beside your boss and all the governing members. So we're just gonna keep calm and carry on here. Also, as Tara said, there's a really clear and strong interconnection between anti-Indigenous racism and trauma. So there is quite a bit of overlap between these two projects here, but we'll try, this one is dedicated to trauma-informed care, reviewing the current resources and national priorities related to not just trauma-informed care, but responding to trauma, promoting wellness and life in communities. So yeah, we'll try really hard not to repeat ourselves, but I recognize that there's quite a bit of overlap. And another shout out to Elise for gorgeous slides. I'm just gonna skip these since Tara already did. So my name is Sandra Gosling. I am a social worker and associate with Weaving Wellness here. I do a mix of supporting projects like this. I have both a health and research background as well as a mental health background. So I also provide individual psychotherapy online to those residing in both Alberta and Ontario. I'm also of very mixed European and First Nations ancestry on my dad's side from Northern Alberta, as well as French Métis from the North Bay area on my mom's side. But I actually live in Edmonton, Alberta, so that's my fun fact. Pass it to yourself, Kim.
Hi, everyone. I'm Kimberly Jordan. I am a non-Indigenous associate with Weaving Wellness Center. My ancestry comes from Holland on my mom's side and from Poland on my dad's side. I am a registered psychotherapist in the qualifying stage. So I work directly with clients with Weaving Wellness, but I wear a lot of other hats. So yeah, was part of this project team. And just to say, it was really lovely getting to meet a lot of people that we engaged with virtually in person the last few days.
And the rest of our lovely team. So just to dive in here, so yeah, very similar, as I said, as the Métis Nation continues to assert its rights as a self-determining nation, it is imperative to assess and understand what the current landscape is of Métis-specific and trauma-informed work. So there's another project that MNC has contracted Weaving Wellness to sort of just create that capture of what's currently happening, what programs and services and resources are governing members providing, what's out there, how's it working, what impact is it having, and where else does the work need to continue going. This work also will kind of touch on a mix of both the TIC, specifically trauma-informed care funding initiatives, but our understanding is that funding was a little bit smaller than the AIR funding, so we're also hoping to highlight the other great work that is related to trauma-informed care and wellness that has been funded from other sources as well. So yeah, similar, we're engaged, this is very preliminary, we're still sort of just wrapping up the engagement sessions, this really is just a very quick and preliminary summary of just the things that we heard from those sessions. So it certainly is not fully comprehensive or fully capture everything that the governing members are doing. So if anybody would like to learn more, I highly encourage everyone to reach out to folks directly, not us. Yeah, as I said that already.
So we'll just touch briefly on the differences between trauma-informed care and trauma-specific care. So trauma-informed care is really an approach to services that acknowledges that many folks who access services will have experienced trauma. And it also recognizes the impact that trauma has on an individual's life. And so what trauma-informed care seeks to do is create a safe environment that avoids triggering or re-traumatizing those who access services. So really anything can be, in an organization, can be trauma-informed, from the way that a waiting room is organized, from the way that interviews happen, for the way that intakes happen. All of this can be trauma-informed. And this is different from trauma-specific services, which are services that directly address experiences of trauma. And these can come in the form of, programs, mental health treatment interventions, toolkits, guides, educational and clinical resources. So this project, while we looked into trauma-informed care, a lot of what we spoke about was also trauma-specific care and services. Yeah. So when we started these engagement sessions, how we opened them was we asked the participants, what were their understandings of trauma from a Métis lens. And what we heard very briefly is there was so much variability in the experiences and understandings of trauma of Métis people. But what did kind of connect from all the engagement sessions is that there's still kind of a sense of shame, fear, and stigma around trauma, and that defining experiences of trauma looks different for different folks. And that another thing that came out of this conversation was just a need for more education and anti-stigma about what is trauma. So one of the kind of key quotes that came out of this was, for a number of generations, Métis experiences have been hidden. A lot of intergenerational and colonial trauma has been hidden. It's great that more experiences are coming out into the open, and there's a lot of harm around that too. This is why wraparound supports are really important right now. We use the term trauma-informed care because it is key in healthcare right now. But is that really a relevant term for Métis people and Métis communities? So yeah, something that was really interesting that came out of this conversation was just talking about language and what language really resonates with Métis folks. And perhaps some folks don't actually have the appropriate language to even be speaking about this.
Yeah, so this slide here is just sort of a summary of the different ways that folks mentioned that trauma is experienced and defined in Métis communities. I won't dive into every single one because I recognize we're before everyone's lunch, but just some of the key things to, I think, highlight is just how, interwoven all these diverse experiences and definitions of trauma are very much interconnected to that colonial, past and present systemic trauma. And as well, I think a good one to, and how it, that's experienced within communities, within services. And then sometimes in rural communities, for example, those experiences kind of are compounded where, there's also that underfunding and less access of resources. So it's quite complex, and there's certainly many layers and experiences of trauma. So now to dive into the current trauma-informed care initiatives, this is just another overview slide of sort of the key themes that we kind of noticed that each governing member is doing something connected to one of these in a similar yet unique capacity. So we heard quite a few land-based and cultural-based healing programs and local events. Life promotion is certainly key. Wellness workers and programs, financial support to increase access to things like mental health care, including therapy, but also recreational and wellness activities as well. Guidebooks for system navigation and self-advocacy to help try and, prevent those traumatic experiences. And we also heard quite a bit too that, trauma-informed care is kind of this newer adapted concept. So there's a need right now to continue planning and engagement for how something like TIC funding could be best used and prioritized in communities as defined by the communities. So a TIC approach and lens is woven through everything, whether it is actually named, it is in everything that is Métis. So like I said, trauma-informed care is certainly that new buzzword, and whether or not the governing members specifically use that term to capture their programs and resources, it often is certainly is a framework that very much aligns and is quite similar to Métis values and principles and ways of being. So the Métis Nation of British Columbia, they're up to lots. So the trauma-informed care funded projects include monthly Métis health and wellness experience circles, which have been really important opportunities to connect and share stories and experiences within about health and wellness. They're also still kind of in those early stages of TIC planning, but they also recently funded to wellness workers. I also practiced saying this, but forgive me. I said it in my head perfectly. Mioyan workers. I know we don't have a ton of time, so, but there's some other really great work too, including the wellness gatherings that I believe they touched on yesterday, and the crisis line and the suicide prevention training. We initially had a big vision for social workers and elders in residence, but had to pull back and work closer with community and build it out with them. If you do it right the first time, then it will have a phenomenal lasting impact on the work moving forward. So this quote really just speaks to that importance of that community engagement and planning with community, but also it's a great example of how, social workers, what we also heard was a term that community members didn't really didn't like, so that's also why those workers are called Mioyan workers. So Otipemisiwak Métis government, they use their funding to provide these really amazing land-based healing retreats for families and survivors. So there were 3 retreats, one for men, women, and survivors of residential school and day schools. They also have a wellness program with financial supports for that mental health and wellness and cultural wellness, and then a whole bunch of other initiatives, from a life promotion guidebook, a survivor sash, mental health system navigators, a peer support program, community wellness advocacy framework, social worker, cultural safety training, all that. And a huge reason for these retreats, for example, and the survivor sash is that we are focusing on our survivors because we need to identify them. They don't even know they are survivors, and we need to give them that pride back of being a survivor instead of it being so shameful. So this also really touches on too on how something like trauma is really just like that conversation is really just starting to open up in communities. So there is that need for those wraparound supports. So Métis Nation Saskatchewan, we love this photo. The Saskatchewan is beautiful. So again, TIC funded included the Wellness Through Our Lands program, which is a really great, land-based program, patient navigators and medical transportation system, as well as a really cool cancer care guidebook. Some other initiatives include 90-day Métis distinct treatment model, some mobile outreach programs. They're starting to bring on dog therapy, and again, that financial support for mental health and wellness, and mental health navigator, which I believe they talked about yesterday, and a mental health and addictions program.
Can you just wait? Just go back.
Yeah.
I just wanted to highlight for folks really quickly that, again, so where you see it says TIC funded, that's what the governing members have done with the money they've been given. Where you see GM TIC initiatives, that's everything else the governing members are doing themselves and pulling and innovating from different pots of money, right, and creating. And so, if you just imagine what governing members are able to do with adequate funding and support, it truly is amazing. And so just wanted to showcase and highlight the phenomenal work that these folks are doing to innovate and to address needs, even in the absence of substantial funding. So I just wanted to make note of that one piece. So when you see all those additional bubbles, those are other initiatives that are led by them without dedicated funding necessarily.
Here is the cancer guidebook, and then there's also a quote from MNS here that says, the goal is to set up land-based cultural events that bring community together, elders, youth, 2S LGBTQIA+, and find ways to give back to the land and reconnect to their cultural identity in their area and respond to mental health within a community. The conversations that we had about how land-based programs really respond to trauma were super impactful, so we wanted to include this quote to kind of speak to that. And then for our conversations with the MNO, so in terms of their TIC-funded projects, there is financial support for mental health care supports, their funding pot funded for 2 mental health navigator positions, and then trauma-informed mental health service providers. And then the other initiatives that the MNO is doing that have trauma-informed approaches are the Youth Diversion Mentorship Program, Our Brother's Voyage, Intake and Support Plan for Complex Presenting Problems. They also have like TIC delivery framework. Their training for staff is trauma-informed, and then also like education training and relationship building efforts with agencies also have trauma-informed approaches. So we go back to relationship building first, building trust and maximizing the system benefit for the client so they can live well. A big success we had was getting the client to engage with the child welfare system in a positive way. Utilize services we had that allowed her the opportunity to attempt to parent under supervision that later allowed her to keep baby under her care, and CAS is no longer involved. And so this quote really spoke to how the MNO navigators use trauma-informed approaches to develop really, really strong relationships with community members and with their clients, and how that develops a sense of trust that helps kind of create successes in their work.
So, yeah, as Tara mentioned, there's a lot of really incredible and innovative work that folks are doing with quite limited resources. And when we, it's really important to highlight, because when we asked about the TIC-funded specific initiatives, it was only, it didn't fully encompass what everyone's doing. And what we heard quite a bit about the challenge of that was that, it's short-term funding, and something like trauma is quite complex and sensitive. So to put in a program that's probably going to get cut after it's 2 years can be traumatizing in and of itself. So where can things kind of go from here? There's still quite a few program and system-based needs. We heard quite a bit of, still this real want and need and interest in cultural and land-based wraparound supports. This is especially true as we begin to have more conversations about trauma, and as communities start to recognize, maybe I do have some intergenerational trauma and stuff like that. We really can't open those conversations without the proper supports in place. And Métis-led mental health and substance use programming, a center, ongoing community engagement, supports for Métis practitioners, as mentioned in that AIR presentation, so that they can stay good and continue doing good work within a really tricky and still traumatizing system, Métis-specific care models, tools and resources, training and education for non-Métis practitioners on trauma and violent-informed care, more research on Métis trauma, but also Métis wellness, supports to meet basic needs, Someone had a great idea for like a trauma self-care toolkit for citizens that identified, what is trauma, how is it experienced, and how to heal and cope in holistic and cultural ways, as well as I thought this was really important, that time to process and heal, because, a lot of this trauma we talk about is rooted in colonial past and present, and that's over 150 years. It's really hard to change to respond to that in 2-year short-term funding brackets. This was a really important quote, there's no space for healing when those basic needs aren't met. So that also touches on that intersectional aspect of, some Métis citizens are really, really struggling, and they might be homeless or houseless or living in poverty. And it's really hard to kind of engage and heal when their day-to-day is still quite traumatizing in those ways and those basic needs aren't met. There's also a really big need to push for the creation of Métis-led and defined resources and tools that actually align with, the core Métis ways of being, rather than just slapping on a sash on something and calling it Métis. So again, that emphasis for distinctions-based and Métis-led approaches are really important.
So as part of our engagement sessions, we had asked what Métis populations are most in need of trauma-specific care. And this diagram shows all the answers that we received across our engagement sessions. And I think it really speaks to the kind of intersectionality that exists when we're talking about who needs trauma-specific care, and kind of emphasizes the diverse aspects of individuals' experiences and, highlighting the need for trauma care that respects these complexities. So I'll just point out kind of 3 populations that we spoke about in almost every session. And the first was Métis folks from rural and remote communities. What came out of that conversation was just an overall lack of access to mental health resources for those folks. We also had a lot of conversation about elders and how, as Métis folks are aging, they're falling through the cracks in receiving services, and how do we, create more trauma specific care to help those folks. And then lastly, what we heard was that for Métis Two-Spirit LGBTQIA folks, this is another population of Métis people who really do need more trauma-specific care.
So I was alerted, we only have a couple more minutes, so I'm just gonna skip through some of these slides here. Obviously, there's a clear need for that funding piece. No shortage of gifted, talented people desiring to expand. Funding is the problem. Folks are ready to create more innovative programs to meet their citizens' needs. Funding is a huge, huge gap in that. This is great if any partners had some extra funds looking to spend in the short term. These are some pretty doable short-term and immediate priorities that folks identified for resource development. I saw someone take a photo, so now I'm just gonna skip this one and really get to, why does this work matter? Folks don't always know where their trauma is from, but as they come to lean into their identity, they found healing through their culture. So again, this is why Métis-led approaches are so important. Citizens, they always say they want more of the gatherings and programs. They always think of the people that could use more of this. And, at MNBC, folks said, as staff that work there, that validates us. It also fills our cup so much too, to create opportunities for people to be as they are, to support their learning and to see them being proud of who they are. These programs have a lot of impacts on families, not just individuals. Without the funding, we couldn't do them, but we could still do so much more. It's every day. There are notable stories every day that we are helping people.
From MNS, you really see a shift in things with our youth when you take their phone away and put them in a bush for a week in camp. They come out so much wiser, more confident. They're able to do a lot and teach others how to do things. You see the confidence grow. Youth are coming on the land saying, I've never trapped anything in my life, but these smells remind me of something from my past. And we see them making these connections and how powerful and beautiful it is. The importance of relationships cannot be underscored. Those relationships are necessary to support clients and citizens, whatever their needs are, and across populations. It builds more trust for the worker and then the service, and then they're more likely to access it. This is what we heard from MNO. Trauma-informed care fosters a circle of care and relationship that was maybe fractured by the legacy of harm. That's it.
Did it. You did great. Yay.
Marcy?
So we're pretty much at lunch, but since no one else has come in here, let's just work with it. So I don't know if there were any questions, if any of the governing members would like to come up to the mic and speak to anything. If we're in trouble, do it during the lunch break. But if you want to speak to any of your projects, we would love for you to come up and also do that when we have a couple of minutes. I'm just teasing about the trouble part. I hope we're not in trouble. No questions? No comments? Hang on, wait. Eva's coming. That's okay. Uh-oh. No, don't.
I promise I won't. I'm not this short.
Crouch. Hello.
I'm just going to hold it like this because that's easier. Hi, everyone. My name is Eva Habib. I'm with Métis Nation BC. Thank you so much for your presentation. It was really nice meeting with you guys to chat. We had a really good engagement for both the TIC funding and the AIR funding, so thank you again for that. There were a couple things in the presentation I know that we're still validating and whatnot, but I think overall it's really nice to kind of see what everyone's doing across the nation, so really appreciative of the project, and just we're all getting ideas of like what's everyone else doing and how can we collaborate and do more. One thing I was just going to flag, we obviously presented a lot yesterday. There was one piece around the Métis Health Experience program that we have, and so I think one of the comments that was made in the presentation is that we have actually embedded identifiers that are Métis specific into the complaints process at FNHA. And so actually that's the First Nations Health Authority, which in the presentation this morning mentioned is a specific health authority for First Nations in BC. So we're actually not embedded within their complaints process. We've created our own separate process within Métis Nation BC. And then we've informed how to better identify Métis as part of self-identifiers and complaints processes across BC. So I just wanted to make that clarification within the other health authorities that's not First Nation specific. So just to clarify, First Nations Health Authority is not collecting Métis specific data on our behalf.
Yes.
So just wanted to make that quick clarification. And then our guidebook as well, we shared the name and title of that yesterday. So again, that one's Métis specific. I think it said something about being affiliated with the ombudsperson. That's a provincial body that oversees it, and they have their own specific Indigenous program as well. But our guidebook is separate from that. So I just wanted to make those two clarifying points. Thank you so much.
Thanks so much for that. Yeah. Okay, well, I see other folks coming into the room now, so maybe we'll pause here. Again, if you have questions for us, you're welcome to come and approach us. But if you, again, are seeing anything that was showcased in terms of work from the governing members, please approach them and talk with them specifically and directly about their initiatives. So with that, let's take a break, a lunch. We're gonna have lunch now. So if folks want to, slowly make their way to the lunch tables, and then we're going to have a guest speaker from the Canadian Medical Association make a few remarks as they are sponsoring lunch today. And then we will also have our fiddler, and we're gonna integrate some spoons this lunch hour since they are here, and Alicia's gonna teach us a little bit about how to do some hand spooning. That doesn't sound right. We're gonna do some hand spooning as well, and have a bit of a jam. So let's break for lunch, and then we will see you all soon.
was looking for just a plug-in for my laptop, or do I not have one of them?
Hi, folks. How's lunch going? Oh. I was like, is everyone alive and well? We're all eating. Well, listen, let me ask again. How is lunch going? There it is. So the reason I'm saying this is because we are thrilled to have our lunch sponsored today by the Canadian Medical Association. We have Dr. Paula Cashin here, who is going to offer some remarks. Dr. Cashin serves in national physician leadership roles as Vice Chair of the CMA Board of Directors, Chair of the CMA Appointments Committee, Board Director of the CMA Foundation, and a council member of the CMPA. Dr. Cashin is going to present some slides. If you can please offer a warm welcome for them and expression of thanks for sponsoring our lunch today. Marcy. There you go. Clicker is right here. And you have to point it at this monitor.
Which monitor? Right here?
That monitor, yep. Forward and back.
Forward.
Green one. Green one is
I'm
forward.
only going forward, yeah.
Going forward. You can also sit if you want, but it's comfy. Okay?
Yeah.
Perfect.
So good afternoon, everyone. Thank you so much for the opportunity to speak with you today. As I was introduced, I'm an Indigenous board member and elected Vice Chair of the Canadian Medical Association Board of Directors. The CMA actually has 3 Indigenous board members. So myself, Dr. Alika LaFontaine, who many of you will know as our past CMA president, and Ms. Santana Hernandez, who's a medical student out of Calgary. We have been guiding the apology work that's being done at the CMA, and that's what I'm here to present about and discuss today. Before I start, I'll just introduce myself. So I'm a Mi'kmaq physician from a small rural town on the west coast of Newfoundland. I'm a member of the Halibu Mi'kmaq First Nation. I'm the first Indigenous radiologist in nuclear medicine in Canada and the first Indigenous board member at the CMA. As part of the CMA's journey of reconciliation, we are committed to issuing a public apology for the medical harms caused to First Nations, Inuit, and Métis peoples. The apology will be made on behalf of the CMA as the national voice of physicians. As the CMA prepares to deliver this apology in June of this year, we will listen and learn from Indigenous groups to shape not only the words we will deliver, but also our action plan and our overall reconciliation journey. The apology will outline the CMA's role and the role of Canada's physician in past and ongoing harm to Indigenous peoples. The apology will express our collective desire to improve the health outcomes of Indigenous peoples, and it will reinforce the CMA's commitment to reconciliation. Importantly, this apology will be offered in the spirit of humility. We hope that honest reflection on both the past and the present will help facilitate healing, as well as bring about meaningful change in healthcare and in the relationship between physicians and Indigenous peoples. But trust must come before reconciliation, and building that trust starts with taking responsibility for the past. The CMA knows that we must recognize the truths of the trauma inflicted, as well as the ongoing harm and racism that still occurs in healthcare today. Accepting these truths is essential if we want to support healing, improve Indigenous health, and strengthen the relationship between physicians and Indigenous patients. We know this will require many uncomfortable and painful conversations, but leaning into that discomfort is part of the process for the CMA and Canadian physicians. The CMA also recognizes that the medical profession's history aligns with Canada's history. This includes the devastating impacts on Indian hospitals, medical experimentation on Indigenous peoples, systemic racism, and the neglect and abuse that continues to this day. To better understand the CMA's role and the role of physicians in these harms, both through action and inaction, we have undertaken an in-depth look at more than 150 years of CMA archives. We're also reviewing the Canadian Medical Association Journal in partnership with the National Collaborating Centre for Indigenous Health. We're reviewing the CMA's media, social media, code of ethics, governance, and human resources structures. We are looking at parliamentary records of harm caused by the CMA as the national voice of physicians, and looking at external and medical reports detailing Indigenous-specific racism and discrimination. And the CMA is also importantly supporting and encouraging national, provincial, and territorial organizations to explore their own organizational truths as a step in their reconciliation journey. So the commitment to an apology is part of our response to the Truth and Reconciliation Commission of Canada's calls to action. But it's also a response to a call to action made by the CMA's first Indigenous Guiding Circle, a group of First Nations, Inuit, and Métis leaders, experts, and knowledge keepers who came together in 2022. We have since convened our second Indigenous Guiding Circle, who we see here in this picture. With their guidance, the CMA is working towards a new Indigenous health goal, which has been instrumental in shaping our approach to addressing past and ongoing harms. And we hope to achieve a transformed health system that is free of racism and discrimination, a health system that upholds Indigenous peoples' rights to self-determination, one that values, respects, and holds safe space for Indigenous worldviews, medicine, and healing practices, and a health system that provides equitable access to culturally safe, trauma-informed care for all First Nations, Inuit, and Métis. And the CMA continues to build on steps that we've already taken in our reconciliation journey. So for example, we've given numerous grants and scholarships to support Indigenous health and Indigenous students. An example is the CMA Foundation that provides support to the Indigenous Physician Association of Canada, which helped them implement a mentorship program for Indigenous medical students and residents. And secondly, we've built awareness of the impact of colonization on Indigenous peoples through education projects such as the film, The Unforgotten. So this is the first in-person consultation and information session with Indigenous groups about the apology. We are hoping to build on a series of fireside chats hosted by Dr. LaFontaine last spring. The fireside chats included conversations with Indigenous leadership, including Métis National Council President, Cassidy Caron, and those are available online if anybody wants to listen to those fireside chats. As we prepare for the apology in June, we are making sure the words we deliver are backed up by action and that we can hold ourselves accountable for the commitments that we make. And a focus on the action component of our apology has been a clear message from our Indigenous Guiding Circle. As part of the CMA's ongoing commitment to reconciliation, we will apply an Indigenous lens to our work, and we will be guided by Indigenous voices on our journey forward, including Indigenous staff and the Indigenous Guiding Circle. Also guided by Indigenous peoples, we will push for change to transform the health system for First Nations, Inuit, Métis peoples to advance their health and well-being. The CMA will explore what it can do to prevent the ongoing harm to Indigenous peoples. And we will explore how we can address historical injustice and foster reconciliation. I'm confident that the CMA can be part of transforming the relationship that physicians have with Indigenous peoples through these actions and others that we hear during our engagement with Indigenous groups. And that is one reason why I'm so grateful to be speaking here today. The CMA needs to hear your voice. And these changes will also require us to build trust that has been eroded by the past history of mistreatment of Indigenous peoples in the healthcare system. Again, thank you so much for the opportunity to speak here and be here with you today. The CMA is committed to listening and learning and hearing your voice to openly engage with you further. And we can be reached if anybody wants to reach out at indigenous.health@cma.ca. And we'd also like to know if you're interested in holding conversations even in smaller groups. Just let us know, just reach out, and we'll certainly work to make that happen. And if you'd like to hear more details about the CMA's work in Indigenous apology and other Indigenous health, this information is on our website. So again, thank you so much for having me here today. And if anybody has any comments or questions, we're certainly open to hearing those right now. And if there's no comments from the group, we're going to be around for the afternoon, so feel free to reach out to myself. And we also have a CMA staff member, Winona's here with me as well, so we're available to talk to anybody if they want. Hey, you're a quiet bunch, or the lunch is really, really good. One or the other. I suspect it might be the lunch. Okay, thank you so much.
Just while everybody's still eating and everything else, sorry, you won't hear from me again. You don't have to put the lights on, that's fine. Nobody wants to see my face. I just want you to know that myself and Dr. Gable just had a quick conversation with CIHR, and I was talking about the funding dollars that are going in for Indigenous health research across the country and that these statistics are coming forward. They told us that there's going to be a webinar that's open to the public on March 26th of 1 to 2 p.m. Eastern Time. And if you go on their website and you look down on Indigenous Health Research Investments at CIHR, this is where you're going to be seeing the amount of dollars that are being invested into Indigenous health research across this country. But you're also going to see the breakdown under Indigenous, First Nations, Inuit, and Métis. And this is, I think, is important for this room to be able to go in there, especially the technical committees, to go and see how low the dismal of the funding and the reason why we continuously fight for this, but what it means. When we look at distinctions-based research, and the other part too is how do you begin to advocate for national Métis calls of health research going across the country? What does that look like? And the other part I do also want to say is that the Chapter 9 for the Tri-Council is being revamped. And this is a really good time because OCAP is embedded within it. We need to embed Métis principles within the Tri-Council's Chapter 9 so that all researchers at university levels have to follow through with this, and it gives them teeth and accountability. Anyways, I know you're all busy eating. We can talk about that later. But March 26, 1 to 2 p.m., I really do think it's important that everybody in this room who is in health research go on there and see what CIHR is doing to see the dismal numbers that are happening. Anyways, thank you.
I just want to take a quick moment to thank Dr. Cashin as she's walking out the door. Thank you, Canadian Medical Association, so much for sponsoring and for your remarks today. Take care, Marcy. So we've got just a quick announcement. We've got a couple of admin things that we're working on for our next session. So we're going to give everyone a few extra minutes to hang out, enjoy, visit, chat, and we'll probably get started in about 5-ish to 10 minutes, okay? Don't go anywhere. Really important presentation. Just enjoy 5 extra minutes of lunch. See you soon. All righty, so I think we're gonna get restarted for our sessions with this afternoon. Before we dive in, we just wanted to also take a moment to acknowledge that some of our sessions this morning, really touched upon some difficult topics. And so we wanted to offer to anyone who is needing or wanting to connect with someone for a one-to-one check-in. Kimberly Jordan, who is a registered psychotherapist, will be available in room 209. It's a confidential space. If you just want to go have a chat, have a check-in, you're more than welcome to do that. She's available for the next 30-ish minutes, but you are welcome to approach myself or any member of my team if you'd like to have a conversation. We also want to put up a slide just to offer up to people and remind people that there are wellness supports available via phone if you'd rather have a conversation. So these are the Métis-specific mental health and wellness supports available at the Métis Nation British Columbia, Otipemisiwak Métis Government, Métis Nation Saskatchewan, as well as the Métis Nation of Ontario. So we'll leave that slide up for a minute, just in case anybody would like to write that down, have a call. And again, my team and I are also here to provide support for anyone who is feeling impacted by the conversations today. On that note, I thought we could maybe just have like a bit of a wellness moment to go into our sessions for this afternoon, to just recenter ourselves, reground ourselves. This is the reality of talking about Métis health and Métis well-being, is that these are not just numbers, these are not just statistics, that we are the people that we are talking about, actually, and that we come with journeys, and journeys that are difficult and that have been filled with difficult moments in time sometimes, in addition to beauty and amazing moments, but also difficult moments. And so it's very, very, just to normalize this, that it is very, appropriate to be impacted by some of the things that we've been talking about this today in personal ways. So I just wanted to offer to everyone, if we can just have a moment, I know there's a lot of buzz in the room, but if we could just all have like a moment just to take a few deep breaths, just to feel your feet on the ground. Just to, if you have a sash, I actually wanted to offer up, our team has done a lot of culturally specific mental health and wellness development work. And so something that we actually often offer for our Métis clients is mindfully Métis moments. And if you have a sash, if you have some beadwork, if you have a ribbon skirt, if you have a shawl, if you have anything like that, I'd invite you to participate if you like. If you'd rather not, that's totally okay. But to just take a moment to bring your awareness and your attention just to this moment. If you have a sash or beadwork or anything like that, to hold it in your hands for a moment and to just take notice of the beauty of Métis culture, the vibrancy of it, the strength of a sash as all of the threads are woven together, and to just really feel present in this moment and the connection that we all share in this room, Métis or not, that we are all connected in this moment together. If you want to just take a couple of deep breaths, feeling yourself centered and in the present moment, feet on the floor. Hopefully your legs aren't numb from sitting all day long, and just bringing your attention and awareness back here. So again, we have some wellness supports available for anyone who would like to connect. And thank you to everyone who was present and engaged this morning as well. So I'm gonna bring us, we're a little bit behind, but that's A-okay. So I'm gonna introduce our next panel. This is a really exciting presentation. When I was invited to MC, the Director of Health just kept saying to me, this is a really important presentation. And I was like, great, we love partnership building. They're all important, but partnership building in particular is, as we've been hearing, about the amazing partnerships that are in existence and have been built across the Métis Nation, truly, truly important and vital. So I'm gonna invite, so again, we're gonna have 3 speakers, one after the other, and then we're gonna open up the floor for a general Q&A session. So I'll invite, I don't know if all of you wanna come up at the same time, but Avery Steed, who's going to be presenting on working with the Métis Nation, Ryan Chawner, who's going to be presenting on your department's responsibilities concerning health, and Kate Gillis, who's going to be presenting on Métis Nation Health and the 2030 Agenda for Sustainable Development. Come on up. Clicker is there on the thing. You have to point it at the monitor.
Great, thanks. Good afternoon, everyone. So I'll be starting with this presentation, working with the Métis Nation. For those of you that I don't know, my name's Avery Steed. I work as a senior policy advisor in intergovernmental strategy at the Métis National Council. What that means is I work on some of the things that we'll be getting into a bit more today, including the permanent bilateral mechanism and other intergovernmental fora between the Government of Canada, the Métis National Council, and governing members. A little bit about me. I'm a settler person of Welsh, South African, and Irish descent. I grew up on Kanien'kehá:ka territory in Montreal, and I've been working and living on unceded and unsurrendered Algonquin territory for over half my life now. I'm honored to work as a public servant of the Métis Nation and to play my small role in supporting the advancement of Métis rights, interests, and priorities in our work with partners, including the Government of Canada. So just an overview of what I intend to cover, and we'll welcome questions after Ryan, Kate, and myself have wrapped up, is really big picture history of the Métis Nation, the role of the Métis National Council within the Métis Nation, as well as the governance structure and decision-making processes. I'll then move into the Canada Métis Nation Permanent Bilateral Mechanism, so what those words mean, what they're embedded in, which is the Canada Métis Nation Accord, and the structure and function of this mechanism. So just to begin, for those of you who don't know, the Métis Nation is one of the 3 distinctions of Indigenous peoples whose rights are recognized and protected in the Canadian Constitution under Section 35. The Métis Nation emerged during the fur trade in the historic Northwest during the 18th century through a process of ethnogenesis, establishing distinct communities along the fur trading routes that span across the Métis homeland. Through this process, a new Indigenous people emerged, the Métis people, with their own unique culture, traditions, language, and ways of life. The homeland includes the Prairie provinces, as well as parts of British Columbia and Ontario, the Northwest Territories, and the Northern United States. In 2002, the Métis National Council reached the following national definition of Métis, which means a person who self-identifies as Métis is distinct from other Aboriginal peoples and who is accepted by the Métis Nation of historic Métis ancestry. Something that, is a common misconception among Canadians is that Métis simply means mixed, but not every person of mixed Indigenous and settler ancestry is in fact Métis. So this national definition that comes from the Métis Nation is critical when we understand what we mean using that term.
So a little bit about Métis citizens as rights holders. I'm always nervous talking about this while sitting next to a lawyer, but I'll keep things high level. So as I mentioned, the Métis are unique, distinct rights-bearing Indigenous people under the Constitution, and these rights are recognized and affirmed in Section 35 of the Constitution. Of course, these rights are inherent to the Métis Nation, but this is kind of how they're recognized within the constitutional framework in Canada. Two kind of important Supreme Court decisions that have affirmed the inherent rights of the Métis Nation include our v. Powley, which recognized that Métis communities emerging prior to effective control and influence of European laws and customs possess rights that are protected under Section 35. It also resulted in something called the Powley test, which describes a set of criteria to not only define what might constitute a Métis right, but who is entitled to exercise these rights. R.V. Daniels in 2016 recognized Métis as Indians under Section 9124 of the Constitution Act, which affirms that the government of Canada has a special constitutional relationship with the Métis, and this has broader impacts on the nation-to-nation, government-to-government relationship, including in the area of healthcare. Just really high level going into the United Nations Declaration on the Rights of Indigenous People and Canada's United Nations Declaration Act. So the rights of the Métis Nation, in addition to being inherent and protected within the Canadian Constitution, are also recognized internationally within the United Nations Declaration on the Rights of Indigenous People, or UNDRIP. In 2021, Canada passed an act that came into force to require the Government of Canada to ensure in consultation and cooperation with Indigenous peoples that all laws are consistent with UNDRIP and that Canada implements an action plan for UNDRIP. This action plan was released this past summer to achieve the objectives of UNDRIP and identify measures needed to ensure that all federal laws are consistent with UNDRIP. These measures kind of lay out a roadmap of actions for Canada to take in partnership with Indigenous peoples to implement the rights that are set out in UNDRIP. The articles that I've identified kind of on this slide pertain particularly to the right to self-determination, decision-making, governance, and free, prior, and informed consent. So a little bit about the Métis National Council, our role and the governance structure. So in 1983, the MNC was established to be the national and international voice of the Métis Nation to advance issues of importance to the Métis Nation, its Section 35 rights-bearing governments, and its citizens. This Métis-specific national representative body kind of emerged out of the 1983 First Ministers' Conference on Aboriginal Constitutional Matters as kind of a trigger in part for establishing the MNC. On the slide, you'll see the 4 governing members identified here. So the MNC receives its mandate and direction from these Métis governments of British Columbia, the Métis Nation of Alberta, Métis Nation British Columbia, and Métis Nation of Ontario. A little bit about the Métis governments, and there's folks in the room here who know more about that than I do. But these are the contemporary expression of centuries-old struggle of the Métis Nation to be self-determining. The Métis Nation has always been self-determining. It's been advocating for its rights since before the state of Canada came into existence. And how this fits into the MNC is it's a body to advocate, convene, and coordinate efforts at the national level to advance policy priorities that are shared across the Métis Nation and the 4 governing members. So advancing these policy priorities includes advocating for a renewed fiscal relationship with Canada that's premised on sufficient, predictable, and sustained long-term funding. Under the system of democratic accountability, Métis National Council governing members serve Métis citizens by providing effective means of representation at the community, regional, provincial, national, and international level. and have a proven track record in addressing the socioeconomic needs of their citizens by delivering government programs and services in a fair, transparent, cost-effective, and accountable manner. I spoke briefly to the role of the MNC, and we kind of describe it under these three separate columns. So an advocacy role, a convening role, and a research and policy coordination role. So we've identified kind of a couple examples of concrete items that fit under each of these columns, from the federal budget submission to some of the international work, standing committees, parliamentary committees, from convening the MNC General Assembly, which just took place this past in December, where resolutions are passed to guide the mandate of the Métis National Council, regular Board of Governor meetings, the permanent bilateral mechanism, and other policy events such as the one we're all attending today. In terms of research, there are technical committees as well as papers and research that the MNC undertakes. So just to kind of distinguish between how the MNC fits into the picture versus the Section 35 rights-holding Métis government. So the MNC is not a Métis government. It's a federation of the 4 Section 35 rights-bearing Métis governments that the MNC represents at the national and international stage. It's also one of the 3 national Indigenous organizations alongside the AFN and ITK. The MNC does not set its own mandate and policy direction, but is instead a collaborative international advocacy body receiving its direction from governing members. So this is a non-exhaustive list of the policy areas that the MNC works in, ranging from intergovernmental relations to health, economic development, environment, emergency management, just to name a few. This diagram just kind of provides a visual for the decision-making process of the MNC and governing members. So you'll kind of see a dotted horizontal line there that divides political leadership from the Métis Public Service. So going from bottom up, there's technical committees and senior officials tables to advance policy priorities at the national level. And then moving up to the elected official level with the MNC president, Board of Governors, and ultimately taking our mandate from the Annual General Assembly, which is a gathering of these parties. So I'll move into the Permanent Bilateral Mechanism, or the PBM. So just a little bit of history about the Canada Métis Nation Accord. So the Métis National Council's participation in the 1992 Charlottetown Accord constitutional negotiations resulted in consensus on a proposed legally binding and enforceable accord on Métis Nation issues. This was originally envisioned to be part of the Charlottetown Accord, but as we know, these proposed constitutional amendments did not come to fruition. More than 25 years later, the parties, being Canada, governing members, and the MNC, signed the Canada Métis Nation Accord. It's a foundational document to the contemporary Canada Métis Nation relationship, and its objectives include establishing a process for co-development, negotiation, upholding Section 35 rights, renewing the Crown Métis Nation relationship, advancing reconciliation, ending the legacy of colonialism and colonial attitudes in the federal government, its legislation, policies, and practices, and improving socioeconomic conditions of Métis citizens. It also lays out a number of priority areas for policy development, and we continue to work towards those policy priorities today through the permanent bilateral mechanism. The PBM was established through this accord, and the MNC governing members and Canada committed to basically this structure of meetings that take place each year to advance shared priorities, set the agenda, advance the work, and reach agreements and funding to serve Métis governments and their citizens. So it's a venue to establish priorities with Canada for the year ahead through an annual meeting with the Prime Minister called the Crown Métis Nation Summit. It undertakes joint policy development on established priorities that have been identified through the Accord and added to the PBM standing agenda over time. And the aim is really to gain significant investments in the Métis Nation on specific priority areas, and is a place for the Métis Nation and Canada to engage on a government-to-government, nation-to-nation basis in a new mechanism. In terms of the structure, as I mentioned, there's an annual Crown Métis Nation Summit where the parties, being the Prime Minister, implicated cabinet ministers, as well as the presidents of governing members and the MNC can gather to report on progress and establish new priority areas. There are 2 leaders meetings a year, so those are implicated cabinet ministers in the Government of Canada, as well as the presidents of MNC and governing members who work to refine priorities, see what progress is being made, and see what commitments need to be made among the parties in order to press forward on this work. The next level down is senior officials meetings. So we host these meetings each quarter, and this is really to guide the technical level work that takes place between all of these formal meetings to actually advance policy work on the ground. So Canada is represented in these meetings by senior assistant deputy ministers, and the Métis Nation is represented by senior officials from each governing member and the MNC. Then, when policy priorities are identified through the PBM, working groups are established at the working level between the Métis Nation Public Service and the Government of Canada Public Service for technical level discussions to make substantive progress on jointly established priorities. This is what the policy cycle can look like. It's an iterative process, and this isn't something that is prescriptive, but it's kind of a trend of how we've worked together to advance policy across different areas. So a joint priority is identified. A work plan is co-developed at the technical level. The parties may enter into a memorandum of understanding or something of that sort at the senior official level. And then hopefully the outcome is a funded sub-accord or other deliverable at the political level. Current PBM priorities include the Canada Métis Nation Co-Development Principles, which Ryan will speak to after my presentation, emergency management, primary and secondary education, languages, health, economic development, and international. So I'll just provide an overview of the few meetings that have taken place over the past year or so, starting with the December 13th PBM leaders meeting. So this was a really critical gathering because it was the first in-person gathering of leaders since the COVID-19 pandemic and under a new administration and new leadership for the MNC. It really was a key priority to resume the important work taking place through the PBM and institutionalize the PBM in this nation-to-nation, government-to-government manner. So work was advanced across co-development principles, economic development, education, health, national benefit sharing, languages, and the implementation of UNDRIP to set the commitments from both parties in order to really lay the groundwork for a lot of the policy development that we've been working on in the context of the PBM since then. The Crown Métis Nation Summit with the Prime Minister took place on June 1st this past summer. At the meeting, terms of reference that kind of define how this whole structure is going to work and the series of meetings that take place through the year were endorsed. Emergency management, which of course intersects with health in many ways, was added to the PBM agenda, and other discussions took place on where we're at in terms of priorities that were set since December of 2022, and new commitments to address barriers and advance the work together. Most recently, we held the PBM leaders meeting actually last week on January 31st. A really exciting deliverable for the MNC and governing members was the endorsement of the co-development principles, which again, Ryan will speak to. But this is a guiding document for the manner that Canada and the Métis Nation will work together. Next steps include the implementation of these principles through a whole of government approach. The international work plan was also endorsed, which I think Kate will speak more to the international work in a little bit. Funding announcement was made to help work towards reaching a 10-year subaccord on primary and secondary education. And there was a commitment to reach a work plan at the upcoming Crown Métis Nation Summit this spring on emergency management. I just wanted to speak a little bit to some of the early successes and where we're at now with the PBM. Between 2017 and 2019, Government of Canada and Métis Nation entered into 7 subaccords across policy areas that are laid out here, ranging from early learning and childcare to economic development. And these agreements have led to tangible change in the lives of Métis citizens. Since then, progress has been slower on advancing other joint PBM commitments, despite commitments that the Métis National Council and governing members have received to enter into funded subaccords on some of those new priority areas that I identified earlier. Meaningful funding to advance these priorities has not been provided by the Government of Canada. As we know, this lack of progress has real consequences and is to the detriment of Métis Nations, governments, and citizens across the homeland. Too often, the Métis Nation has been left behind by the Government of Canada. Just over 7 years ago, the Daniels decision affirmed that Canada holds the same fiduciary duty to Métis as it does to Inuit and First Nations. But despite this, the Métis Nation is facing barriers across many jurisdictional areas, including health. On the 31st, MNC and governing members communicated to Cabinet that we're seeking a firm commitment to reset the PBM and really break through on these key policy areas. And this could include avenues to institutionalize the Canada-Métis Nation Accord and the PBM through legislation as a means to honor the Crown's solemn commitments to the Métis Nation. We also strive to bring central agencies, so Privy Council Office, Treasury Board Secretariat, and Finance into these conversations because we understand the important role that they play in decision-making processes in the Government of Canada. Just to kind of wrap things up, 3 key points that the intergovernmental team conveys consistently in our interactions with the Government of Canada about what working together on a nation-to-nation, government-to-government basis looks like. So there's 3 main principles, which are engaging with the Métis Nation through a distinctions-based approach is essential. So what that means is working with the Métis Nation as a nation to ensure that the unique rights, interests, and priorities of Métis people are acknowledged, affirmed, and implemented. The second is to renew the relationship on a nation-to-nation, government-to-government basis. The Métis Nation is just that, a nation, and the Accord and PBM reaffirm this relationship between the parties. The third is the Government of Canada needs to commit to help build the capacity of the Métis Nation by investing in these policy areas through a renewed fiscal relationship that's premised on sufficient, predictable, and long-term funding. We really look forward to continuing to work with the public service as allies in advancing this important work, and the PBM is really something exciting and has been a place where in early years, really rapid and significant successes were made. And we hope to revitalize the process and continue on that work. That's it from me. I look forward to any questions that you might have after Ryan and Kate conclude their presentations. Thanks.
All right, thank you, Avery. As mentioned, my name is Ryan Schauner. I am legal advisor and acting director of justice and legislative affairs for the Métis National Council. I have been with MNC since August 2022 and have been working primarily on matters relating to Canada's implementation of the United Nations Declaration on the Rights of Indigenous Peoples. I am here to talk about responsibilities and obligations concerning Métis health. As mentioned by Avery, the Métis are one of the distinct Indigenous peoples recognized in Canada's Constitution, and based on the Supreme Court of Canada's decision in Daniels 2016, the federal government has constitutional responsibility for Métis. Through statute and through political commitments from the Prime Minister and Cabinet, Canada has undertaken obligations and provided the mandate and authority for government departments to work with the Métis Nation on advancing our health priorities in a manner befitting the nation-to-nation, government-to-government relationship between Canada and the Métis Nation. As Avery mentioned, in 2021, Canada passed the United Nations Declaration on the Rights of Indigenous Peoples Act, or UNDA. One of the purposes of the Act is to provide a framework for Canada's implementation of the UN Declaration. To do this, the Act imposes legal obligations, with Section 5 being of particular importance, as that provision imposes obligations regarding the consistency of the laws of Canada with the Declaration. Section 5 states, quote, "The Government of Canada must, in consultation and cooperation with Indigenous peoples, take all measures necessary to ensure that the laws of Canada are consistent with the Declaration," end quote. There are two elements here that deserve some mention at this point, the phrase consultation and cooperation, and what is meant by consistency of laws. So consultation and cooperation is a term from the Declaration itself, and it must be interpreted purposively with the aim of fulfilling Canada's obligations in implementing the Declaration in Canadian law. Articles 18 and 19, as mentioned by Avery, are of central importance to understanding this phrase. Within the Declaration, it refers to the process that Canada is required to enter into with Indigenous peoples through their governments and representative institutions prior to adopting or commencing legislative or administrative action that may affect Métis and their rights. The purpose of consultation and cooperation is to obtain the free, prior, and informed consent of the Indigenous peoples concerned for a particular action, and processes must be designed to achieve this end by ensuring adherence to the minimum standards articulated in the UN Declaration. The procedure and substance of consultation and cooperation must be based in the consent of the parties, not be predetermined by Canada, and must promote and respect Métis procedures and processes of government. Failure to satisfy the obligation to consult and cooperate is not only inconsistent with UNDRIP, it fails to respect the nation-to-nation, government-to-government relationship that underlies the Canada-Métis Nation relationship. So, as mentioned, consistency with UNDRIP entails, in part, adherence to the minimum standards articulated in the Declaration. The Declaration is a rights document. It is not an aspirational principles document. So for health, Articles 21, 23, and 24 are relevant for understanding the rights of and Canada's obligations toward Indigenous peoples, including Métis health. So Article 21 affirms the right to be free from discrimination in health and imposes obligations on states to take measures to achieve this end. Article 23 affirms the right of the Métis Nation to determine and develop priorities and strategies relating to health, and affirms the right to be involved in developing and determining programs and the administration of such programs. Article 24 sub 1 affirms the right to traditional medicine and to maintain health practices, and 24 sub 2 imposes an obligation on states to take measures to achieve the realization of this right. Through its United Nations Declaration on the Rights of Indigenous Peoples Act action plan, Canada has committed to actions and measures to implement the rights set out in the declaration, including relating to health and to advance reconciliation in a tangible way. Measures in the action plan represent commitments from the Government of Canada and provide mandate and cabinet authority to carry out the action listed. While many of the 181 action plan measures are relevant to advancing Métis health priorities, there are 4 that deserve special mention. Métis Action Plan Measure 11, which was co-developed by the Métis National Council, governing members, and federal departments, commits Canada to ensure work continues with Métis governments to realize Métis-specific access to health services, improve equitable health outcomes, and to ensure that the Métis Vision for Health informs the co-development of distinctions-based Indigenous health legislation. Shared Priorities 6 and 7 contain commitments relating to co-developing distinctions-based health legislation, and Shared Priority Measure 81 commits to improving health equity through access to culturally appropriate health and wellness services and supports. So these measures provide key footholds in reforming entrenched practices that exclude Métis from equitable health services and in co-developing laws and policies that advance Métis self-determination and self-government in the area of health. Beyond UNDA, departmental home statutes contain further direction from Parliament and impose additional legal obligations on ministers and departments. As laws of Canada, these statutes must be interpreted in accord with the UN Declaration. So under the Department of Indigenous Services Act, the minister has a duty to ensure that services are provided to Indigenous individuals and Indigenous governing bodies that are eligible to receive those services. Health is expressly listed in this section, as is governance, providing a statutory basis for the provision of health services by and for Métis. Section 7 of the ISK Act speaks of collaborating in the development of services with Indigenous peoples, and Section 7 of the Department of Crown Indigenous Relations and Northern Affairs Act speaks of implementing rights and advancing self-determination and reconciliation. The Department of Health Act does not contain specific duties or functions for the minister with respect to Indigenous peoples, but it does contain duties around the promotion of health, data collection and analysis, and cooperation with provincial authorities, all of which are relevant to advancing Métis self-government in health. Ministerial mandate letters provide direction from the Prime Minister for undertaking the work therein. The ISK mandate letter contains a commitment to co-develop distinctions-based health legislation, and the Health Minister's mandate letter refers to the implementation of UNDRIP. Canada's principles respecting the Government of Canada's relationship with Indigenous peoples are a further authority for transformative change in practices and processes. So these principles are intended to guide Canada's work in renewing nation-to-nation, government-to-government relationships in a manner that fulfills Canada's commitments and obligations. To do so, they recognize that Canada has a responsibility to shift its arrangements with Indigenous peoples, including changes in the practices and processes of the federal government. So with these obligations and commitments and authorities, how is self-government, self-determination, and the nation-to-nation relationship advanced? As Avery mentioned, recently endorsed during the January 31st Permanent Bilateral Mechanism Leaders Meeting through the Canada Métis Nation Accord, the Canada Métis Nation Principles of Co-Development provide a structured process for this commitment to develop effective mechanisms that support the transition away from settler mechanisms of administration and governance. These co-development principles set out how the Métis Nation and Canada can co-develop policy and law together equitably in a manner that fulfills Canada's obligation and upholds Métis self-determination. These principles commit Canada to work with MNC and the Métis governments in a manner befitting the nation-to-nation, government-to-government relationship, including commitments around upholding Métis self-determination and self-government, commitments to respect governance structures and processes, and commitments that ensure Métis rights to participate in decision-making as equal parties. A core foundation of the principles is the need to align the application of cabinet confidence with the decision-making rights in Articles 18 and 19 of the UN Declaration. The co-development principles contain specific commitments needed to give effect to Métis decision-making, and this language, which was developed with Canada, sets out the Métis Nation's access to key materials and decision-making points rather than relegating our governance and decision-making to the edges of blanket assertions of cabinet confidence. These principles establish foundational understandings between the Métis Nation and Canada, and the Métis governments may choose to invoke these commitments in the bilateral work they undertake with the federal government. To move forward with reconciliation, Canada must fulfill its obligations under the United Nations Declaration on the Rights of Indigenous Peoples Act and other statutes and commitments made in the UNDA Action Plan to advance Métis health priorities and to ensure full and effective Métis Nation participation in Canada's decision-making practices and processes. In sum, there are multiple statutory and policy authorities for all Government of Canada departments to undertake transformative change for the Métis Nation to exercise its inherent right of self-determination and self-government in health. The statutory obligation to ensure the consistency of laws with the UN Declaration requires working directly with the Métis Nation through its mandated representatives. The principles of co-development provide a structured process to ensure that these statutory obligations regarding consultation, cooperation, and the co-development of laws and policy are satisfied and advance the nation-to-nation, government-to-government relationship between Canada and the Métis Nation. This process is essential to advancing and realizing Métis health priorities. Thank you.
Hi, everyone. Good afternoon. I guess I don't have to talk that close to the mic, sorry. My name is Kate Gillis. I'm the Policy Advisor of Intergovernmental and International Relations at the Métis National Council. I joined in January of 2023. I just celebrated my 1 year a couple weeks ago, and it's been an absolute pleasure to work on developing some of these policy portfolios. I am Métis myself. My mom is a Chartrand from St. Laurent, Manitoba. I was born and raised in Calgary, Alberta, and I moved out to Ottawa in May of this past year, predominantly for this job. And yeah, that's a little bit about me. I've spent the last year predominantly focusing on how to develop a Métis Nation international strategy. And so as Avery said, MNC does hold the mandate as the international and national voice of the Métis Nation. And so I've been trying to work on how to incorporate all of you Métis folks in the room into this strategy and how we can advocate not only at the national level, but at the broader international level as well. And so I'm going to talk a little bit about one opportunity to do that through the United Nations Sustainable Development Goals. Let me make sure. Okay. So in 2015, the United Nations General Assembly adopted what is called the 2030 Agenda for Sustainable Development, which provides a blueprint for peace and prosperity for people and the planet now and into the future. At the heart of the agenda, there are 17 Sustainable Development Goals, or SDGs, that you can see on the screen. And the broadly encompassing goals recognize that ending poverty and other deprivations must go hand in hand with strategies that improve health and education, reduce inequality, and spur economic growth, all while tackling climate change and working to preserve our oceans and forests. So on top of Canada signing on to the 2030 Agenda at the United Nations, they've also launched a federal implementation plan, and Prime Minister Justin Trudeau is actually the co-chair of the United Nations Sustainable Development Goals Advocates, which is a group of 17 influential leaders raising global awareness for the goals. So the SDGs, similar to UNDRIP, are an example of international mechanisms that trickle down to the national level and have direct implications on Métis citizens. And utilizing the language of the 2030 Agenda is a tool to hold Canada accountable to the commitments that it's made. So I'll start with some broad strokes of how the SDGs can be applied across all Métis Nation policy priorities, and then I'll get a little bit more in depth as to the health-specific ones. So first, the 3 dimensions of sustainable development are economic, social, and environmental, and all are integrated and indivisible. This essentially means that implementing one goal will impact the implementation of another, and that efforts should be made to work beyond silos in the actioning of this framework for sustainable development. In adopting the 2030 Agenda, member states of the United Nations reaffirmed the importance of the Universal Declaration of Human Rights, as well as other international instruments relating to human rights and international law. They stated that they emphasized the responsibility of all states in conformity with the Charter of the United Nations to respect, promote, and protect human rights and fundamental freedoms for all. This reaffirmation underscores the indivisible nature of human rights. And in Canada, the implementation of the 2030 Agenda for Sustainable Development must go hand in hand with the implementation of the United Nations Declaration on the Rights of Indigenous Peoples. So second, for all aspects of the 2030 Agenda, it is crucial that there be disaggregated data to measure progress. This is especially crucial in Canada, where a distinctions-based approach must be taken with respect of any measures relating to Indigenous peoples. The phrase often connected to the SDGs is "no one left behind," and this especially means the most vulnerable, which in Canada, of course, includes Indigenous peoples. Third, the Métis Nation must be included and represented in decision-making at all levels pertaining to them. The SDGs commit Canada to ensuring that decision-making is responsive, inclusive, participatory, and representative at all levels. And lastly, the elimination of all forms of discrimination is crucial to effective implementation. It is important to consider non-discrimination across all sectors when advocating for the implementation of the 2030 Agenda. So to get more specific into the topic of health, I'll focus predominantly on 2 specific goals: good health and well-being and reduced inequalities. The 2030 Agenda envisions a world with equitable and universal access to healthcare and social protection, where physical, mental, and social well-being are assured. Countries, including Canada, clearly stated in the 2030 Agenda that we must achieve universal health coverage and access to quality healthcare. No one must be left behind. These ambitious commitments stand in stark contrast to the experiences of Métis people who face exclusion on top of many layers of discrimination in accessing healthcare individually and systemically. The Métis National Council's holistic priorities for healthcare, including access to care, healthy living, and comprehensive community wellness, are well aligned with Sustainable Development Goal number 3 to ensure healthy lives and promote the well-being for all at all ages. The MNC prioritizes culturally competent health systems that provide cultural support and traditional well-being, and it is important to note that the international community has recognized that all implementation measures regarding healthcare should be culturally sensitive. In addition, addressing systemic and political barriers that contribute to health inequalities align with Sustainable Development Goal 10, ensuring equal opportunity and reduced inequalities of outcomes by eliminating discriminatory laws, policies, and practices, and promoting appropriate legislation, policies, and action in this regard. We can use this alignment to continue advocating for the enhanced distinctions-based legislation and resourcing for healthcare for Métis citizens. It is imperative to note that though a Métis social determinants of health approach, through a Métis social determinants of health approach, the efforts to achieve all the SDGs can impact the closing of health gaps between Métis and other Canadians from a multi-sectoral lens. Socioeconomic sectors and determinants such as infrastructure, employment, housing, education, and the environment need to be addressed if substantial improvements in health are to be realized. Each of the 17 SDGs has corresponding targets and indicators. Health specifically has 13 specific targets, but I've chosen just to focus on a few here for time's sake. Firstly, I have target 8 here, which is essentially to achieve universal health coverage, which I've paired with target 10.3 to ensure equal opportunities and reduce inequalities of outcome, including by elimination of discriminatory laws, policies, and practices, and promoting appropriate legislation, policies, and action in this regard. Métis people have an equal right to the enjoyment of the highest attainable standard of physical and mental health as affirmed by the United Nations Declaration on the Rights of Indigenous Peoples. However, as we know, Métis citizens are often excluded and marginalized in the healthcare system due to systemic barriers and racism within the healthcare system. For Canada to meet SDG Target 3.8 and 10.3, resourcing must be provided that enables equity in the healthcare system, equity in health for Métis citizens, entails culturally appropriate access to primary specialist care that promotes healthy living and disease prevention and self-determination in health systems. Next, we have targets 3.1 and 3.7, which relate to maternal mortality and sexual and reproductive healthcare services. By working in partnership, the Métis Nation can assist Canada in achieving these targets. Métis citizens must have access to culturally relevant sexual health and reproductive care, and Canada can provide the political and financial support through sustained funding for the Métis Nation to have culturally appropriate access to said sources. And lastly, I have Target 3.5, which focuses on the prevention and treatment of substance use. In order to promote mental wellness, there must be funding for culturally appropriate and trauma-informed substance use supports that enhance comprehensive Métis community wellness. Métis-led initiatives with distinctions-based funding provided by Canada will be the most appropriate way to support Métis citizens on their journey towards well-being and achieving success on this target. And so aside from the United Nations Sustainable Development Goals, there are multiple United Nations entities and forums that focus on Indigenous-specific health and well-being. Sorry, I changed on my laptop, but I didn't change on the actual screen. For example, in May of 2023, the World Health Assembly of the World Health Organization passed a resolution titled "The Health of Indigenous Peoples." The resolution states that Indigenous peoples have the right to the enjoyment of the highest attainable standard of physical and mental health. The resolution urges countries to take action to develop, fund, and implement national health plans to reduce social, cultural, and geographic barriers to their equitable access to quality health services provided in Indigenous languages, among other measures. Importantly, the resolution calls on the Director General of the WHO to develop a comprehensive global action plan for the well-being of Indigenous peoples and present it at the World Health Assembly in 2026. The Métis National Council might work alongside Canada to ensure Indigenous peoples' involvement in the development of this global action plan and to take action on the action plan domestically to advance Canada's progress on the SDGs. Additionally, the United Nations Special Rapporteur on the right to health has been mandated to pay attention to groups in vulnerable or marginalized situations, to apply gender perspectives and to address the needs of children in the realization of the right to health. Engaging with the Special Rapporteur might mean contributing to their studies to advance the global understanding of Indigenous people's right to health. Any individual or organization, including MNC and governing members, can submit information to the Special Rapporteur. And lastly, health is one of the 6 mandated areas of the United Nations Permanent Forum on Indigenous Issues. There was a study released in 2023 on Indigenous determinants of health in the 2030 Agenda. Contributing to the work of the Permanent Forum through these studies contribute to the advancement of Indigenous rights globally. So that's a broad overview of all the different, or some of the different forums that MNC and governing members can participate in the International Forum. And I think we have time for some questions. Yeah? Great. That was a quick hand.
Awesome. Panelists. Oh, you're a bunch of smart people. It's a lot of words. I feel overwhelmed, but who am I?
Thank you. Sorry,
I'm
Tara.
sorry, Minister
You go
Friesen.
ahead,
I'm
Tara.
having a moment up here by myself. Over to you.
Thank you, Tara. And thank you for the information and the ongoing work and advocacy with Métis National Council in these specific areas. I have a question on the health sub-accord. We started that work in 2022. I want to know what the status of that sub-accord is and why the work has been stalled. And the second question about health is the Indigenous Health Equity Fund that was disseminated here recently with Canada. Is the Métis Nation Health Sub-Accord and it's incomplete? Is that a reflection of why the Health Equity Fund wasn't equitable for Métis Nation? So 2 questions. Thanks.
Thanks for the question. Our Director of Health, Ginny, would be better positioned to speak to that. Go ahead, Ginny.
No problem. I think I got the first question. I might need more clarification on the second question. But I really just want to give a shout out to my colleagues at MNC. All of your presentations were amazing, and I love working with all these bright folks at the office. It's really great. So thank you for those presentations. So hi everyone, I'm Ginny Gano. I'm Director of Health at Métis National Council. Just to update everyone on the status of the 10-year health and wellness subaccord. So we did sign an MOU with ISK in, sorry I feel funny not facing you. We did sign an MOU with ISK in December of 2023. And that was to basically, for the third time, try to land a 10-year health and wellness subaccord. The first, I think I have the date right, it was December 2022. And what happened with the first attempts to sign a subaccord is there was no investments from ISK. And the senior officials within the governing members have said, we're not willing to sign a subaccord without investments attached. And the department was not able to secure those investments, so therefore the subaccord fell flat. We are now negotiating for a third time through a third MOU, which is set to conclude March 2024. And as soon as the budget drops, we'll be setting up meetings at the elected leadership level as well as the technician level within days after the budget dropping, so that we can sit down and talk dollars and cents of what could we put together from the budget and from the envelopes that are funded and what carve-outs of those for the Métis Nation, so that we can come to an agreement on amounts of long-term sustainable funding that will support a 10-year health and wellness subaccord. So that is our game plan. We've made it very clear. We presented to the budget team at ISK that actually puts in the budget submissions. We presented a whole MC and costing memorandum to Cabinet, which outlines the Métis National Council's Budget 2024 asks. We broke them down using that costing analysis to explain exactly all of our rationale and all of our numbers for all of those asks. And we had a really positive discussion, but basically the department has said they can't, other than existing funding, they can't confirm anything until the budget drops, which is undetermined of when that will be, sometime in the next couple of weeks. The sooner the better, we hope, because there's a lot of funding that's up for program renewal, and we won't know until then if those programs are renewed. So that's the subaccord update. We presented that to the leadership prior to the leaders meeting, and we do hope that folks in the room being here at the Health Forum better understand our priorities, can better advocate within the federal machinery to ensure that we are reflected in all budget submissions that are going forward, that they are distinctions-based, and that there's an adequate carve-out for the Métis Nation within all envelopes that are going forward to support our health priorities. And it would be a real shame because the minister has actually committed, Minister Haidu is committed to negotiating a health and wellness subaccord. And we do have a PM summit coming up that we want to share good news that hopefully we've landed a subaccord. Third time's the charm, we hope. So that's the subaccord, but the second question that you had was? Oh, so the Health Equity Fund, that was announced. President Karen actually requested for 25%, no less than 25% on behalf of the Métis governments. Unfortunately, the allocation that we received from Minister Haidu was 9.5%. That was drastically below what we were hoping for. And when you look at what that works out to be for each governing member annually over 10 years, it wouldn't even cover a medical transportation program in one of our provinces. So we've met with Minister Haidu. We've done all of the briefing on this at the leadership table. And in terms of when that funding that we did secure is coming through, not until July of 2024. So it's going to take a while. It will flow through the self-government agreements. And we're hoping that Métis Nation BC will get a named grant to receive the funding so they have the same flexibility as the other GMs. So it's not what we wanted, and it's definitely not equitable. So did that answer all your questions? Okay, thank you.
Thank you. Any other questions for the panel before we move on? All righty. Well, listen, I think these are the people, if you want to be friends with the Métis Nation, right? Métis National Council, these are the people, Métis Nations abound around the room. So we absolutely want to encourage everyone to connect, all of our partners that are in the space. So big round of applause for our panelists. Thank you so much.
Great.
Yeah.
And if you do have any follow-up questions at any point, Ginny has our contact information, and we'd be more than happy to connect with you. So thanks.
Thank you. And so we've had an unfortunate change in our, well, not unfortunate, but unfortunately, one of our speakers is no longer available. So Aaron Myers is not able to be here this afternoon. But what we are absolutely thrilled to do is to invite up Ashton James and Reagan Bartel, who are going to be speaking on Missy Yehewin, learning from the Métis Nation of Alberta's Tobacco Reduction Initiative.
Sitting is the flavor today. Can we do that?
Yeah, you can. Sure you can. The clicker is there.
Oh, okay. Yeah. I'll sit here then.
Do you guys do you have slides?
Yeah, we have slides.
Oh, I'll take a hug. Yeah, I will. Bringing that into the space. Why else hasn't anyone else hugged me? I'm going to take that personally.
Okay, maybe, can we share a mic? Does that work?
Yeah, do you want to be, let's switch sides.
Sure.
So you can be the clicker.
I'll let you log on. We're just getting ourselves organized, folks. I don't know how I'm going to follow that. You're doing clicker, I'm doing this clicker. All right, everybody's staring at us and it is very bright.
It is very bright. And I'm just going to make sure that I know how to work this.
I think you just press the big green one.
Oh, and that's the back.
Yeah.
Perfect.
There you go.
Oh, and the back. Okay.
There you go.
Okay, sorry about that, everyone. Tanse, Nea Oma Ashton James, Ki Tatam Scott Nawau. Hello, my name is Ashton. And I just want to begin by acknowledging all of you who have stuck around with us, as well as the traditional stewards of the land that we are gathered on today, the Anishinaabe Algonquin people. I'd also like to acknowledge the place that Reagan and I are visiting from. We both currently live, work, and play in Amiskwichi, Waskahegan, also known as Edmonton, which is located on Treaty 6 territory in the Métis Nation homeland. So we have all arrived at the last presentation of the day. I know it's happening a little bit earlier than we all had initially anticipated, so perhaps that is a good thing. But I also know today has been a full one, so if you need to stand up, move around, or do whatever you need to do to stay present with us, then we hope to keep this as enjoyable as possible. And I also want to invite us all just to use the presentation title as a bit of a reminder of how to ground in the moment. So Missy Yehewin translates to big breath. So if you feel like you need it, I know I do, then feel free to join me in a breath before we begin. So I'm joined on stage with my colleague and friend, Reagan Bartel, many of who you may have heard speak yesterday, so I'm really happy to have her on stage with me. Originally, Lisa Vaughn was supposed to be on stage. She is the manager of community wellness at the Métis Nation of Alberta, and she's really a truly wonderful person. She's feeling unwell today, so you won't get to meet her in this presentation, but we hope she's recovering quickly, and I'm happy to have Reagan jump in.
My one job and I've messed it up already, guys.
So just briefly, I'm a white settler in Canada. My family is originally from Europe and settled in central Alberta in the 1920s, where I was born and raised. These are just a few photos of the people and the places that are near and dear to my heart. And while I know it's hard to really know a person in a slide, I hope they leave you with a bit of a better understanding of who I am and where I come from. And I just realized I missed an opportunity to put a very important photo on here. Today is my dog, Stuart's 12th birthday. Yeah, happy birthday, Stuart. And I really missed, anyways, if anyone wants to see a photo of Stuart on his birthday, then come find me later and I will happily show you many photos of Stuart. He is a very, very good boy. So I've had the opportunity and the privilege to work for the Otipemisiwak Métis government of the Métis Nation within Alberta, also known as the MNA, for over 5 years now, and currently as the Senior Manager of Health, where I work closely with Reagan and the rest of our amazing team, who you also likely heard yesterday too. It was a big day for MNA presentations.
Hi guys, it's me again, Reagan. These are not pictures of my family. These are pictures of Lisa's family, so she's not here. But look at how lovely her family is. I'm just not taking them out, and you saw Rowan yesterday, so you have seen my family. I was born and raised in Kimberley, BC, before I moved to Edmonton, where I completed my nursing degree. And I spent more than 16 years working frontline in the intensive care unit at the Royal Alec Hospital in Misquachuskegon before I completed my MPH and moved into the role of Director of Health for the OMG, which we're not allowed to use, so the Otipemisiwak Métis government. My family name is Patras, and my roots trace back to Batoche in Saskatchewan before my family traveled through southern Alberta, mostly in Coleman, and settled in interior BC in Creston and in Kimberley. So that's a little bit about myself that I didn't share yesterday.
So I'm really excited to talk a bit about our tobacco reduction program. In my opinion, this is some of our best work, so that is always nice to share with people. And this is actually the first time we've really talked about this program in such a public setting, so we really appreciate the opportunity. And lastly, and maybe most importantly, this is the only program in our department that we have sustained funding for. So it's obviously really great to share that with everyone. I know everyone is really hoping for that for a lot of their ongoing initiatives. We've heard a lot about that this week. So really, I guess I offer this presentation as an example of what is possible when we have the resources to succeed. So the funding for this program comes to us through Indigenous Services Canada. And Ginny made me aware that there's a couple of people from ISC, from the Healthy Living team, who helped make this possible, who are in the room. So shout out and thank you to Mary T. and Corey Henry.
I don't know where they're at. We love you guys.
You don't have to stand up or anything. We won't put you on the spot like that. But thank you so much for everything you do. And we're really happy to have you here and in our lives. So I'm going to share just a really brief overview of what this program looks like and how we got to where we are now. And then Reagan will jump in with some of the key takeaway messages from our program evaluation. And before we do that, I also just want to acknowledge that all of the great work that you are about to hear about wouldn't be possible without Kyla Hatchie. Yeah, shout out. So Kyla's the community prevention practitioner at the MNA, and she is responsible for all aspects of this program. So while she couldn't be with us today, we just want to acknowledge all of the amazing things that she does to move the work forward. So thank you, Kyla. Let's begin. So our tobacco reduction program is what we consider to be a multidimensional health promotion initiative that ultimately aims to support Métis Albertans who wish to make a change in their commercial tobacco use. So this program has 4 main components, and the first component is our Quit Core group program. This is a group program that consists of 6 weekly online sessions. And this program was actually an adaptation of the Alberta Quit Core program of the same name. And this 6-week program equips participants with a variety of methods to support them in reaching their tobacco reduction goals, including cultural and holistic approaches. And just out of interest, some of the other adaptations that were made to the Alberta Quits program include M&A branding, incorporating the Michif language, and quotes and videos from Métis Albertans on their own tobacco reduction journey, a focus on building relationships, and this includes inviting a pharmacist to attend the program, to share information about nicotine replacement therapies and answer questions. We've integrated opening and closing prayers, and the time of each session has been extended to 2 hours from 1.5 to make additional space for sharing and reflection among participants. And lastly, this also includes space for participants to explore building a ceremonial relationship with tobacco. Graduates of our program are eligible to receive a $500 Alberta Blue Cross benefits card, and this can be used to access nicotine replacement therapies from any pharmacy across Alberta. So graduates of this program are also eligible to join Change Corps, which is a weekly peer support group that is led by Quit Corps graduates, and really it just allows them to stay connected and continue to support each other. And in addition to Change Corps, graduates of our Quit Corps group program are invited to a Quit retreat. These retreats bring together graduates and their families for a celebratory weekend at Métis Crossing, where everyone has an opportunity to connect to each other, the land, and Métis culture. And lastly, we also have a standalone NRT program. This program is really intended for people who aren't interested or able to commit to the group program. And it includes 3 one-on-one sessions where participants work with Kyla to build their own individual change plan. And then at the end of this, they also are provided with access to a $500 Alberta Blue Cross benefits card. So to develop this program, we hosted a series of community engagement sessions and completed a literature review. And ultimately from this work, we were hoping to better understand the factors that influence commercial tobacco use behavior among Métis Albertans. Our program was designed with all of these factors in mind over a 1-year period. And really the main takeaway from that is we were hoping to move beyond individual behavior modification to really acknowledge and address the broader factors that were influencing Métis Albertans on a tobacco reduction journey. So when it came time to actually implement the program, we did this slowly over a 1-year period, roughly, beginning in January 2021 with our Quit Corps group program. So this program has been up and running in some capacity for 3 years now. To date, 140 MNA citizens have graduated from our Quit Corps group program. Of these, 23 have continued to join our Change Corps peer support group, and 62 have attended a Quit retreat. And additionally, 50 MNA citizens have completed our one-on-one NRT program. So throughout this period, we have also worked with an evaluation consultant to evaluate this program. And ultimately, the scope of this evaluation was aiming to explore the question, are we doing it right for the community? So we used a few different methods to answer this question, including interviews with MNA staff, reviewing program records, and surveys and a sharing circle with program participants. And with that, Reagan will tell you a bit more about what we learned.
And Reagan is just getting to this presentation this morning. But before I move on to the evaluation, because Ashton loves it when I go off script, I want folks to understand the magnitude of the fact that we reached 140 citizens. And for folks that are not working in our communities very often, you have to remember that we are a smaller, tight-knit community. So having 140 participants over 3 years with a single coordinator is massive. That's what we could do with the funding that we had. Imagine if we were resourced appropriately. And I want to leave that with you, because I know that this is a sustained program, but just because something is sustained doesn't mean we don't have the ability to grow within that based on our own self-determined needs. So 140 people were served by a single coordinator. That is massive, massive. And Kyla deserves that shout out. Okay, now I'll go back to my regularly scripted presentation. So the innovation in this program really truly is that our team was able to host those gatherings and ground the programming in spaces that community identified as important to health and wellness. So it wasn't us, although our team is brilliant. It was actually community voice that drives this program, and that's where the innovation is, and that's what's often missed in mainstream programming. We go right to the literature and we forget the people that we're serving, and this program doesn't do that. Community identified a few things that they thought needed to be in our programming. They wanted connection to space, supportive connections with family, friends, culture, and community, as well as land in the nature. And you can see that reflected in the myriad of programming that is involved within this one portfolio. We have everything from online and virtual meetings, peer support, but we also get out on the land. So we're honoring what they told us. They wanted to honor the fact that they have their own self-care needs. They want to accept themselves. Just because they smoke doesn't mean they're less than. So we wanted to honor that within our programming. They wanted to feel content with their life and at peace with themselves. So they wanted that incorporation of all the domains of wellness that they identified as being normal as important for them, things that included that physical, mental, emotional, and spiritual sides. And they wanted to be able to access it across the province. And that is a barrier, I think, that a lot of our programming departments, when you have a province-wide health department, but you're under-resourced. So access to that, geographically available supports and services that are culturally safe. Safe space is critical, is something we hear all of the time. And looking at how do we do that? We integrated that into our programming. I'm going to do two things at once here. One of the things we truly realized early on is that for our program to be successful, we needed to ensure that the capacity to deliver the programming was prioritized. So this meant that Kyla, our community prevention practitioner, needed to be set up for success herself. She needed to receive comprehensive training that included education, training, and support in the following areas. So the theoretical component, Kyla is a certified tobacco educator. So I'm not going to go into all of the pieces that come with that, but it is an actual certification within our country. And so we needed her to have the confidence in herself to be able to deliver the programming and adapt it in ways that are important. So I'm just going to move on and not go through every single little teeny piece, but you can come and chat with me and Ashton if you're looking to develop these in your own space. We're happy to share lessons learned with you. But we found that in our evaluation, if we would not have done that, we would not have had the same success, according to what we were hearing from community members and our own staff. We also, beyond the formal training opportunities, provided to Kyla internal cultural safety training, but we have a Métis 101. Who are we? Where are we? We know it's important to ground everything we do in our historical and contemporary context. So we do truly try to support all our staff who are running programs in connecting, not only in a module that's online, but with Métis individuals, families, communities, and our culture through gatherings such as our AGA, our own health forums. We participate and volunteer in other departments to really ensure that our staff have that fulsome understanding of who we are. So those community events are so important. So the priority focus for the evaluation of this program, kind of happened between April 2022 and February 23, was really wondering what Métis Albertans' experiences were with the program. And we learned that there are a few key points that help make the delivery and implementation of this program a success. Firstly, we have a very strong partnership with Alberta Health Services Tobacco, Vaping, and Cannabis Program. They are our cheerleaders. In fact, they have enjoyed working with us so much, they've asked us to do some of their work. And so we're working with them to help make their programming within the system also more robust. And that is also something we learned from community. Choice matters. So yes, there are going to be folks that want to come and sit with us on their tobacco journey, but there may be some that want to sit within the regular system. So we've realized that through that partnership, we're able to attack, this complex commercial tobacco space through the regular system and our own. We also have an incredible partnership with Alberta Blue Cross, who supports our NRT programming. To be honest, they pretty much sit down and try to innovate with us and are curious about what our community needs on a regular basis. So if you have not reached out to your sister Blue Cross, we certainly have had a wonderful experience, and I'm happy to talk about them. And I bring this up because I know we always are going to government for support, but there are some some really truly great spaces outside of government that we can utilize to boost our programming, and we learned that through our evaluation. Our program utilizes an approach that does center Métis values and kind of Western tobacco cessation programming. And so we're very, happy to see that that has been well received within our community. Our program tries to be holistic. I believe it is as holistic as we can make it in this moment with the funds that we have, looking at the physical, emotional, and psychological realms of care. And our program truly is, a strength-based program where we celebrate successes, even when we have setbacks. We know that on a tobacco cessation journey, those sometimes happen. But honestly, we're looking for success, we're looking for solutions, and it's really grounded in Métis visiting. So it's an important kind of moment for those community members to come together and know that they're supported. We have incredible support staff, and we need to make sure that they have that healthy balance of theoretical knowledge, program implementation knowledge, but also that community connection. And without that, I think the program wouldn't have been successful. Kyla is part of this program as much as any words on paper. It's because of her that this program lives and breathes, and it's because she has the same values and goes out into community and meets us where we're at and has conversations and has become very, very close to a lot of the folks, obviously within healthy boundaries for delivering programs and services. We have sustained funding, period. That makes a difference. We can dream within this program. We can iteratively make changes because we have the ability to do so. And that is not the same. You've seen so many programs and heard at the end, our funding is sunsetting. It's really hard to grow a program when you don't know that next year it's going to be there. How do you invest that capacity when you're not sure if you're going to even be able to support Kyla the next year? We don't have that. We can invest in Kyla because we know next year Kyla will be there to continue investing in our community. It's fantastic. So evaluation and revisions that we do make, and I think we do iteratively evaluate this program, are really still grounded in community voice. We're always listening to our peer support leaders. We're always listening to our program participants. Every program or every participant has an opportunity to complete an evaluation with Kyla or our evaluators or just an email. And for folks that work in Métis communities, they're pretty good at telling us when they don't like something. So we just try to respond to it. So it's been really, really great. So all of the revisions and the expansion of this program have all come from the suggestions of program participants. So I'm going to ask our friends to just quickly share a video. Instead of me reading our community's words, we have a short video, if it works.
I think that I learned again that, other people, everybody was kind of struggling. It was, it could be a struggle, but listening to people's, experiences, other people's experiences, realizing that people are going through the same thing that you are, listening to their successes and things like that, I found to be helpful and to be a good experience.
Well, I found two things very useful. It was the getting together with the group and having the support of each other and providing the support. But it was also the $500 allowance to purchase nicotine replacement aids.
I didn't really have a lot of hope in it. I thought it would be a good place to get a little bit of support and, but that was about it.
Before I even attended session 1, I wasn't sure it was going to be for me because I need more determined people behind me, per se. I need someone with that whip to crack it every once in a while.
I didn't really think too much about it. I'd heard of it, but I wasn't gonna go and seek it out.
Honestly, try it. You don't have to quit right now. Try it. Do the whole 6 weeks. It's worth it. It's 110% worth it.
Oh, I would definitely say try it out, check it out. you'll like it. It's helpful.
So I would encourage them to do so. I would say that I found it very helpful. I think that, the program in itself is excellent. I feel that, the funding and the time and everything that's offered to people at no expense to themselves is wonderful. And I think that they should definitely try it.
QuickCore helped me, and I have not smoked a cigarette in 442 days, which is 1 year and 2.5 months.
It's a long journey, but with the support and the tools that QuickCore has provided for me, it is possible.
Just a short one, guys. Those are some of our peer support leaders as well. So they're an incredible, incredible team. So I just do have a message from Kyla, and I know it might be small, so I'm going to read it. She says, supporting Métis Albertans with their commercial tobacco-related health goals has been an incredible experience over the last few years. From meeting citizens online through Zoom to being out on the land at Métis Crossing, no matter the way in which we connect, it is always meaningful. The M&A Tobacco Reduction Program allows Métis Albertans to work on their health goals at their own pace in a safe environment with no judgment. The vulnerable conversations shared and the varying lived experiences among program participants create a foundation for people to feel connected and supported, spiritually and emotionally. Witnessing citizens achieve and exceed higher than they could ever have imagined is very inspiring and rewarding. Métis culture and community are two of the biggest pillars of support that make our program holistic, community-driven, and Métis-specific. It is a privilege and an honor to work and learn from Métis Albertans. So you can see what an incredible human being our Kyla is, who delivers this program. She gets just as much out of it as our community does. Thank you, Kyla. And I think I'll just leave you with a couple things moving forward as I try to get my speaking notes back up. Yep, I'll get Ashton to do that. So I just want to leave you with a few next steps because, we do have sustained funding. So what are we doing next? So we are going to update the materials that we have to try to reach some new audiences. So as most of our participants actually have been women. So we want to have an increased focus on youth, including adding more information on vaping to the M&A QuickCore curriculum. We want to support AHS to include some more Métis perspectives in their own QuickCore materials. We want to focus on the men of our nation, who we know also do smoke. So we're trying to have conversations to figure out how we can engage them in a way that's meaningful for them. And we're looking to create a self-guided online version of our M&A QuickCore. So for folks who just don't have, the extroverted personality to attend a group session, they can do it online within their own spaces. And I think that's where we'll leave you. Marcy? You done?
Only like 5 minutes, I think.
Are we good, or do we have questions?
Do you want to do questions?
If anybody has questions.
If anybody has questions, our amazing presenters would love them.
Yeah, it's
I know
very
that
bright.
light's blinding.
No?
Questions? No? Okay.
Okay.
Well, thank you so much, Marcy. Thanks, everyone. Okay, so here's what is going to happen next. We are at 2:35. And so remember when I was really kind of spouting off this morning about a ballroom party and then it hasn't happened the entire day? Well, we're going to do it now. So we have a break scheduled. And we don't want you to leave. Don't leave, okay? Stay here. The nation's awesome. So if you need to get up and move around a little bit or get a coffee or whatever, do that, but come back. Our amazing fiddler, Alicia, is gonna set up and we're gonna kind of do I don't know, we're gonna feel the energy in the room, see if we set up some chairs in and around or do a couple of different things. If that's not your if that doesn't float your canoe, then you can spend some time like connecting, socializing, visiting, networking, whatever way you like to relate with people, do that. And then we're gonna have, I think, our closing remarks probably at like 3:30ish would be my guess, and our closing prayer. The other thing, do we have an update? Yes. Okay. So if you leave, so here's another reason not to leave. So if you leave, there's a couple of disruptive things happening apparently in and around the building. Everything is okay. If anybody wants to check in, I don't know what's happening, but there's a bit of commotion apparently happening. So if you leave the building, you may not be able to get back in. So just hang around here, go for a walk, stretch your legs. I've been assured everything is okay. If anyone wants to check in or has been impacted by whatever is happening, then our team is here. Please let us know. But just get up, stretch. Alicia's going to set up, visit, and then we'll do our closing remarks and our final prayer in and around 3:15, 3:30. What? What's the matter? 3:30. All right. See you all soon. 5 to 10. Don't leave. Come back. See you soon.
All right, good afternoon, everyone. I'm glad to see that everyone's still here. Sure.
You know the devil's waltz?
I do.
You do?
I will play that tune for you. We're going to end with, as a request, we're going to end with Devil's Waltz, which goes in line with what my plan was. So this plan's all lining up here. But yeah, we're going to have a little bit of a rowdy time. I'm glad to see people are still around. And hopefully we're going to get you a little bit more engaged. We have a decent dance floor. We have... I can teach you some rhythms so that it's not just me playing for you. It's you guys learning a little bit about the rhythm, getting you into it. Does anyone know what this is? What's this instrument? Spoons! Are they the spoons that you eat your soup with? No. Okay, so these are spoons. I call them cheater spoons because they're attached together. You can actually go to the back of the room and get 2 teaspoons or 2 soup spoons, put them back to back, and make your own music. Sure.
So we would love everyone to actually get up and come on over here. So if you want to participate, because Alicia, remember the hootin' and the hollerin', and this was the whole point of like today. So let's kind of drag some chairs over, hang out. We're going to give you a real experience of a Métis party-ish, as best we can with no fiddler. No, we got a fiddler. She disappeared on me for a while. I found her. She went west and I wasn't sure if she was going to come back. But we have no jigger, but that's okay because we're going to get ready and warmed up for tomorrow when Brad is here. So please, pull a chair, come sit. This is going to be a fun moment. We love participation and friends of the nation. So, Spicy M&O representing. We have to have at least one member of each governing member in the circle, I feel like. Okay. Becca's representing. We have an M&A. We have M&O. Where's M&S? These folks have been ragging on me today, M&S peoples. All right, here we go. Listen, I should get a job as a caller at one of the back to Batoche, hey? Get up here, everybody, right now. Let's go. This is what we're going to do. This is what's happening right now. There's Sophie. Good? Okay. Any government people want to learn how to be like in the community with the music, rowdy? This is actually how we roll. Partnerships, we love it. We're getting fuller. Here we go. 2 more seats left. All right. We're full. Yeah. You want some light? Could we raise ever so slightly because people may feel vulnerable in the circle, but a little bit of light because the photographer would love to grab some photos, I'm sure. Yes. All right, last call, y'all, for a good seat at our party here. Breakdancing. This is a different cultural infusion, eh? That would be great. Breakdance fiddle. Break it fiddle. Break down the fiddle. I don't know what I'm saying anymore. Okay. Good? Should we get some spoons? Breakdance fiddle. Why the hell not? Do you want to end here? Do you want us to bring it down so you can still talk into it?
Yeah.
Like lower it?
I mean, it doesn't matter.
So you can sit?
Oh, yeah.
Yeah.
All right.
Good?
All right. We're all good.
We're good.
We're all
It's
good.
under control.
It's under
We're doing
control.
this.
We got this.
You want to lower more?
No, it's fine. Okay. I love this. I love this.
Yeah, you do.
This is awesome. Little circle. So I'll introduce myself. My name's Alicia. I'm a Métis fiddle player, also a Métis Nation of Ontario citizen. Strong ancestral and familial ties to the Red River area. Lots of my family, after the hanging of Blue Whale, I don't know, whatever term that is. My family moved north to St. Rose du Lac, Manitoba, and had lots of family who played the fiddle. My great-grandfather was a fiddle player. His father was a fiddle player. And it skipped a couple generations in the middle there, but happy to be reclaiming that in my history. Yeah, hoping to pass down some knowledge in the meantime. Are you guys ready to go? Awesome. All right, well, let's warm up. Don't want you to sprain any wrists or ligaments. So we're gonna warm up into this. Yeah, perfect. We need a spoon player. Tara, you kill me. We're going sideways. I love it. Okay. Yeah, you gonna demonstrate it? Sweet. Okay. What's your name again? Susie. Susie from MNBC, correct? She's gonna demonstrate for us. You can look, observe for now. Don't want to break any fingers going on for WSIB. We can get some metal spoons. Yeah, you guys are already great. That was sounding awesome. And you're a lovely spoon player. It's hard to play the spoon. Yeah, the cheater spoons. Yeah, where are the spoons? So yeah, spoons, if you've never played them, it can be a little bit tricky to grab it in your hand. You want it to be tight but kind of loose at the same time. It's a little bit trial and error, and every spoon is a little bit different. So yeah, do your best with them. If you're like, my hand's cramping up, you can always ditch the spoons completely and go with the hand spoons. So I'll show you what hand spoons are. Essentially, it's like making rhythms, but with your hands. So any kind of rhythm that you feel translates this way instead. So you always, regardless if you have spoons or if you have hands, there's always whatever dominant hand you write with, or whatever your dominant hand is, usually the one that you write with, that's the one that's going to be doing most of the action. So if you have the spoons, that's the one that's going up and down. If you don't have the spoons, also the one going up and down. And then the other one just stays and hovers around your thigh. And you're either gonna backhand with your normal hand, or you're gonna use your spoons, and that's the up motion. You're awesome. You guys are all awesome. I just picked it up. Good. Oh, there's one there. We're good. She's like, no, let's not. This is awesome. I don't know what that is. Okay, so how does that feel? Good? Okay, let's, I like when we're all together, because then it's not just like, I don't know, unity, whatever. So let's practice a couple of really basic rhythms, and then we'll progress and get a little bit harder. Does that sound good? Okay, so the first thing is what we're gonna do. It's called the We Will Rock You rhythm. So what you're gonna do is you're gonna go thigh, thigh, hand, thigh, thigh, hand, thigh, thigh, hand, or down, down, up, down, down, up. Nice. Good. Can anyone hear the We Will Rock You song now? We will rock you. Yeah. All right, this is We Will Rock You. Okay, I'm gonna keep going. I don't want you to lose focus, so keep this up, and I'm gonna play a fiddle tune over top, okay? Keep going. Down, down, up. Down, up. Down, down, up. Down, down, up. Very good. So we're down. We're all warmed up. Yeah, you're not. I should have said that. You're not going hard on yourself. Like, be gentle with your body. Remember. Yeah, gentle spooning. Yes, gentle spooning. You don't need to go really hard in order to make an actual sound. And since there's so many spoon players, just your little one tiny gentle contribution will be more than enough. We'll be able to hear you because it's a collective thing. I know, right? I wasn't expecting this layers that are happening here, but they just merging in real time. It's crazy. Yeah, okay, let's go a little bit faster, a little bit more advanced. You guys did grade 1. That's awesome. You nailed that one. Let's move to the next level. Okay, so this one, I call it the horse galloping rhythm. You'll often see fiddle players do that same rhythm with their feet. It's also incorporated a lot into the jigging steps. A lot of the fancy steps incorporate this kind of rhythm in it. And same with the spoons. And so these rhythms, a lot of spoon players like how you played at the beginning. It's a lot about the feeling and knowing the tune and listening to the fiddle player and where you add extra little beats and stuff. But this way we can all come together, have some basic good roots, and then you guys can go crazy afterwards. All right? So let's do this rhythm. It's the horse galloping rhythm. So what you're gonna do is you go down, down, up, 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 down. Nice. Good. Down, up, down, down, up, down. I know, if people want to go down, down, up, just go with it. Don't think too hard. Down, up, down, down, up, down, down, up, down, down, up, down. Nice. Okay, keep it up. Keep going. You're doing great. I feel like a jazzercise instructor. Keep it up, girls. One more rep. You got it in you. Okay. I had too much tea today. Keep going. Down, up, down. Down, up, down. Down, up, down. Awesome. Okay.
Listen, come back tomorrow because there'll be more hooting and hollering.
There will be.
Celebration.
There is.
Yeah.
And we got jiggers tomorrow. This is just warming it up.
Yeah.
Warming up the space. Someone else, you taking notes? Because she's not coming tomorrow, so. Who's my spoon player tomorrow? No.
Susie Solo.
Susie Solo?
Spotlight.
We can arrange that, right?
Well, oh, I didn't mean a light.
Oh, okay.
Like a music spotlight.
Like a literal spotlight. Spoon solo. Okay, no, we're not gonna do that.
The one from the stage that goes into your eyes.
It's getting too rowdy in here. Okay. You're so funny, Tara. Okay. Let's go faster. That was like waltz speed. It was really challenging for me. It was not. We can do it. We can do it. We're gonna go like twice as fast. Maybe 3 times.
Down again?
Yeah. Yeah. And if you ever get lost, I should have said this, you can always just go back to the basic beat. Just like down, down, up, down, up. I'll like sway so you know where that is. Okay.
Wait, what's the faster one?
Okay, the faster one. Down, down, up, 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 down. Yeah, nice. Good. Keep going. Doing great. Okay. Too silly. Awesome. Very good, everyone. That was a lot of fun. Thank you to my Susie on spoons.
Don't take this spoon.
Yeah, nobody can.
Open the bucket. Maybe National Council will get a bill for
300
spoons.
Yeah, 40 persons.
Thank you, Alicia, so much. Thank you.
That was lovely. Oh, nice. Yeah. Did you decorate them?
I did.
Nice. Cute. Cute.
Like you're my helper. Sophie, can you bring me the agenda? Thank you. She's falling apart. All right. So, I just want to give a big round of applause to our fiddler there, Alicia Bloor, who led us in such a fun little circle. We lost her for a while, and then I tracked her down. I went on a voyage in the hallways, and, you know, fiddlers are always on the move. They're just serving the people everywhere they go. But we're so happy that you're here and brought all that music. Got my steps in today, so merci to you for that. And she'll be here tomorrow too. So warm-up round happened, and tomorrow's the big party. Well, celebration. So listen, what a fun day. What a great day. I want to just make a couple of closing remarks. They're going to be very brief. But I did want to acknowledge all of the speakers, extend, you know, our deepest thanks. Today was a big day. I think it was a tough day at certain moments because we're talking about things that are very real and very impactful to our people, but it reflects the reality of our lived experience. And, you know, I also want to acknowledge all of the amazing videos and stories and you know, even quotes, things like that from our citizens that have been integrated into this space, that it is not just, you know, speakers speaking, that it is speakers who are also bringing life and voice to our citizens in this space and in this forum. So it's really special to have that presence and to have that reminder. You know, we started off our day today talking about cultural safety, talking about how to, you know, cultural safety, not just as a principle, but really across a continuum of care, and how we are always mindful and how important it is that cultural safety is instilled at every step of the way. And so a huge shout out to the Métis Nation of British Columbia and HSO and that partnership that is bringing together that amazing work. You know, also that importance again of Métis specific care, and also that equitable approach to implementation. So funding is half the story, and probably part of the pie, and development is another part of the pie, and then implementation, right? And so there also needs to be support all throughout that process of gestation and imagination to acquiring funds to then implementation of those funds as well. We also heard a lot about health data and the importance of disaggregated data, taking again that distinctions-based approach to research and reporting, and doing that responsibly, doing that ethically, and really looking at what are the Métis models and Métis systems of gathering that information, that we are not using models that have been developed with other Indigenous peoples in mind, but what are our models? What are our knowledge systems that are reflective of how we engage in research and how we engage in knowledge generation? And again, you know, that beautiful relationship around building those connections, those partnerships, those collaborations. And we want people in the circle. We want partners. I mean, if any of the governing members disagree, I absolutely respect that, but I imagine many people want partners who are willing to work in good ways, who are willing to take that direction, but to also work in very responsible, relational, accountable ways with the Métis Nation and with Métis communities. And we heard, you know, a really important point around that. When funding is given, and it is short-term funding, the harm that comes from that funding being ended, those programs ending, that resources then removed from community, that is an ongoing form of colonial harm. It is a harm to fund and then take away programs and services from communities, from citizens who are accessing them, benefiting from them. And there's lots of data and research that shows that people are benefiting and healing. And we've heard such tremendous examples of work that is addressing effectively the needs of our people and our communities. And so it is, you know, that it is so important to bear that in mind, and also factor in that collaborative, understanding approach and that directional piece that is given. We heard some other amazing examples from our different governing members of other programs, again, that have been developed and innovative in culturally grounded, culturally based ways. And the importance, again, of that partnership, that the Métis Nation is very ready. The Métis Nation is ready, wanting, and willing to move forward. And that this is the time, this is the window of time to address long unrecognized, long underserviced, long problematic disparities that Métis people have experienced. And so, with our leadership who is moving forward, our rights-based agendas and our rights-based vision, that our health is an integral part of that. Health is a foundational component to that. And that intersection between self-governance and self-determination as an Indigenous people, it is inherently linked with health and well-being. So I just wanted to offer those kind of comments and remarks in closing. Again, extend my thanks to all of the presenters today. And with that, let me just see if I'm supposed to say anything else about tomorrow before we invite Elder Vida to come up and close our session. A thank you again to our sponsors, the Canadian Medical Association and the Canadian Agency for Drugs and Technologies in Health for sponsoring our sessions today. A reminder to complete evaluations and that tomorrow the registration for the recognition of advancements in Métis Health, the appreciation brunch hosted by Healthcare Excellence Canada. Registration opens tomorrow at 8:30 a.m. and at 9 a.m. we're going to have performances as well. So it was a great day, great second day and an amazing third day. I'm looking forward to it. Big round of applause for everyone. And with that, I'll invite Elder Vida to come up and bring day 2 to a close for us.
Thank you. I'm amazed at how much capacity building has been done in just a few short years, and what an amazing amount of results have happened from programs despite very uncertain funding in many cases. So I feel very honored to have been here and to find out about the progress that's being made. So thank you to everyone for the good work you're doing. Close the meeting with a short prayer. We thank you, Creator, for this day, for the good ideas, the good discussion, and the sharing that has taken place. We pray for healthy people and healthy communities. We pray that you be with those who are suffering this day, people in physical, spiritual, or emotional pain, people suffering from mental illness, people living with anxiety and fear for the well-being of those they care for. Please keep us strong in spirit as we work together to solve problems and make positive change through our many programs and through our work in community. Please keep us safe, secure, and in good health. Miigwech for all that you have given us. Marcy.
Marcy. Thank you, Vida. Marcy, everyone. Thank you, Elder, for that closing. And we wish everyone a wonderful night. And we will see you in the morning. Have a good night.